are done by series of small things brought together. A very good morning to one and all gathered here. This is me, Panchami B. Suvarna. Welcome you all to the Department of Anaesthesia and Operation Theatre Technology of Mangala College of Allied Health Sciences in association with KAHPA organizes AHSCON 2K24. Anesthesia plays a crucial role in the operation theatre, inducing a controlled state of unconsciousness, ensuring pain relief and enabling surgeons to work with precision. Meanwhile, advanced operation theatre technology integrates cutting-edge equipments and systems, creating a harmonious environment for integrated medical procedures. Together, they form the backbone of modern surgical interventions, promoting safety and efficiency in healthcare. Before we begin our program, let's evoke God's blessing through prayer song.
जनहृदय हरणशीला इह पुष्पितार्ति दिव्या सुरभारती सुरम्या सुरभारती सुरम्या सुरभारती सुरम्या सुरभारती सुरम्या सुरभारती सुरम्या सुरभारती
We are about to commence our event by lighting the lamp of knowledge and wisdom. This is a symbolic movement that signifies the dispelling of darkness and igniting of thought and enlightenment. Now I request the dignitaries to do the honors.
Kalyanam Arogyam Dhanasampadah Shatrubuddhi Vinashaya Deepajyotir Namostute Deepajyotir Namostute Deepajyotir Parabrahma Deepajyotir Janardanaha Deepajyotir Parabrahma Deepajyotir Janardanaha Deepo Hartu Me Papam Sandhya Deepa Namostute O Deepa Brahma Rupastham Jyotisham Prabhuravyayah O Deepa Brahma Rupastham Jyotisham Prabhuravyayah Arogyam Dehi Putrasya.
Thank you all. A warm welcome is the universal language of kindness. Firstly, I heartily welcome our Chairman, Dr. Ganapati P. Sir, and Vice Chairman, Dr. Anita G. Bhatt Ma'am. I would love to welcome our speaker, Mr. G. Prasad, Area Sales Manager. A warm welcome to you, sir. A warm welcome to our dear Principal, Professor Pratijna Suhasini Ma'am, Vice Principal, Professor Geeta Lakshmi Ma'am. A warm welcome to Dr. Shailini Rao Ma'am, Medical Advisor. A warm welcome to you, Ma'am. I would love to welcome Padma Shri Ma'am, HOD of A and OTT Department. A cordial welcome to Administrative Officer Dr. Dharmaraj K. Sir, Manager Ramesh Nayak Sir, and PRO Vijay Sir. It's my pleasure to welcome all the teaching and non-teaching staffs, and finally, a warm welcome to all the students gathered here. As we will be beginning with our session, I request all the dignitaries to occupy the front seats to fill the feedback form after each session. I repeat, all are requested to fill the feedback form after each session. Without making much delay, let us begin with the first session of AHSCON 2K24, that is intravenous line care management and hands-on training of IV cannulation by Mr. G. Prasad, Area Sales Manager. Mr. G. Prasad, he is an experienced professional with 11 years in hospital sales and medical devices, currently servicing as an area sales manager. He is specialized in hospital infection and control and prevention, collaborating with clinicians to deliver effective solutions. His responsibilities extend to managing channel partners and distributors for product distribution. He is known for fostering strong customer relations and achieving impressive sales record. He is excelled in clinical and solution selling. He thrived on building interpersonal relationships and active seek opportunities for self-improvement, consistently placing himself in challenging situations to enhance his capabilities. Let us now turn our attention to Mr. G. Prasad. Over to you, sir.
Good morning. As you are just gathered here to enhance your skills, so let us discuss about few of the best practices, what IV therapy is required, infusion therapy is required. And let us discuss this in not in monotonous way, in an interactive way. So this one hour, the next 1 hour, we will discuss about the basics of IV therapy, line care management. Also, we will try to do the hands-on session with each and every one. This is the overview of infusion therapy process. You can see. This is the overview of infusion therapy, which you come across in your daily day-to-day practice. So what is competency required for IV therapy? Do you think everybody can do the infusion? Only the certified nurses, the clinical practitioners can do the IV therapy, right? Why it is required? Because the public, the patients, they can trust you, right? If the common person can do the IV cannulation, then what is the point in that? Is it possible to do? No, right? The minimum skills is required, right? The certified registered nurses infusion is the body who is having the skills and the right to do the IV cannulation. So infusion therapy education is basic in your college also. Now I hope everybody is now you are getting your theoretical knowledge and gathering some practical knowledge also in infusion therapy. And when you go for job and when you join a hospital, then on job training also you will be getting. Also manufacturing representatives like us, we are having the ability to influence the best practices of IV cannulation. Like what are the technologies available in the devices, what is the best practice, what are the guidelines suggest to use. We are having the ability to influence the best practices. So why infusion therapy is required? Anybody can answer? Answer is you can see the answers. Why infusion therapy? Just I don't want this to be a monotonous. Let us interact, let us discuss so that it will be interesting. Because rapid onset of action, direct route to bloodstream. Do you think 90% of the patients who get admitted in the hospital requires IV therapy? Do you agree with me? Yes, right, thanks. Like the patients who are sick, maybe the person who is not able to take medicine through his gastrointestinal tract, absorption is not proper. For them it is required, right? And better control over the drugs administration. So IV therapy is very much required, right? What is the desirable outcomes of IV therapy? Can anybody answer? Do you think if a patient requires multiple pricks, what he will think? With one prick, with one IV cannulation, you can give multiple medication, right? That is also one of the major goal, right? And also ultimate goal is patient satisfaction. Can you see this model? This looks like a fishbone model. This involves like from consideration of devices, preparation of the devices, infusion, to administration and disposal. It involves multiple steps. Multiple steps are there, right? Collectively it is showed in this fishbone model. So purpose of the therapy consideration. While considering a therapy, what and all we consider? Duration of the therapy. We will consider about duration of the therapy, route, types of solution to be administered, and flow rates. What are the chemical properties of the solutions we consider before giving infusion? Which are isotonic, hypotonic solution, hypertonic solution. Normal pH is 7.35 to 7.45. Ideal infusate is in the range of pH 6 to 8. There are irritant drugs and vesicant drugs. Irritants means which cause destructive effects on venous endothelium. Vesicants means again it causes destructive effect on endothelium and risk of tissue necrosis is high. Just normal pH of the serum is 7.35 to 7.45 and extremes of pH irritates the vessel. Higher the osmolality increases the phlebitis risk. So while considering any infusion, lowest risk is 450 milliosmol per liter, having the lowest risk of phlebitis. So in this diagram it is showed that 18 gauge catheter which is inserted in different veins, how it looks. If it is inserted in cephalic veins, it looks like this. If it is inserted in basilic vein, looks like this. The axillary veins, like this. Just the standard like rules or formula for insertion of considering vein and catheter ratio is 2:1. The 2 should be vein, 1 should be cannula. And methods of fluid delivery, there is 2 methods. One is continuous infusion and intermittent infusion. Continuous infusion, I hope everybody knows about continuous and intermittent infusion. Continuous infusion requires a consistent rate over a specified time, and intermittent infusion may be given at a specified time, not continuously. Why? What are the different therapies used in IV cannulation? Hydration, anti-infectives, chemotherapy drugs, total parenteral nutrition, and pain management. Also blood and blood products, blood transfusion. All these are used in IV therapy. So now we will discuss about the patient considerations. What are the different patients we come across for IV therapy? First, these are the challenging set of groups, geriatric patients. Why it is challenging? I hope you know basics about this and you all can understand this, why geriatric patients are a challenge. Because skin is a challenge. Skin, like rolling veins, there are loss of subcutaneous and muscle tissue, thinner skin, vein wall aging. easily forms hematomas. What is hematoma? You know, right? Medication absorption is an issue in this set of patients. Cognitive ability is also poor. If we try to explain them, they may not be able to understand. These are the challenges we come across in geriatric patients. In newborn neonate patients, fluid overload is the highest risk. Smaller vascular space, immature kidneys. Phlebitis is uncommon. Infections are also not that much. But fragile veins, tunica intima is fragile. Umbilical insertion is common in this type of patients. In pediatric patients, they are little chubby, right? So, increased subcutaneous tissue, difficult access, anatomical sticks, difficult to recognize infiltration. If we cannot confirm that whether the cannula is in the vein or not. And mobility is the highest risk because explaining them they cannot understand. And parents are also at panic stage. So cannulation in pediatric group of patients is challenge. Lower extremities used for insertion sites if immobile. I think you might have seen in pediatric patients veins in the legs are also used for cannulation. IV pumps are very common for infusion. And these are the medications which affect vein skin integrity. Corticosteroids, which form vein wall fragility. Heparin can cause hematoma. Chemotherapy drugs can cause irritants and vesicants. Again, the chemotherapy drugs, if vesicants, this can be caused, this can be formed. This is extravasation, where the tissue damage is there. While the first step before a cannulation is site consideration, that is skin assessment. Function of the skin is barrier to the outside body. It's a defense against microorganisms, fights against infection, maintenance of fluid status and heat retention. The vascular system is an open system or closed system? It's a closed system, right? So the first intravenous thing, the administration which will be done in the hospital is IV cannulation. So the vascular system is responsible for delivery of oxygen and nutrients, delivery of hormones, removal of CO2, and delivery of white cells to areas of injury. In vascular system, you come across arteries and veins. Arteries carry oxygenated blood from heart to other tissue, whereas veins carry deoxygenated blood. Which in artery the pressure is high or in veins? In arteries pressure is high, right? There is arterial cannula available and venous catheters is available. Valves are present in veins, not in arteries. What are valves? We will discuss. These are the layers of the skin, vein. Tunica intima, tunica media and tunica adventitia. Tunica intima is the innermost layer. The characteristics of tunica intima is it's the innermost layer, smooth elastic endothelial lining which is very sensitive. The cannula which we will be inserting, it lies in this intima, this layer, innermost layer. You can see this, right? These are valves. This is tunica media, middle layer, which is consists of muscle and elastic tissue. Comprises the bulk of the vein. Nerve fibers are present in this, so the pain can be felt in this. Tunica adventitia is the outermost layer, consists of connective tissue and nutrient vessels, provide support and protection. While doing a cannulation, we all can feel one pop sound just while entering that vein. That sound can be felt in this area while pricking this tunica adventitia. We will try to do that in hands-on. You may not feel that like in real hands you feel that pop sound. In the dummy arm you may not be able to feel that pop sound, but you will try to learn the techniques and you can feel the IV cannulation process. These are valves. Valves are majorly helping to pump blood to the heart actually. Upward, formed by tunica intima, it's a maintain upward flow. You just think from heart, oxygenated blood is pumped towards all parts of the body. From all parts of the body, the deoxygenated blood should reach back to heart, right? How from legs it will come? The valves are present, so they help to pump blood or move blood upward. These valves may prevent the catheter insertion because these are like this. It will form a it will prevent catheter advancement, or while removing also it prevent withdrawal of the cannula. Usually in hands near the joint areas where you can feel valves. Which vein do you choose? According to the therapy, you choose veins. How to identify different veins? Any method is there? Just if you stretch your hand like this, the veins which start from this direction is called cephalic veins. And the veins which starts from this direction is called basilic veins. The veins in this area is metacarpal, and here median cubital, antecubital. These veins are usually used for blood collection. And the most nursing staff most favorite veins are metacarpal, right? So before choosing a vein, how we will choose? The veins which are soft, straight, elastic, which can be easily palpable, we choose that type of veins, right? See, here you can see the straight, elastic veins. This type of veins choose for you choose for cannulation, not a sclerotic or a bumpy vein. Which one is right according to you? First one or second one? Raise your hand who say first one is right. Second one? Most of you go for second one, right? Earlier I said, right, 2:1 ratio. This is a cannula, this is a vein. It's almost in 2:1. This one is correct. These are the flexion areas. If you do cannulation in the flexion area, it will happen like this. We should always avoid flexion area for cannulation. You can see different veins in hand: cephalic, basilic, antecubital veins. And there are veins in the scalp like frontal, temporal, posterior auricular and occipital. There are also veins in the foot: dorsal venous arch and saphenous. There are multiple devices available for cannulation. That is there are central venous catheter and peripherally inserted IV catheters. You can see there are different types of catheters, devices which is available. So majorly, what is the difference between peripheral axis and central axis? In peripheral axis, tip of the catheter terminates outside the superior vena cava. Whereas in central axis, tip of the catheter terminates within the superior vena cava. That means near heart. The peripheral lines are inserted in the hands. The appropriate size of the vein and appropriate size of the catheter helps for faster flow rate. These are different types of peripheral catheters. This is a straight catheter which does not have any wings, and this is a catheter with wings and also having attached closed system extensions. The CDC suggests up to 72 hours, 72 to 96 hours you need to change the cannula. According to INS, there is no need to change the cannula. Only whenever clinically indicated, you need to change the cannula. So short peripheral catheter advantages are easily inserted, economical. It's not that much complicated, minimal training is required. Disadvantage is easily dislodged and frequent monitoring is required. These are the different gauges of the cannula: 16 to 18 gauge, 20, 22, 24, also 26 gauge cannula catheter is available, used for different purpose. 16 to 18 gauge is used for rapid infusion in emergency and surgery case. 20 gauge routinely used infusions, and 22 gauge for general infusion, elderly and children. 24 for children. Why central lines are required? Certain therapies are having high osmolarity or high pH, which can damage the vessel wall if administered in peripheral veins. So central veins are required. Therapies that are required for long term required central lines. Site preparation is essential. How to do the site cleaning for IV cannulation? Anybody know? Anybody can answer? Center to periphery in circular motion, right? So how infections are transmitted? How to avoid infections? We will try to. Aseptic, what is aseptic technique? Like hand hygiene, site disinfection, medication administration, IV access using needleless connector, that is needle-free connector, Q sites, which forms a self-sealable closed system, and aseptic non-touch technique, sterile parts, interface with sterile parts, male lure to female lure. These are the aseptic techniques which we should use to cut down the infection. So areas of potential contamination, like these are the catheter insertion sites. If a poor site cleaning is there, then infection caused from this, like catheter hubs where the potential infection chances are there. So there are multiple touch points in from IV bag to a cannulation, right? So in these areas are having highest risk of contaminations. So whenever using an extension also, before using the extension, we need to scrub the hub to stop infection. What are infection prevention measures? Hand hygiene. I hope everybody know about 5 movements of hand wash. Wearing gloves and PPE whenever required. Skin preparation prior to access and maintenance. Sufficient preparation area and sufficient duration for site preparation, and we should thoroughly allow it for air dry. Clean access sites prior to each entry. Frequent observation of the site. Evaluate continued need for access. Use single-use items. Whenever it is like you are using any devices, use single-use items. So now we will try to observe how to insert the cannula. Which one is correct according to you? First one or second one? This is correct or this is correct? This is related to angle of insertion of IV cannula. First or second? Correct. First one is correct, right? So tourniquets are used while doing cannulation, right? Why? To identify veins. Just not more than 2 minutes we should tie a tourniquet. Immediately after cannulation we should remove. Can you see in this how they have stabilized the vein by pulling it back? This is vein stabilization and skin traction. See, in this you can see the angle of insertion is almost 15 to 30 degree angle. You can see the veins, side cleaning is done, and at 15 to 30 degree angle the insertion is see almost 15 to 30 degree angle, then lower the angle almost parallel to skin and advance. This is the technique. You should not continue at the same angle, 15 to 30 degree angle. What will happen? Double puncture may happen. You can see. See, there are different techniques for catheter advancement, that is threading. One finger push technique is there, modified finger push, two-handed technique. I usually use two-handed technique for catheter advancement. You can choose anyone, like you have to practice that, then you will come to know that which one suitable for you. You can continue that technique. These are the techniques which are usually used for catheter advancements. How to put a digital pressure? This is not the right way. See, if you put digital pressure like this, this is the way we have to put digital pressure to prevent backflow of the blood. This is the extension. Cannula is here. Transparent dressing they have used, and 10 centimeter, 15 centimeter extension is used. Hand wash is proper or not? Not proper, right? Observe what is good and what is bad, okay? This is the site preparation agent they are using there. That is also something new, right? That is in abroad maybe. The cannula is also different they use. But the technique remains the same. Primary flashback. When you prick a vein,
lower
the
the
primary
angle of the
flashback
catheter
can be seen
and
here.
advance the entire catheter
Here the
needle
secondary
unit slightly.
flashback.
This ensures the catheter tip, not just the tip of the needle, is within the lumen of the vein. While maintaining traction on the skin, push the catheter off the needle and into the vein. Traction keeps the vein path straight and prevents bunching of the skin. Release the tourniquet. To prevent blood leakage, compress the vein above where the tip of the catheter resides in the vein. Some catheters incorporate technology eliminating the need for venous compression. Shield the needle and immediately place it into a Sharps collector. Connect an extension or the administration tubing as appropriate for the therapy being administered. Assess for patency by flushing or slowly beginning the infusion. Stabilize the catheter and dress the site according to your policy and procedure. The following tips can help you when encountering insertion difficulties. If you're having trouble advancing the catheter once you've obtained a blood return, lower and advance the entire catheter needle unit once you get a blood return. This assures the catheter tip is also within the lumen of the vein. Maintain traction on the skin and vessel until the catheter is completely in. Hold the needle stationary while pushing the catheter forward. Try the following if you're blowing veins. Lower and advance the entire catheter needle unit once you get a blood return. This assures the catheter tip is also within the lumen of the vein. Maintain traction on the skin and vessel until the catheter is completely in. To prevent blood from leaking out when removing the needle, release the tourniquet before shielding or removing the needle. Imagine where the tip of the catheter is beneath the skin and compress the vessel beyond this point. Review the insertion and troubleshooting steps repeatedly and ingrain them in your mind to help you be more successful when starting IVs. Start inserting IV catheters in patients with relatively good vascular access first to hone your skills before moving on to more challenging patients.
Anything new you have observed? Can you recollect? Multiple things she has done, right? She has gathered all the equipments, what needs to be done, like what are needs to be used. Site preparation she has done. She has chosen gloves while doing cannulation. She has flushed the line after insertion to assess whether it is in the line or not. She has used the extension. So many things, right? See, the extensions, if you use, you need to scrub the hub before using that extensions. Disinfection is very much important. What agents you need to use for disinfection? Alcohol swab or chlorhexidine. There are disinfection caps are also available. Majorly in India, they are not extensively used. Scrubbing the hub is the procedure which is extensively used in India for controlling the infection. Flush preparation, there are manual flush and pre-filled flush available. Manual flush, you are drawing a normal saline from a IV bottle or a specific bottle which you will be keeping it for a specific patient, whereas pre-filled syringe available, like the syringe which contains normal saline, you just need to open and flush. Ready-made, it is available. So catheter maintenance procedure, you can see this transparent dressing where the site of insertion is like visible. If any phlebitis or any complication, easily it can be visible. This is a next generation IV cannula. It is called Nexiva, which is having attached extension with dual port. So flushing and locking is very, very important to maintain the line. Like, what are catheter occlusions? Catheter occlusions are blocks which are caused because of thrombus or fibrin flap, or a precipitation may be formed. Because of that, the flow is restricted. To like assess whether the occlusion is there, or for that the flushing is required. What is catheter flushing? Catheter flushing is the periodic administration of bolus of saline or heparinized saline through a vascular access device. See, in this slide you can see when and all we need to flush. Flush is like, there is simple formula ACL of flushing. A means assess. To assess, to check function of the catheter. That means immediately after a insertion of IV cannula, to check whether the cannula is in the vein or not, we need to flush. To clear a medication, one medicine is given. The residual may be there in that cannula, right, or the extension. To clear that medication, in between two medications, you need to flush. That is clear. And lock, to lock during the time of non-use, you need to flush. That means after giving a medication, you need to flush and lock the device, so that the IV cannula stays for a longer period of time. What is the use of staying longer period of time? More indwelling time means like repeated prick will not be there. What is the objective? One patient, one prick till discharge, right? If clinically no complications are seen, then one prick can be maintained, right? Only one prick for one patient. So with proper flushing, we can maintain the line. What are the complications which we come across? Like phlebitis, infiltration, dislodgement and infections. What are the types of phlebitis? Chemical phlebitis, mechanical phlebitis and bacterial phlebitis. See, chemical phlebitis, because of the prolonged duration of infection, maybe the site cleaning agent, they have not allowed it for air dried and the insertion is done. It may also cause chemical phlebitis. Mechanical phlebitis, area of like the flexion areas are used for insertion, which may cause mechanical phlebitis. Bacterial phlebitis, again the proper site cleaning is not done. Because of that the infection has happened because of bacteria, that is causing bacterial phlebitis. There are different grades of the phlebitis. Grade 0 means there is no clinical symptoms. Grade 1, erythema with or without pain. Erythema means redness. And grade 2, pain at the access site with erythema or swelling, edema. Grade 3, a streak formation. A palpable cord is formed. This is phlebitis grade 3. And grade 4, palpable venous cord and purulent drainage. Grade 4 of phlebitis. This is infiltration. What is infiltration? Inadvertent administration of non-vesicant medication into the surrounding tissue. If you have not checked properly with flushing after insertion of cannula, if it is not in the vein, it may form infiltration. If vesicant drugs are used, like chemotherapy drugs are used, infiltration happens, then it forms a extravasation, where the tissue necrosis you can see. Surrounding tissue got damaged. Dislodgement means a catheter becomes dislodged from the vein, removed from the vein, requires a reinsertion. That is called dislodgement. It may also cause infiltration and extravasation. If it is not completely out, but if it is out of the vein, if it is in the surrounding tissue, then it may cause infiltration and extravasation. If infection happens, what we need to do? We have to discontinue, and warm packs need to be given, and treatment whenever it is necessary. For central vein, again discontinue, exchange with a new one, and culture needs to be observed. If any like CRBSI is there, then treatment needs to be given. What is CRBSI? Catheter related bloodstream infection. This is Again a bacterial phlebitis, kind of bacterial infection. When open system like three-way stopcocks are used, which is completely a open system, it may cause CRBSI. The stopcock use, poor hand washing, poor aseptic technique when assessing lines. The needleless connectors are not used and the open system like stopcocks are used. It may cause catheter related bloodstream infection. This is about the basics of IV therapy and line care management. Let us learn about the hands-on session, how to do the cannulation. This is a peripherally inserted IV catheter. You have to remove like this and hold from the wings and take out. Okay, spread the wings and remove the needle cap. Just to assess whether it is correct or not, you just need to pull and put it back. This is a safety catheter which prevents from needle stick injury. The normal catheter is also same, but that can be rotated 360 degree. This needs to be just pull and you have to put it back. Okay. This is cannula material, sterile part. You should not touch while doing insertion. This is a stillet. Here you can see the bevel needle. This is injection port. These are wings. Can you see? This is the primary flashback chamber where the flashback you can observe. Okay. So I'll just show this. When you remove the stillet, 90% when you remove, you can put it back again. So when you remove completely out, it forms like this. This is having a needle stick prevention feature which protects against needle stick injury. You all observed like how to identify veins, right? This direction is called? This direction? Basilic. These are? These veins? Antecubital, median cubital. Majorly used veins for IV cannulation is metacarpal, cephalic and basilic veins. Here we will choose a cephalic vein for cannulation. Madam, group alli karitira. Catheter. Where that safety feature is not available. Come this side. You all can see, right? Mic beka? Bedala. Mic beka, ma'am? You have to remove like this. Spread the wings. You have to hold it like this. Have you all done cannulation before? On dummy arm at least? You have done? Where? Hospital. In hospital. It was successful? See, you have to hold it like this. You can hold it like this. Thumb should be on this or else on this. Like this. Okay. Don't hold like this cannulation. Always hold like this. Okay. Now, take out the cap. Tunicate. How to do the side cleaning? Circular motion. You have to take alcohol swab from center to periphery. You have to clean it in a circular motion. Clean a proper area. Like nearby area also you clean it. and allow it for air dry. 15 to 30 degree angle. Now just technique I said, no, 15 to 30 degree angle, slightly little higher angle. You need to prick. Have you got, can you see the flashback? Flashback can be seen. Now immediately you need to lower the angle almost parallel to skin. If you continue at that same angle, what will happen? Double prick. Now you immediately needs to lower the angle almost parallel to skin and advance 2 mm further along with stillet. Don't try to pull the stillet. Can you hold here, brother? Yes. Now, see, I said, right, there are different methods. I am using two-hand method. Now what I will do, along with stillet, I have gone 2 mm. Now, just 1 mm I will pull. I will go little bit. Again I will pull little bit and you remove little bit and completely advance and you can pull. Got it? Or else how you can do? One more technique. You pricked, got the flashback, lowered the angle, along with stillet 2 mm you have gone. Just pull and completely advance. No need to worry. Then put a digital pressure here and remove the stillet, add extension. Got it? Why we need to pull little bit? If we continue at that same without pulling a needle, it will again cause double puncture. Anybody can demonstrate now? Brother, ನೀವು ಮಾಡ್ತೀರಾ? You will do? You can do. Just explain how to do the side cleaning.
Circular.
From center to periphery in circular motion. Okay. How to hold the cannula? I have showed, right? Not like that. Not like this. Just leave it. Like this. Like this you need to hold the cannula. Okay. Now, yes, at what angle? 15 to 30 degree angle. Got the flashback? Now, lower the angle. Along with stillet, you need to go 2 mm. Yes, that's it. Now, use two hands. Pull little bit. Only 1 mm. Yes, enough. Now, very good. Perfect. Now, completely remove, applying digital pressure. Got it? No need. Now, or else this, it will flow out. Remove. Good? Easily can be practiced. Now who want to do? Anyone else want to practice? See, on patients we cannot practice, right? We cannot take a chance, right? On dummy arm you can. This is... ಯಾರು ಮಾಡ್ತೀರಾ? ಮಾಡ್ತೀರಾ? You will do? Explain how to do the side cleaning. Center to periphery. Imagine if you imagine it, this is a alcohol swab. How we will do? Just put it. How we will do?
Circular.
Not like this. In circular motion, you have to do like this and remove. You should not come again. Okay. Angle, lower the angle. Along with stillet, you gone 2 mm. Now, next step. Very good. That's it. And advance. Very good, very good. Completely. See, this much. Very good. Now, remove. Got it? Remove. Very good. ಇನ್ನೊಂದು ಬ್ಯಾಚಿಗೆ ಎಕ್ಸ್ಪ್ಲೇನ್ ಮಾಡುವ ಮತ್ತೆ ಬ್ರೇಕಲ್ಲಿ ಇವರೆಲ್ಲ ಮಾಡ್ಬೋದು ಪ್ರಾಕ್ಟೀಸ್. I will provide cannula to you. You can practice in the break time. Next, fine, fine. Can you all see? See, you have to remove like this, hold the wings and take out, okay. Now, after that opening, you have to spread the, we should not do oof oof, or we should not touch that place again. Thoroughly we need to allow it for air dry. Also, we should not touch this area because this is sterile area which is going into the patient's vein. And to check the patency, what we needs to do, just rotate, put it back. Whereas with safety catheters, just pull and put it back. You cannot rotate in this type of safety catheters. This safety catheters offers needle stick injury protections. Okay. Now, I have did the site cleaning, chosen a cephalic vein for cannulation, explained everything to the patient, gathered all the necessary devices nearby. Now, at 15 to 30 degree angle, I am doing a cannulation. Can you see the flashback? Got it? This is the chamber where we will see blood return. Flashback means blood return. That confirms cannula is in vein. Immediately after this, we need to reduce the angle almost parallel to skin. Then, along with stillet, we need to go 2 mm further. Ma'am, can you hold that hand? There? Yes. Now, using two-hand technique, some people use single hand. I use two hands. You just 1 mm you just pulled. And you can completely push, or else slowly you have to pull little bit and push, little bit and completely push. This can be done. If not possible, what you can do? Prick, lower the angle, 2 mm advance along with stillet, then pull little bit and push entire catheter and remove the stillet. Immediately after removal, you need to flush to assess whether it is in the vein or not, then add extension. Clear? What are 3 steps? First, prick at 15 to 30 degree angle, then lower the angle almost parallel to skin. Along with stillet, go 2 mm further, pull little bit after that, 1 mm like that, then advance catheter fully. Can anyone demonstrate? You want to do? Or anybody volunteer, you can come and do. Take it now. How to hold? Yeah. No, how to hold? No, not like that. I have showed. Keep it here, ma'am. I will show. Again, I will show. See, you have to hold a cannula like this. Okay. These 2 fingers on these wings. And thumb should be on this cap or else on this. Okay. And one more thing I will. While you are pulling, no, don't pull from this. The cap will come into your hand. Always hold here and remove. Okay. Hold it like this. Hold it. Ah, very good. Prick at 15 to 30 degree angle. You have identified veins, right? Lower the angle. Along with stillet, go 2 mm. Yes. You pulled? Yes, yes, pulled, right. Now completely advance. And remove. No, don't remove or else back flow will come. Got it? Yes. Remove completely. How to do the site cleaning? From center to periphery. You have to clean the nearby area also. Okay. Anyone else? Come.
We start with disinfecting the area.
Yes.
Central to peripheral.
You need to clean. Okay. How to hold? Yes. Don't, non, careful, careful. If it falls, no problem. You should not prick you, that's it. See, stillets are open here. NSI should not happen.
15 to 30 angle.
Little higher angle, 15 to the... Can you see the flashback? Lower the angle then. Yes. Now, with one hand hold the wings. Yes, very good. Like that. And this hand, just pull. Only 1 millimeter. See, you should not touch here, ma'am. If you touch this, sterility will go. That is a crime. We should not do. Okay? Again you are touching. Don't touch here. Leave it. 1 minute. 1 minute. 1 minute. Leave it. Don't hold here. Hold here. Okay? Don't touch this part or this part. Hold here. Okay? Got it? With that hand hold. Very good. Don't worry, don't worry. Hold here. And little bit pull. Don't worry, don't worry. Remove. 1 minute, 1 minute. Don't panic. No problem. See, this one mistake you have done. Now, I will explain. Most of the senior also, experienced people also do that same mistake. I will explain. What is that mistake? Okay. They will prick. Okay. They will get the flashback. Then they will lower the angle. They will try to pull this. Like this they will pull and they will try to push. They will pull, they will push. See, can you see here? Stillet came outside the skin. Why stillet is given? Because to give the cannula the strength to advance, right? If it like this, can you push this? It will go? It will not go. If you do couple of times, it will become like this. And what they will say? Cannula is not good. Cannula is not proper. Catheter is damaged. But actually the technique is not proper. Okay. I'll take out a new one. Here is this then, no? Ma'am, you have done the same thing. No problem. Prick. Lower the angle. Go 2 millimeter further. Ma'am, can you hold? Then, see, with this hand, you hold. And with this, just pull. And by using 2 hands, push. Got it? You will do now. Little higher angle. Lower the angle. 2 millimeter. Yes. Now, very good. Completely push. No problem, no problem. It is not in the vein, maybe. Yes, yes. You observe the technique? Gottaitalla nimge? Technique gottaitalla? Remove. Very good. Okay. Anybody want? Come. Now with other group we will do after this, and in the break time you all can practice. Okay. I will keep one more arm also. 1 minute, ma'am. 1 minute. I have not seen. You do it here, here. Take little higher angle. Very good. Now lower the angle. Go 2 millimeter further along with stillet. Don't make urgent to pull the needle. Very good. Enough. Now, yes, that's it. See, again, you are also doing the same mistake. Come, again, this putting back you should not do. Kannada vartada nimge? No. Hindi? Malayalam. Completely you have to. Okay. See, while doing this, cannula got damaged. One minute. You got it right? Ma'am, we'll do it for one more group, last group. Time ಆಯ್ತಲ್ಲ ma'am?
10 minutes.
Everybody is in? All of you can see now? How to open this cannula? You know, right? See, it will be like this. From this you need to open. Okay, like this. You have to peel. Then this wrapper also peel and hold the wings and take out. Okay. Because if you hold it from here and all, there may be a chance of only the stillet will come out, not entire catheter will come into your hand. So always hold the catheter and take out. Now spread the wings. Okay, hold it. You should hold like this. Okay, these two fingers should be here and thumb should be on the cap or else on this. Can you see? Now take the needle cap, stillet cap. Ma'am, these are sharps. Okay, we have to be careful. Huh? Next, I will give you a chance to practice. Now, how to do the site cleaning? From center to periphery, we needs to clean in circular motion, right? Now I have chosen which vein it is. Cephalic. Okay. See, at 15 to 30 degree angle, I am pricking. Can you see the primary flashback in this chamber? Blood return, can you see? Now, immediately after this process, we need to lower the angle almost parallel to skin. And along with stillet, 2 millimeter you should advance. Ma'am, can you hold that hand? Can you hold it? Yes, yes, just hold. Now, this step is important. Hold with this hand and with this hand just pull 1 millimeter. And by holding both the wings, advance completely and take out the stillet and put digital pressure here. Afterwards, you need to attach needle free connectors or extensions. Got it? Should I demonstrate once again? Now, at 15 to 30 degree angle, you are pricking. Okay. Now, after this primary flashback, you are reducing the angle almost parallel to skin. It is like this, right? Now, almost parallel to skin. Along with stillet, you are going 2 millimeter further. Now hold the hand. Now, with one hand holding these wings, with this hand I am just pulling and pushing this. You can either completely push or else pull little bit, go further, pull little bit, go further. Both way you can do. Now put a digital pressure, remove this and flush, do a flushing, check if any bulging happens. If no bulging, that means it is properly in the vein. Add extension and add dressing. Do the other procedure. Got it? Who wants to do now? You want to do? I'll come that side. Just a minute. How to do the site cleaning? You have to explain.
alcohol.
Swab?
With the swab, we have to start it with the circular motion from
Central
central
to?
to peripheral.
Okay. How to hold?
We can hold like this.
Not like this. Completely on. Ah, very good.
This
You should
otherwise-
not touch this part. Okay? Ma. Ah. At which angle? Little
At 50.
15 to 30 degree. Prick. Yes. Good. Now reduce. Go 2 millimeter further. Yes, now you have gone. No, no, not now. With this hand, hold the wings.
Okay.
Don't worry, don't panic. Not like this, ma'am. Ah, very good. You should, just, that's it.
Then fully.
Very good. Very good. Got it? Always with patient, you should not panic. You should be confident. Or in the beginning, you have to take seniors, you have to observe. Then gain confidence and do it. They will be observing, right? If our hands are shivering, if we are sweating, if we are not confident, patient will observe, right? Now who wants to do? You want? Okay, ma'am. Come.
First, by this,
1 minute. Yes, ma'am. You take that. That is proper. Oh, it is gone, huh? Give here. Take this one. Okay, just a minute.
first by the swab, we have to clean the circular way from
Yes.
the center to the peripheral, and we have to hold the cannula.
Very good.
And we have to insert by the 15 to 30 degree
Angle. Very good.
We have to see the vein.
Little higher angle. Yes. Yes, very good. Now lower the angle. And go 2 millimeter further. Again, yes. Yes, that's it. Now, very good. Yes.
Then we have to check.
Just pull. Just pull. Yes. Now, with, yes. Good. Got it? Remove. Very good. Anybody? Ma'am, time is up. ಇನ್ನೊಬ್ರಿಗೆ ಪ್ರಾಕ್ಟೀಸ್ ಮಾಡಿಸ್ಬೇಕಾ ಅಥವಾ ಟೈಮ್ ಆಯ್ತಾ ಮ್ಯಾಮ್ ನೆಕ್ಸ್ಟ್ ಸೆಷನ್ ಎಸ್
Thank you, sir, for your exceptional presentation at the event. Your insights and expertise made a significant impact. I request Dr. Shalini Rao, ma'am, to hand over the token of gratitude. Now with us, Sahiruddin S.K. sir, ABM South Karnataka, Wound Closure, and Mr. Nandish sir. I extend a warm welcome to you. Now, we Science of Tissue Management by Sahiruddin S.K. sir. Currently, he is working in the AHSCON Johnson & Johnson Company as a ABM South Karnataka in the division of Wound Closure, Bangalore. He has worked in Merrill Endosurgery Private Limited, New Life Global Medical Devices Private Limited, Rupashri Healthcare Private Limited, Birla Sun Life Insurance Cooperative Limited, Reliance Life Insurance Cooperative Limited. Over to you, sir.
Hello everyone and welcome to this AHSCON program. I am S.K. Sahiruddin. I work for Johnson & Johnson since 9 years and I have been in this medical device industry for almost 15 years now. And I have been doing this professional education program since almost 12 years. And congratulations everyone for selecting this profession, a very noble profession as a nursing. and we will start the wound closure program. So we will take you to the very basics of what is a wound and what are the medical technologies today available to close the wound. And we will be talking about the tissue characteristic, which is very important to know the tissue characteristic, the tissue healing period, and the tissue functions of the tissue in relation to the wound closure devices, which is available in the market today. We will touch little about the surgical site infection and also the hemostatic cascade of the biosurgeries. Okay, so we begin. So as an AHSCON, this is our credo. So every company, every organization has some sort of credo. So we have a great credo like caring for the world one person at a time. So AHSCON has been since more than 150 years in this global market, and we believe that caring for the person, like caring means training, lot of charity work, and we do lot of charity work like the cleft palate, like operation smile we be conducting. We train the surgeons so that they give a good patient outcomes. And also we train the nurses. We have an institute where it is in Mumbai and Chennai. And recently we also got a AHSCON bus. I think some of you might have seen in institutes like AJ Hospital or Manipal. So we have a full-fledged Volvo bus where you can have a hands-on training also. We introduced these two buses, one for the North India and one for the South India. So this bus will be traveling to your cities anytime soon. And we have been earlier also previously we have brought this bus to educate the medical fraternity, the PG student also. Nonetheless, that you are the nurses who have been grooming to be a nurses or OT assistant. So very important for you people to know what the surgeons do. You should know what they do, and you should know the logic between why the selection of the wound closure device, or it may be any material, maybe a suture material, or it may be any other form of wound closure device, maybe the energy device also. So you should know the relation between the wound and the technologies available in the market. Okay, coming to our credo back. So this is the credo. So there is a very big list of our credo, but the important thing is we believe our first responsibility is to the doctor, nurses, patients, and the fathers and all others who use our product and services. So AHSCON always use this credo. Globally, we are all bound by this credo. Okay. So we think about you and our customers, then comes our stakeholders, everyone. Okay. So let's begin the program. Now the question, what is a wound? So technically you people, can I walk there? Can I go there? Yeah, thank you. So standing here, I look like a sort of dictating. So we will be doing lot of hands-on coming here. Okay, so better. So what is a wound? Practically, everyone says a breakage, an accident, anything happened, that is a wound. But you are a professional, correct? You are not the common people. You are not the layman. So you are the professional. So you should know actually what is a wound. So breakdown in the protective function of the skin, a very layman term. Okay. So what happened to the body, that is what very important to you people. So what technically happens? The loss of continuity of the epithelium tissue. Epithelium is two, one is tissue and one is the cell. So both are there. So anything happens, any damage happened to the epithelium tissue, the body considered it as a wound actually. And you have a mechanism of hemostat, correct? Whenever there is a wound, the hemostat comes into the place, correct? So to, in order the hemostat to happen, the mechanism of the body to happen, the epithelium is the trigger. The epithelium should actually, has to be damaged. Or the surgeons, or it might be the surgeon taking the incisions, correct? So inside the OT, the surgeons give a wound. It is called as a clean wound. Everyone knows clean wound, okay? But the wound can be a clean contaminated. There are categories or sequence of the wounds, okay? But whatever the wound, if it is an accidental, or if it is inside their OT. The epithelium is the responsible for activating the body mechanism of hemostat. Anyone knows what is hemostat? Have you heard about hemostat? What is hem? Blood, everyone knows. So hemostat means stop. Stat means stop. So hemostat. So body has the mechanism of hemostat. So we will touch the hemostat subject after the wound closure. First we will go to the wound. We will make a wound. We will close the wound and then we will talk about hemostat. Okay. So any questions, it can be a very interactive class. You can just raise your hand, you can ask the question so that it will be a knowledgeful for everyone. We will just consider it as a hands-on. And we have brought many things for you, like you can see the sutures, the needles, everything at the end of the session. You can feel it also. Okay. Wound healing versus closure. So whenever there is a wound, the closure is important. Why the closure important? The body has an hemostat, as I said, but yet the closure is important. What sort of wound the closure is important? I think you should give some mics to them. If you have a mic, you can give them so they can center, you can answer. Yeah. So when the surgeons give the wound inside the OT, the wounds are deeper. The hemostat won't work very fast. Until the hemostat achieve the hemostat, what happens? The patient will be losing the blood. Lot of blood loss, means the patient is going to die. If it is an accidental wound, people don't die of the accident more, but they die of the wound, the draining of the blood, and they will die of the draining of their infections and the infection. A burn patient, when he shouts, the surgeons are happy. Remember this quote? When a burn patient shouts into the hospital, the surgeons are happy because he is having the sensitivity. You can still be saved. If the patient doesn't speak, the chances will be very, very grim. So this is what the surgeon says. When they take an incision inside the OT, they see that whenever the bloods are good, the surgeons are happy. If the blood is not there, where the area is taking incision, if there is no vascularity, the surgeons will not be happy. The surgeons will be happy when the area which is taking incision should be very bloody. It should be very vascular. Because if it is not vascular, the healing will not happen. The healing will come from the vascularity of the tissue. So we will be discussing more about the tissue today. So more about the fascia tissue, okay, soft tissues. Now the support is required. Now in the market, lot of closure devices are available. Steri strips are there. If the wounds are smaller, so small steri strips, you put a bandages, no? Your mommy used to put bandages earlier day. So it is sufficient. But inside the OT, the wounds are very deeper, the larger wound. Everything has to be closed. And as per Dr. Hallstead principle, for the surgeons, whatever they open, they have to close it. They have to respect the integrity of the tissue. The integrity of the body has to be respected always. So whatever the product available in the market, the suture material is considered as a gold standard among all the wound closure devices. You go across the world, the sutures are considered as the gold standard. Lot of things available in the market. Today we have our own energy company where they manufacture laparoscopy instrument. So what happened in the laparoscopy instrument, when the surgeon take the incision with the energy devices, you have seen the cautery division the surgeons use. But cautery is not the advanced. So we have the more advanced than the cautery. We have energy device, so called as an AHSCON harmonic. If you go to the bigger hospital, you see the harmonic brand. So that harmonics are the incision. They also do the incision. They also do the coagulations. They also do the dissection. So we had that kind of source of energy devices also. But for the surgeon, a cardiac surgeon, he do the anastomosis, distal anastomosis. He used the needle. He used the needle. The vascular, what the surgeon do, the cardiac surgeon, is almost this much thin only. So he has to join those tubes and he has to suture it. He has to suture the surround. So it takes a lot of skill to do the suture. And among all the suture, the wound closure, among the medical fraternity, plastic surgeons are the master of sutures. They are the masters of sutures. That is why the suture is considered as a gold standard. A plastic surgeon or a vascular surgeon, he anastomoses the tissue which is of your hair size, which is the size of your hair. He anastomoses the tissue. You know, the severed hand, the industrial accident, the severed hand, the severed finger. So the plastic and the vascular surgeon is responsible for joining those organs, and he has to anastomose the tissue which is of your hair size and also very thinner than your hair sizes. So they are the masters, and the sutures plays a very wonderful role here. Okay, we'll talk more about the suture because that is the best in the industry, and AHSCON is known for we are the world brand leader in the sutures. We manufacture sutures which is 56,000 kilometers in a year, which can rotate the earth almost 3 times. That much suture we manufacture in a year. And the needle we manufacture in a year, almost a weight of the 40 cars. So that is the very large scale industry, and we manufacture the product, the sutures, which contributes to the among all the surgical all the surgical needs. Maybe it's a vascular, maybe it's a uro, neuro, whatever. We have the range of needles, we have the range of suture. So we will take this opportunity to explain you. So I attended personally more than hundreds of surgeries with hundreds of different specialty. We learned from the surgeon. We have our AHSCON Institute where we are trained on the animals. We are trained on the laparoscopy model, endoscopy model. So whatever our experience you today. Okay. So remember this chart. If you want to note down, you can note down this chart because this is the most important wound healing parameters. So tissue dependent healing period. Now tissue dependent healing period means the tissue required a critical wound healing. So skin is also a tissue. The same way the tissue has to be, as I said, Dr. Halstead principle, every tissue has to be respected, their integrity has to be respected. This, whatever you're writing, the 5 to 7 days of the skin, the healing period, this is the critical wound healing period, not the entire healing. Entire healing will take very, very long time. It takes 2 years for the scar maturation, more than 2 years also, the collagen, the formation of the collagen. So it is a very long process. But the tissue, the critical period means where the tissue required immediate support. Whether it is an accidental case, whether it's in anastomosis case, or whether it's an incision, whatever the surgeons do inside your OT. Okay, so the critical wound healing period is for the skin is 5 to 7 days. Now 5 to 7 days for the skin. Skin is a toughest tissue. What are the other things? Anybody can tell? Any function of the skin? Sorry? Protection is there. The largest organ of the body. Okay, largest organ of the body. Protection, skin. Lot of vascularity. Lot of connectivity. Sensory organs. All the sensory organs you feel through the skins. Okay. The healing period is very less. 5 to 7 days, the critical period is over. Rest of the time, the skin will try to mature. The scar will mature, and whatever the scar will be remain, that will go in a due process of 2 years or 5 years. Okay. The critical period is what you have to give the support. Now, what are the support available? Suture material inside the OT. Usually, they use the suture material. Okay. Or if the wounds are very lesser, what they will do? They put the bandages. That is sufficient. Okay. The characteristic of the skin, it's a tough tissue. The skin is a tough tissue. And if you go to the OT, the surgeon who are closing the skin, they will be using the needle which are very sharper. They will be using called reverse cutting needle. I will show you the needle, the reverse cutting, how it is. So the needles comes with a blade-like structure. So this is the needle, so the structure here will be like a blade. So that is called the reverse cutting. So it will also penetrate the tissue, the needle, also it will cut the tissue because the skin is a tough tissue. Okay. Any other thing I missed on the skin? Anything? Perfect. Then the mucosa. Now the skin has a lot of subtissues. What are these? Submucosa. Then? Okay, which is the true skin? Among the skin? The true skin. T-R-U-E. Anyone? Everybody knows the skin. Okay, one more quiz. The skin on the surface. It is a dead or the living tissue? Sorry? Living? How many living? I am not here because of this collar. So you can raise your hand. How many say it's a living tissue? Just raise your hand. Not even one? Okay. So the skin is not actually the living tissue. The surface of the skin is keratinized skin, which is the dead tissue pushed by the dermis. The dermis recycle all the cells and it pushed to the epidermis, and from the epidermis come to the surface of the skin. The surface of the skin is made up of dead tissues. Okay. Now the skin has sublayer like mucosa and epidermis, dermis, and the last is hypodermis. Hypodermis is also the part of the skin. I will show you the skin structure, then we will discuss all the three layers. So all these are part of the skin and all are vascular tissue. All the skin, all the tissues are vascular. Now we were talking about the true skin. The true skin is the dermis. The dermis is considered as a very true skin. And when the first slide we were discussing of the epithelial tissue, that epithelial tissue is on your dermis. So that is why the dermis is ruptured or dermis is damaged, the bleeding is more, and the support is also required. Your body hemostat comes into effect. But when the wounds are very deeper, the support is required. The mechanical supports are required. So whatever the surgery surgeon do, they had to go through the skin. Any part of the body, they had to go through the skin only. Correct? So you are breaking the protective layer. Someone said the protective layer. Very good. So you have to break the protective layer, goes inside. Now the protective layer has lot of meaning. No bacteria should enter from the skin. The skin is protecting all the bacteria not to go inside the body. Okay. So very important issue. The closure is very important. And the device, now WHO said in 2016, they said whatever goes inside the body should be antibacterial, because surgical site infection is more. And when you are breaking the protective layer of the skin, you are going inside, then the infections are also, chances of infection are very high. And that is where all you come into the picture. You are from the OT, you will be the assistant to the surgeon, and it will be your responsibility to scrub, to manage the OT, all the disposables, all the sterility, the fogging, the donning, everything is the duty of the OT nurse or the scrub nurse. Okay. So we will discuss more, we will throw more lights when we come to the surgical site infection part. Okay. So we'll finish the skin. Now, what is the other layer of the skin now? Subcutaneous. What is that subcutaneous? Very common name. Any idea what is the common name of subcutaneous? What we say? Nobody? You go to the gym now to burn all the fat. Correct? So the fat is the subcutaneous layer, the fatty layer of the body. Now skin is the protective layer. Now below the skin, the fat are there. So what is the function of the fat? What is the function? Anybody? Sorry, yes. I'm unable to hear, so I have to come very closer to you. Okay. So the fat is the function of the fat is to insulate your body. It provides an insulation, fight against the cold, store your energy, all the fat deposits, so it stores the energy. Whenever it's required, fat provides the energy. And the fat has lot of connective tissue, lot of connectivity is there. The tissue look very spongy. If you attend the open surgeries, you can see the fat very clearly. When you attend the open surgeries, you can see the fat layer very clearly. The people who has a lot of deposits of fat also, you can see them having this much thick, almost an inch thick of fat. Okay, and but the surgeons are, and the fat are very sensitive tissue. It's a very sensitive tissue because you cannot displace the fat. So many a time the patients, after the surgery, the patient complained, I got a lump, means I get a dead space here, something is hole inside me. So what has happened? The hole is because the fat was displaced. Fat is a spongy-like tissue. It's a spongy-like tissue. If you try to close it, you have to close it very carefully with a proper material. So if you close it with a very braided, like a braided suture, like a vicryl, what happened? It will drag the tissue and it will create a space, dead space. So the surgeon cannot explain the patient, I did something wrong and you got a dead space. Correct? The surgeon had to be very particular. So I attended a surgery, and the next day the surgeon is calling me, Sahir, we did that surgery, that patient is complaining a lump. So ma'am, I didn't do the surgery, you did the surgery. So what has happened really? So we told him maybe there is a dead space in the fat. And that was a laparoscopic surgery, not the open surgery. Open surgery we can still explain. But laparoscopic surgery, the patient got a lump. The patient was a lady, almost 40 plus years. We did a laparoscopy hernia and the dead space was there. So when they use the instrument inside, they have to be very careful. And you will be the people who will be assisting the surgeon when they are doing laparoscopy surgery. So you have to hold the instrument very properly, not to dissect the fat here and there. Very sensitive tissue. So the patient will complain. Patient doesn't know what has happened, but they will still complain. Even if the surgeon are very, very experts, they still have some challenges dealing with the fat. But they have to close it. Remember, many surgeons don't close it, but the principle says you have to close, you have to respect the integrity of the abdominal wall or the tissue. So as I say, it has insulations are there, and the fat is a tissue which is very sensitive, I said, sensitive. So whatever material goes into the fat, closing material, should not be colored, should not be dyed agent. So the fat will leach the color from the agent, the dyed agent, whatever. Suppose you are using a suture material which is colored, which is dyed, like the normal Vicryl, the fat will start leaching the color of the tissue. And that is not very good with the fat. So most of the OT people, they use monocryl suture, which is a monofilament, like the monofilament is single filament, like a single wire. So the fat will not be disrupted and it is undyed in nature, so that the fat should not leach the color. Very important tissue, okay. So better skip the gym, okay. Now comes the peritoneum, correct. So the peritoneum, the function, anybody can help with the function of the peritoneum, anybody? What is peritoneum? What is the function at least for the peritoneum? Someone said? Sorry, ma'am. Okay, good. It protects the organ. You are partially correct, almost to the point. So peritoneum is known as the natural mesh of the body. It's a natural mesh of the body. So ma'am said it's a protection. It's a protection to the organ. Why? You have an organ inside the abdominal wall. This is the abdominal cavity. Inside, most of the organs are there in the, most important organs are also there in the abdominal cavity. And you have the body pressure. You do yoga, you do gymming, you do running, badminton, everything. So what happened? The organs are pushed into your abdominal wall. All the organs come in contact with the abdominal wall frequently. Frequently it will. And the pressure you generate is almost 155 to 158 mmHg of pressure, almost a 150 cc bike. That pressure the body generates. So that pressure inside the body will go and touch all organs go and touch the abdominal wall. It will keep on touching. It will try to hold the object also. Now this tissue is a protection layer. So two types of peritoneum are there. One is on the organ, another peritoneum is on the abdominal wall, the last tissue of the abdominal wall. So this tissue is gel-like form. It's like a gel form. It's like a liquid. The tissue is like a liquid itself. So the organ, the peritoneum on the organ, that is called the visceral peritoneum. So the visceral peritoneum is which the peritoneum is on the organ, and the peritoneum which is on the abdominal wall, that is called the parietal peritoneum. So both these peritoneum, when come together, they will not stick to each other. So remember the adhesions, adhesiolysis. So many surgeons, so we will go back 20 years back, when in our families, the lady who undergoes C-sections, the C-section, they used to complain of pain for almost a decade, 5 years, 10 years. So there was a myth that whenever the lady goes to a C-section, she will have a pain for 10 years. So what was that pain? Doctor opened the abdominal wall, they go to the uterus to deliver the baby. So they incise the uterus and take the delivery of the baby. Now the peritoneum which was there on the uterus, that was damaged. That was damaged due to the incision, correct? Now the peritoneum of the abdominal layer, that is also damaged because you are going to your incision, you are inciting all the abdominal wall and going to the peritoneum, correct? No? So both the peritoneum is damaged now, the visceral and parietal. Now what happened? Due to the body pressure, these both the peritoneum go together and join together. That is called the adhesion. Now that adhesion was the pain, was the lady was suffering for so many years. The pain you should be there. So now there are a lot of product has come to avoid the adhesion. So like in AHSCON, we have Interseed, a product which is made from the natural plant tissue. It's sort of a mesh we put inside on the uterus. After the C-section, we put that on the uterus, and until the new peritoneum is formed. The new peritoneum to form, it takes 7 to 14 days. So this mesh, the natural mesh, will take care of the adhesion. It will not allow the abdominal wall to come and attach to the uterus. So no pain, so pain-free. Also, the surgical techniques also change in last a decade or more. So earlier when we see the lady who undergo a C-section, you used to see a mark here, correct? You see a mark here. Now the marks are not visible, the scar is not visible. Any reason? Why? Ma'am, you had the answer. The incision change? The incision change, the surgeon is not taking incision of the abdominal wall now. Where they taking the incision? On the fold of the abdominal wall. So that is called financial incision. Now the incision has changed to the financial. So financial incision is not on the abdominal wall. It goes to the just above the pelvic cavity, the natural fold of the abdomen. You see the natural mark, no, the fold. So there they take the incision. So the scar is not visible. Adhesion also is been managed now. So the deliveries, the C-section deliveries become more safer and more pain-free now. Okay. So that was the function of the peritoneum. Gel-like tissue. So soft tissue, no need of very hard needles, just a round body needles will sufficient to close this tissue. Okay, so now comes the very important fascia. Any your understanding about fascia? Any meaning to the fascia? Have you heard anywhere fascia layer? Yes, you have heard. The meaning of fascia, anybody heard? The meaning. It's a layer. It's a part of the abdominal layer, very important layer. Okay. So the fascia word is not in the English. So most of your medical terminologies are not in the English. It's in Latin or either in the Greek. So fascia is known as a band in the Latin word. Band means the rubber band. You are right, the rubber band. So why the fascia is a rubber band? It's a part of the abdominal wall. And fascia is not a single tissue. It's a lot of tissue coming together and joining the linea alba, the midline, the linea alba, where the people show the six packs, no, the midline, that is called the linea alba. So all the fascia, the anterior rectus sheath start from here to here until the pelvic cavity, anterior rectus sheath. Then comes the aponeurotic, the transversus rectus sheath, internal, external. Correct? All fascia comes together and join the linea alba. Okay. Now this tissue is act as a band, the rubber band. You know hernia surgeries? Why hernia happen? Why herniation happen? Because the rubber band has lost the viscosity. The same way your rubber band, when you put for a longer time, when you open the rubber band, will lose the tension. The same way your abdominal wall will also lose the tension. So what happened? It become very viscous. And the pressure, remember the body pressure, it goes and kick the abdominal wall and try to create a hole. It create a hole on the abdominal wall. So that is the hernia happens. So now doctor has to pull out the hernia, put a mesh, close it. Okay, will not go deep into the surgery. Okay, so this tissue is so important, but the healing period, you see, it is 14 to 28 days. Skin was 5 to 7. Fat was 7 to 14. Now this is 14 to 28 days, almost a month, and that too we are talking about critical wound healing, not the complete, the critical wound healing. Okay. So the fascia is a very, very slow healing tissue. Why it is slow healing tissue? Any general idea? Commonly, just wild idea. Why it is slow healing tissue? Yes, ma'am. Yes, exactly. So it is of a poor vascularity. The vascularity to this tissue, so important tissue, yet the vascularity is very less, very poor. Why? The fascia doesn't get blood from the heart directly. It doesn't get your arteries. The blood from the artery doesn't go directly to the fascia. So the muscle of the fascia supply the blood to the muscle of the fascia. And it is a very slow healing process. And whatever surgery surgeons do in the medical colleges, open surgery, they are one or other way damaging the fascia. Once the fascia is incised, it will not heal 100% ever. It will never heal 100% ever. It will only heal 80 to 85%, and that too, it takes 2 years to 5 years, the fascia to heal. That is why today the surgeons are more going for a laparoscopy option rather than open surgery option, so that the fascias are not damaged again and again. Once the fascia is damaged, it is damaged. The damage is done. The healing is very slow. The patient can go for an incisional hernia. You heard about this incisional hernia surgery? The incisional hernia surgery happens due to the previous incision on the fascia itself. The fascia is not properly healed and the herniation is happening, and they have to again do the hernia surgery. And the hernia surgery is not one surgery. Once they do, 6 months, it may recurrence. The recurrence will happen, keep on hernia. Hernia is never a 100% secure surgery. So the importance of the fascia, very important muscle, slow healing muscle, okay, and you have to be very careful with the fascia. You cannot use anything which is very sharper on the fascia. They use round body needles on the fascia here. The closure should be very secure here, and the closure should be almost permanent. If you go to the hospitals, the surgeons will use the suture which is permanent most of the time, but the body doesn't allow anything you put permanent inside the body. The body does not allow it. There is a foreign body reaction. So you have to use a material which should give a longer support to the fascia, and also it should not stay inside the body for a permanently. So there are absorbable sutures options available nowadays. Absorbable like PDS, AHSCON suture is one of the most appropriate suture for the fascia closure, so that it gives the support for 56 to or 57 to 70 days. It gives support until the critical wound healing period happens, and it get absorbed inside the body. It get degrade inside the body in 233 days. So that is the material they use for closing the fascia. They use the permanent material when the patient is a geriatric. When the patient is geriatric, they use the permanent material because the patient is 50 years or more. So the doctor will never expect him to come back after 20 years, correct? The patient is already 50 years or plus. So doctor sees that whatever I am doing here should be permanent. The patient should not come in for any other recurrent surgery or redo surgery. So what he does is, he closes this fascia permanently. But in the same case, in the pediatric cases, if it is a pediatric cases, the doctor cannot use any permanent material on fascia because the child grows and the fascia grows with him. So you cannot just restricate the fascia there. You cannot restrict the fascia growing. So whatever the surgeon uses is absorbable on the child. If the child also goes, most of the child has the inguinal hernia. The indirect hernias are more in the newborn, the congenital diseases. So for them, the doctor will use the absorbable material which will not be permanent inside the body. Okay? So we spoke more about the fascia, but very important tissue. It's guard your organs. It guard your organs. It gives you a good, and you do all the flexing, no? You do yogas and all. What happens? The anterior rectus sheath acts as a 2 pillar, and your fascia do the glide and slide effect. The fascia will glide and slide on the anterior rectus sheath. You jump, you sit down, correct? No, you can see lot of fantastic yoga done. So all this, the fascia is helping with the anterior rectus sheath as the 2 pillar. Only the anterior rectus sheath is a vascular area. Otherwise, most of the fascia is all very poorly vascularized. Okay, very important tissue. So whenever you go to the OT, all the surgeries 80% done on the abdominal wall, and the fascia has to be, you have to respect the integrity of the fascia. Okay. So bone, we will not talk much here. 8 to 12 weeks is the bone healing, critical healing period. In case of a pediatric, the bone heal very fast. In case of a geriatric, the bone will not heal as fast as the child heals. And whatever support used to the bone has to be permanent. It cannot be temporarily. So the doctors, the orthosurgeons, they use the nuts, the bolts, the plates, correct? No, they put the rods, everything, nails inside, so that they give the permanent support to the bone. Bone is a living tissue or dead tissue? Now the answer is not the same. Living tissue, absolutely. So bone is a living tissue. It grows, it joins together. See, whenever the wound happens, the doctor cannot cure the wound. The body itself will cure the wound. The doctor has to place the wound together. That is the duty of the doctor. And a doctor has to see that the infection should not happen. Otherwise, the body take care of the wound. The cellular interactivity will happen. So that will take care of the wound closure. Okay, so doctors see that I am just joining the wound with a proper clinical standards, with the proper infection control, so that the wound will heal better, and you need not again go and open the wound. If you attend the infection cases, the person undergoes surgery and he got lot of infection, so he comes back to the hospital. The doctor will be very much, he will be very sad, because he has not done the surgery better. The wound got infected, and the infected, he has to again open the wound, go inside, do the irrigations, come back, again close. The patient has to the patient burden is he has to stay additional day in the hospital. The bills will be. So all those things, if you are doing your best, and you people are the best when you become the assistant of the surgeon. So I attended many surgeries with the very top surgeons in the country. What they said is, I do best surgery not because I am very skillful, because my people are skillful. My OT staffs are skillful. My nurses, my anesthesia team are very skillful. That is why I can able to do the best surgeries, the best laparoscopy surgeries. Okay. So you will be in future you will be going to assist the surgeons, you will be going inside the OR room, you will be going to the hospitals. So your profession as a profession, so you have to learn, and you have to keep learning. You have to keep learning. Okay, learning never stops. So surgical classification of the wound, we will not spend lot of time here. It's about the incision. So clean wound are wounds which is given inside the OT, which the surgeon gives the wound, that is the clean wound. Okay. Now what is this clean contaminated wound? Clean wound is surgeon gives the wound inside the body, that is a clean wound. The clean contaminated wound means clean wound and it's contaminated. How it is? Okay, so bowel surgeries, all the bowel surgeries, the intestines, the colon. So whenever the wound surgeons go from the skin side, it is a clean wound. When he goes to the bowel and inside the bowel, the wound becomes contaminated. So that is a clean contaminated classification. Then the wound is contaminated. The clean wound was already contaminated with the bacteria. After doing the surgery, the surgeon will do the lot of vacuums. He will be doing lot of irrigation, so that the bacteria should never remain inside. After he closes, he never know the infection will happen. He will know only after 5 days, sometimes after 2-3 months. I had a best doctor whose patient, he operated. The patient went to US. 6 months after, she got pseudomonas, a very bad pseudomonas on the hernia mesh. You see, when the implant inside the body, infection happen, it is very deadly. It will be a very deadly. If the infection happen on a normal patient, your immune will take care. The antibiotics will take care. But when the infection happening, when there is an implant inside the body, the surgeons are mad. They will become very mad, because it is very dangerous. The patient will lose the life. Why? I will talk when we talk about the surgical site infection. Dirty infected wound. The wound which was contaminated, that wound become dirty. And when the wound is dirty, means the smell is coming, gangrene will be going to form, and it's called a dirty wound. On infected wound, the wound is infected, it becomes dirty, and that wound is going to be very, very bad, very, very dirty. The infections will spread across the body. Okay, and ortho surgeons, when you are assisting the ortho surgeon, be very specific. He will be very, very strict on these principles. He will never allow more people on the OT. He will be wearing helmets, like a space suit, everything. Why? He is doing so much. He don't want his patient to go infection on the bone level. Because if the bone is infected, the bone marrow, where the blood is produced, that will also get infected. So the orthos are very, very afraid of infection. The ortho doc surgeons are very, very afraid of the surgical site infection also. Now, factor determining the healing. So there are a lot of factors which will determine the healing. It is not that the patient is very immune, looks immune, but he might be smoking, he might be drinking alcohol, so his immunity will be bad. If the patient comes with a overweight, obesity, his immunity will be very, very bad. If the patient has a nutritional status, if the people living in the villages, they will be eating daily, same cereal daily, so their immunity will be not very good as the people live in the metro areas. So his nutritional status are not very good because due to the poverty, he will not be having a good immunology. Next is the blood supply to the site. We spoke about this. Whenever the blood supply is good, the surgeon will love because the healing will happen. If the blood supply is not adequate, the healing will not happen. Dehydration and chronic disease. Dehydration means the person who is very dehydrated, who has a very less fluid intake inside his body. Very less fluid inside the body, again the vascularity will not work properly. The healing will be very, very slower. So, and the chronic disease, if the patient already is comorbidity, the patient is already facing, he is in cancer, the patient has a cancer, or the patient is a diabetics, hypoglycemia, all these patients are the factor, the wound will be not be healing. As you see in your home, when your relations who have the diabetics, they will be very afraid of the wound, but the wound will not heal. Correct? No, the spots will be remain as a black spots there. The complete scar maturation will never happen. Even after 2 years, even after 5 years, the scar maturation will not happen. The collagen will not develop to the fullest. Now, what is the collagen? Any idea? You heard about collagen, right, everyone? Collagen. What is the collagen? It's a tissue. It's a fiber. It's sort of fiber. It gives the elasticity to the body. The collagens are the elasticity. The natural, when you stretch your body, the collagen, which is not the body cell, the collagen is responsible to stretching all the body. And when the hernia happens, when we talk about the rubber band losing the viscosity, that's what's the collagen inside your rubber band. The collagen that loses the viscosity, that's where the hernia happens. Have you seen the patient who has a stomach like here? TAR cases. Very expert surgeon perform TAR cases. The person will lose half of the weight. The patients come to the hospital with 250 kg. Going back to home, she will be 120 kg. And it happens most in the woman. It happens mostly for the woman. And mostly because of the pregnancy. After the pregnancy, most of the women develop the obesity. They develop obesity. And if the obesity is not controlled, that's going to be very severe. And what happens when the abdomen comes here? That because your fascia losing the viscosity every day and the rubber band is having no tension to hold the body and the rubber band is stretching, the abdomen comes here. So it has to be treated, very costly surgery. Very expert surgeon does that. And they have to dissect everything, remove everything, cut the rubber band and try to stretch the whatever remain the rubber band they do. So that is called transabdominal resection surgery. So all because the fascia muscle, it's very important. So these cases happen, TAR cases. I'll show you the photos of TAR cases later. So complication of wound healing. So we were talking about infection. We were talking about the contaminated wound. So all these are complications. Now this wound is already infected. You see the suture has lost, that body tension is more. Why? Whenever, when the suture was done, the tissue was very much approximated. But it has opened up. Why the body is opening up the wound? Body has its own mechanism. Body has its own mechanism. Now, any infection comes near the body, it will give the signal to you by blocking all the site, creating an edema, which edema will open up the wound again. So the surgeon will see the wound has opened. Again, he has to cut. Again, he has to go inside, do the irrigation, put the patient of a higher end of antibiotic, and then again he has to close the wound. So complications are, see, infection is very simple. Infections happen very simply, but the infections are too many. One thing, too many things can happen. Too many complications happen. You know the diagnostic, the investigation rule of infection. Anybody from the laboratory here? No? So the investigation rule says, if you had to declare a patient as an infected patient, so you should have 100 to 300 bacteria per gram of tissue. Getting it? You should have 100 to 300 bacteria per gram of tissue to declare you as an infected. A normal person, I may be. But if there is any implant inside the body, implants are anything. The suture inside the body is an implant. The orthosurgeons put the implant, that is also an implant. The mesh inside the body is an implant. So what happened? If there is an implant inside the body, oh sorry, I gave you the reverse way, sorry. So to declare a patient an infection, the investigation rule says you should have 20 lakhs to 40 lakhs of bacteria. 20 lakhs to 40 lakhs of bacteria per gram of tissue. Got it? I said the other way, very sorry. So 20 lakhs to 40 lakhs of bacteria per gram of tissue, just imagine to declare a infection patient. But if you have an implant inside the body, 100 to 300 bacteria is dangerous. 100 to 300 bacteria, 1 gram of tissue is considered as a very dangerous. Very, very dangerous. That is why the orthosurgeons are very, very particular, because they are putting an implant inside the bone. They are putting an implant inside the bone. If infection happen, 100 to 300 bacteria in per gram of tissue, very dangerous. The patient may lose his limb itself. He may die also. So 20 lakh to 40 lakhs of bacteria and 100 to 300 bacteria. Looks very, very obnoxious, is it? So that is the infection, the challenges of infection, and the US itself has 40% of infection rate. We are talking about the developed country, US. In India, we see surgeons do a lot of tricks inside the OT, correct? So in developed country like US has challenge of the infection, the surgical site infection. So infection of the wound due to virulent organisms in the wound can lead to prolonged illness, gangrene, or even death also. Disruption or dehiscence of the wound can be partial, total suppression of the layer, too much tension placed on the newly suture line, improper closure, like the nurses, many a time the surgeon give the skin to the nurses, the OT assistant. You do the skin closure. The nurses are not properly trained or not properly sterile. They will infect the patient. The skin is not closed properly. So everything starts from the skin. The infection will go from the skin. So there are two types of infection happen. One is exogenous, one is endogenous. Exogenous happen from the outside. The bacteria goes from outside to the inside. The bacteria already which is inside, endogenous bacteria, what happened? That bacteria will attack from the inside only. The colonization will happen from the inside the body. So the doctor will never know the infection also until the patient's complaint. And in India, no one complains, no? India, everyone complains of the last hour. Sir, I am unable to get up. Now he will go to the hospital, correct? When he is having something, he will never. But in US and UK, anything they suspect, they will go to the hospital. Sir, I am not feeling okay today. So he will go. But India, everything at the last moment they will go until the infection is very bad, too bad. The surgeon will be shouting rather than treating. He will be shouting. You didn't came last month. I told you like this. So we see lot of patients there. Evisceration. So evisceration happened. So you see the evisceration. The bowels will try to pull up the skin from the outer layer. The bowel will do the lot of pressure. So evisceration happened. The organs will come outside. Your organs will start exposing. See how so much of the complication is the body is not properly treated, closed. So much of complication happen. Okay. So emergency situation. Now important surgical principle. This surgical principle is for the surgeons. Of course, you should also know what the surgeons has to length and direction of the incision. As I said, the surgeon will allow the incision where the vascularity is very good. Where the blood is good, the surgeon will take the incision there. Correct, no? Lot of name of the incision, financial, Joel-Cohen incision, so paramedian incision, mediolateral incision. All these incisions are designed so that the vascularity, the area where you take the incision, the vascularity should be good. The blood circulation or vascularization should be very, very good there. Okay. So tissue handling, dissection technique. When surgeons will do the dissection, the bowel dissection, he should be very careful. He cannot use any energy device near the bowel and do the dissection. They are very careful. Tissue handling. So tissue handling, the surgeon will be shouting to the OT nurses, oh, handle with care, properly. So when you do the evisceration, when you do the open surgery, you put the clamping and open the abdominal wall. So you have to, it's not that something you are opening, like opening a car engine. No, not at all. You are dealing with the tissue. Tissue should be very, very gently handled. Okay, hemostasis. Okay, if I find that time, last I will talk about hemostasis. The hemostasis, which I said, the stopping of the blood, the mechanical hemostat from your body, the signal from the body whenever there is a damage to the epithelium tissue. Maintaining tissue moisture, not too much of moisture, not too low of the moisture. The dehydration patient, I said the patient dehydrated, so no, not enough moisture, the wound will not heal fast. Okay. Removal of removal of necrotic tissue. If the patient is already diabetic, gangrene of wound, the doctor will see all the necrotic. What is necrotic? Necro, dead tissue. So it has to be removed. Then the new tissue has to be joined together so that the healing will start. Choice of closure material. The choice of closure material, suture is a gold standard. So they will use suture only most of the time. Okay. Cellular response to the closure material. Now everything you put inside the body has a response. The body will reject. You put hernia mesh inside, the body reject. So that is why they put the hernia mesh. Why they put the mesh? You know that hernia mesh is put to stop the hernia. No, not at all. The hernia mesh is put inside so that the body will reject it. The body reject the hernia mesh. It can't reject. It cannot throw out. No, they put the mesh and they anchor the mesh. They anchor it. Now the body cannot reject the mesh. The body cannot throw the mesh outside. What body does? Body has all the mechanism inside. What it does? It will try to encapsulate. It will try to encapsulate the mesh inside so that the mesh should not trouble you. So it will start the encapsulation of the mesh. Now that encapsulation of the mesh will become a scar plate. That scar plate will protect the herniation, not the hernia mesh. The hernia mesh was just to activate the body mechanism of fibroblast. The fibroblast happened, all the mesh has a holes, pores inside. So the fibroblast will happen, the tissue will go inside the pores, encapsulate the mesh is not seen. Only your muscles will be seen after the X-ray, after 3 months. Okay, and that scar plate will protect the herniation in future. Okay. Okay, what was there? Cellular response to closure material. So suture characteristic, not go much. Suture, whatever you're using, whatever device you're using, that should be sterile, that should be easy, pliability, ductility, all should be there. Okay. So AHSCON suture, okay, we are the brand leader. We have a highest standard of the manufacturing process, the very high ethics. The AHSCON means ethics and consistency. That is what AHSCON means. Okay. Yes. Sorry, ma'am. Another, I think we started late. So, yeah. 12 we can fill in. They say tea time. No? Okay, so we can break and later we can continue if you want. Okay. So, ma'am is telling we should have a tea. I am also tired, so we'll have a tea. We'll break it. So, another slide we will finish later on. Yeah, thank you everyone for the observation.
Welcome our Vice Chairman, Dr. Anita G. Bhatt, ma'am. I welcome you, ma'am. Over to you, sir.
Try to be as simple as possible. It is not going to end very shortly, I understand. But we will see that this program is run across again and again. Okay, so we are there for organizer, I will tell them. So we have lot of formats to make you understand. And AHSCON believes that training is what we can change. If you want to get a good patient outcome, the surgeons has to be trained. The OT nurses has to be trained. The proper principles, the guidelines which the world body, the world authority has put. So that has to be followed. The higher standard has to be followed. That is why we dedicate a lot of things to the training. We also bring, we are the only licensed to bring the animals, to bring the organs of the animals to the, we have the wet lab. We can get the wet lab anywhere. So that is how we train the PG student, the surgeons, if you want to learn laparoscopy, and we will continue to do this. Okay, coming back, the suture sizing. So very easy, not much. So you go to the OT. Now we were discussing about the tissue. Now all the tissues are not alike. All the tissues are different, characteristic different. The strength of the tissues are also very different, and all the tissue required different types of hold. The hold is required. Now the hold comes from the suture which the surgeons is using. Now suture comes in different sizes. Now the sizes, when we say, the surgeon will tell you size 1, 20, 30. So when he use this word size 1, 20, 30, that means the thickness of the suture material, the thickness. Okay. Now we manufacture suture which comes from size 0 in the middle, size 0, 1, 2, 3, 4, 5, 6, 7, the thickest. From the 0 to the 7, the thickest suture. And from the 0, then we will go minus the thinnest, that is 0, 20, 30, 40, 50, 60, 70, 80, 90, 10, and 11, 0. So from 0 to left side, the thinnest is 11, 0. Now talking about your hair size is 7, 0. So the suture we manufacture is 11, 0. The half of the size of your hair also. So we were talking about the vascular. So those sutures, the micro sutures are used on those vascular surgeries, some of the neurosurgeries, plastic surgeons, they use it. Okay. There is a classification for the sutures. Now, we will not give you all the classification, not required, not necessary. We will give you very simple. So these materials come in two different types. One is absorbable, the another is non-absorbable. This is commonly spoke inside the OT. But there are another classification, very important to tell you. The first classification comes natural and synthetic. The first classification, do remember, is natural and synthetic. Okay, in natural, the sutures are like catgut, steel, silk. So silks are also widely used. So this comes under natural sutures. In the synthetic, you have polyglactin 910, which is Vicryl, polyglycaprone 25, which is monocryl, polydioxanone, which is PDS. And there are proline, polypropylene, ethylene, polyamide. So these are there. If you want, I will give you the list. You can write it down later. I will ask your organizer to share with you. It's a very big list. No need to write. We will spend more quality time on the tissue rather than the product here. Okay, product the surgeon will tell you. You will not decide the product. The surgeon decide the product. Okay, you will be helping him. But you should know what he is doing. You should know why he is using. You should know why absorbable, why non-absorbable, why what. You should know that because you will be the boss of the OT. When you go to the OT, OT will be yours. You have to keep the OT, you have to maintain. Okay. And there is third classification also, braided and monofilament. Okay. So natural, synthetic, absorbable, non-absorbable, braided, monofilament. Three classifications sufficient. Okay. So there are a lot of sub-classification we not required. Okay. So these are some of the brands. Okay. So we were lot of in my first half we were discussing more on infections. Tissue we were discussing, and we are discussing more on the infections. So infections, we will go through, we'll dissect how inspection happen, what not to do, what to do. So surgical site infections are very, very common phenomena. Very, very common phenomena. It's going in across hospital, even in the corporate hospitals, these things are happening. So approximately 7,80,000 SSIs occur annually in US. I'm talking about the developed country US. Okay, we don't have Indian data. If you give the Indian data, the things will not be very good. So we'll talk about US data. Okay, changing demographic increase patient risk of SSIs. Like old age, nowadays what happened? The immunity is, we are losing immunity. All the youngsters smoking, drinking, eating lot of pizza, not exercising. We are not going to the bus. We are using more vehicles. So lot of things, the lifestyle changes. So happened lot into the younger patient generations. So obesity is common, diabetic become very common. So all these factors are affecting your wound healing. It directly affects your wound healing. History of smoking. If the patient comes with a history of smoking, definitely the wound healing will be very, very challenging. Even the anesthesia team cannot provide the proper anesthesia if he is smoking. They have to put it on the extra ventilators because the lungs will not be capacity of drawing the oxygens. Okay. And the reimbursement policy, the insurance company now are telling if the patient has so much of commodities, the Medicaid, the SSI is happening. In the US, there are very strict policy. If the infection happen inside the hospital, the insurance company will not pay the patient. Because they say it is the hospital factor. The infection is happening because of the hospital factor, not of the patient. Patient came to you and he is getting infection from your OT. So the insurance policy in US are very, very strict now for the surgical site infection. So patient with SSI, surgical site infection, 5 times more likely to die. This is the data. Whatever we are telling, backed by the data, in the below you can see the journals are published here, the below. So those journals you can go and see. Hospitalized up to 11 additional days in the hospital. If he's got an infection, he will be additionally admitted 11 days in the hospital. 11 days means the cost of the hospital livings goes up, the bill goes up, correct? The burden, 2 times likely to die. So 5 times more likely to be readmitted, almost 11 days additional stay in the hospital, 2 times the patient likely to die also due to the surgical site infection. Increased use of antibiotics and other medications. So additionally, patients with SSIs experience additional antibiotic, higher antibiotic. The cost, again, the cost is going on the patient. Okay, potential pain management complication, other healthcare associated risks such as bed sores, catheterizations, related infection, interruption of work, his personal life, all these things are happening just because of a simple infections. So data, so the data is surgery wise in the US. So they're talking about breast surgery, plastic surgery, and they're talking about the below the dollars they're given, the cost. I think this marker not working, I don't know. So the below the line, you can see $5,000, $10,000. These are the additional expenditures happening because of the surgical site infection in the US itself. So burden of SSI, increased length of hospitalization. So the patients are hospitalized for the longer duration because of the surgical site infection. All data says, according to the surgery, the knee prosthesis, spine, hip prosthesis, plastic surgery, abdominal hysterectomy, ventricular stent, CABG, ventral hernia, and colon surgeries. Now, the risk comes with a 2 factor. One is controllable, another is controllable. So, the controllable factor, the endogenous bacteria. We are talking about exogenous and endogenous bacteria, correct? So, surgical personnel. Now, you are the surgical personnel here, including the surgeon, okay? Your surgical tools, correct? Your tools which you are going to deploy on the surgery. OR environment. The OR environment, how well your OTs are maintained, sterile, properly fogged. Nowadays, corporate hospital are going into modular OTs, correct? They are going into modular OTs. They are not building the OT like this. So everything, even the AC vents, they say has a lot of infection. The bacteria in the AC vents are very, very challenging. Studies now came, now they are even controlling the AC vents also. So such a challenge is the surgical site infection. Bacterial colonization of the suture. The material, because the surgeons are using more and more sutures, the sutures are very, very more used. So what happened? The bacteria will, the suture will act as a nidus for the bacteria to colonize. So when the bacteria happen, when infection happen inside your body, the bacteria goes and sit on the body, your organs, or suppose your tissues or muscles. So your body immunity is there to take care. But when the bacteria goes and sit on the suture, what happens? You have no control. Your immunity has no control on the bacteria. So what happens? The bacteria will colonize. Colonize means how the British colonize us. The same way, the bacteria will colonize the entire suture. I'll show you the photograph. So it start colonizing, it will multiply, build lot of colonies, and that will be very deadlier. So what happened? So surgeons, you heard about biofilm? Anybody? Biofilm formation? You heard biofilm. Can you explain biofilm? No. So biofilm, anybody? Okay. So when these bacteria start colonizing on any implant inside the body, let it be suture, orthopedic implant, the mesh, anything, the bacteria first colonize the area of whichever the prosthetic inside, the implant inside. Then what they do? They try to protect themselves. So what they do is they create a biofilm among them. They create a biofilm on the upper part of their colonization, wherever the bacteria sits. So when the biofilm is formed, none of your antibiotic goes and touch the bacteria. So they are also very intelligent. So and when the biofilm happens, the surgeons are very mad. So they had to do the redo. They had to open again. They had to redo the surgery. They do the irrigation. Again, they have to irrigate, open the suture, everything they remove. Again, the fascia. Remember here the fascia. Remember the fascia again, which is slow healing. Again, opening because of the small infection. Too many things happening. So again, they have to incise the fascia. Again, they have to go do the irrigations. Put the patient on the higher antibiotic again. Okay, so costs are happening. Your body is also getting weakened due to multiple incisions. Correct? The fascia is bearing the brunt here. So the infection, now the controllable factor is you, your surgeons, your tools, everything, even the patients. Now which are the uncontrollable factors? Patient comorbidities. So patient age, if the patient is of a very high age, definitely the infections will also be the chances, the risk will be very high here. Age, diabetes, smoking, obesity, prior contamination of the wound. So these are also the factor, the patient, which is uncontrollable from the surgical fraternity. It is uncontrollable. So now the devices what surgeon use. So in 2016, I was touching this topic. In 2016, the WHO said, whatever goes inside the body, any implant going inside the body, even it may be a suture, that has to be antibacterial. So what AHSCON did, we had this antibacterial 10 years before the WHO gave the guidelines. So 10 years before, we had an antibacterial range. The surgeons were using this only for the high-risk patient or the patient who already got the infection. The cost of the sutures was high. But when in 2016, WHO said, you have to put antibacterial, you have to give antibacterial suture, whichever goes inside the body. So what we did was, we gave all the suture by default antibacterial. We didn't increase the cost. So that is one thing we gave it to across the medical fraternity. 2016, WHO said, 2017, CDC came. You know CDC, everyone? Center of Disease Control, USA. Although in the COVID news, CDC, remember? CDC, during the COVID, you didn't read newspapers. So nowadays, people don't read newspapers. So during the COVID, the CDC was playing a very central, very pivotal role, no? So testing, all those things, giving the data, countries' data, all those. So CDC is known as a very good authority on the disease control. It's established in USA. They also set a guidelines that everything goes inside the body should be antibacterial treated. Now coming down, UK, NICE guideline from UK also said, Krinko guideline from Germany 2022 also set a guidelines that whatever goes inside the body, especially the suture, should be antibacterial. So why they are telling all these things? To fight the surgical site infection. Because infection seems very simple, and what happened commonly, I myself go to many OTs, across the top surgeons we go, and moreover the nursing homes, no? The smaller nursing home try to compromise on the patient. The smaller nursing home. But what happened, they don't tell the patient. They don't explain the patient. Ma'am, I will give you non-antibacterial suture, which will cost will be lesser. If I give antibacterial, the cost will be little higher, but chances of infection lesser. But surgeons don't give choice here. Surgeons don't give choice. And why that is happening? Because the patient also are alike. The patient are very, whenever they go to hotel, they will pay 1,000 rupees bill. Eat all the pizza, whatever they wanted, they eat everything. Biryani, everything. But when they come to hospital, they will bargain. No, sir, I am very poor, I am like that, like this. So doctor also no option to use whatever available. They have to do the surgery. So this is also a patient factor also. So we have to educate the patient also. As a nurses, you will be doing that. So most of the time, the nurses also will go and tell the patient. So these are the good things, these are the bad things. Surgeon also try to explain them. So these are the factors. Oh, we have to educate the patient also. The surgeons are already there. They know it. They know the side effects. They know the things. And tomorrow, you are also going to the same profession. You should also know this. Okay. Now you see the bacteria. So, okay, the quiz to you. You can see the two pictures there. In one picture, the bacteria is one bacteria is there, I think. The second picture, the bacteria is more. That is on the skin surface. You can see the skin surface, the first one. The slider not working. Okay, it's not working. Okay, the left one picture, you can see the bacteria. There is a hair follicle there. So the bacteria, you do the scrub inside the OT. You do all the scrubbing. You do maintain the instruments, very sterile, everything. But still, the bacteria is going to affect the patient. How? can see the skin follicles, the bacteria is inside. What is that called? Heard about skin flora? Skin flora, anybody heard? Yeah, that is where the bacteria are there, and that bacteria get activated. The surgeries goes prolonged. The surgeons are worried. He has to close as soon as possible, so that the scrub won't work after so many hours. The bacteria from the skin flora will come. Again, it will go through it will contaminate the patient inside. So that is why your scrubbing also won't work much. If the surgeries are prolonged, very longer, or these things can hamper until the epidermis heals. It takes 24 to 48 hours after surgery. Bacteria can enter the wound from the patient's skin or the environment. The bacteria can still enter the patient because the wound is not closed. The healing is not happened. The skin is just closed together. It is just closed together. It is not healed. It is not sealed. Correct? The bacteria still can enter. Exogenous factor. Endogenous was the patient is not immune. Correct? So two factors playing here. Now you see the bacteria, and I was talking about biofilm. The right picture is the suture, the material, which has been zoomed almost 500 times to show you the blown up picture. You see the dots, the white dots, that are all bacteria. The white dots are all bacteria there. Okay. And on the left side, the knot is there. That is the suture knot. You can see the white, something like white film, like that is called biofilm. So we are talking about biofilm. That is the biofilm on the left side. So once the biofilm is formed there, no antibacterial agent or whatever doctors put, that will not disrupt, not sufficient to clean the bacteria there. So what the surgeon do, he has to open it again, do the irrigations, then put the patient on higher antibiotics again, and then has to, once the biofilm is formed, it is very difficult to manage the infection. So developing antibacterial sutures, we have given 5 bacteria name there. So any idea? Yes or yes? Staphylococcus aureus, very good. Where this bacteria is found commonly? Any idea? Someone said. Nobody? Yeah, you can tell, you can be wrong, no problem. Where it is? Where it is commonly found? Sir? Acha, nasal, you say nasal. So the air. So this bacteria is commonly found in the air, the AC vents of your hospital, the AC wherever the air, the Staphylococcus aureus is there. The second one, Staphylococcus epidermidis. So where this bacteria is commonly found? Where? The answer is there. On the skin, epidermis, the epidermidis on the skin. Excellent. The third and fourth is the same bacteria with the methicillin resistant, which is already resistant to the methicillin. So higher antibiotics has to be administered. Now the E. coli. Any idea what is E there? E. coli? Escherichia coli. Great. Where this bacteria is found? Any idea? Where this bacteria is very important in certain organs of your body, but very dangerous outside that organ. Which organ? Someone said. Sorry? Very excellent. Intestine, the bowels. This bacteria is present inside the bowel, which is good for the bowels, but outside the bowel, that is why the leak-proof surgery, the surgeons, remember the clean contamination? So this bacteria, the bowel surgeons, the gastrosurgeons, they are very much afraid of this clean contamination. So this E. coli is a very dangerous outside the bowel. It may leak. So we have the needle. You can see at the end of the session the needle, how to anastomose the bowel so that the leak proof will happen. So those kind of technologies are available. We'll show you at the end. The last is Klebsiella pneumoniae. Where this bacteria is found? Pneumoniae. Lungs, someone said, right? Excellent. So this is found in the lungs. Klebsiella pneumoniae. Pneumonia, no? Patient get admitted, no? Pneumonia due to, so this infection on the lungs, this is response. All these bacteria are there inside the OT, exogenous factor, all these are. E. coli is endogenous factor for the infection. So all has to be managed. If your OTs are efficient, if you are efficient, your OTs are efficient, your surgeons are efficient, because surgeons will not come and keep up the OT. It is the nurses who keep the OT, correct? It's the nurses who maintain everything. She knows what to wear, what not to. Even when I was conducting a class like this, one nurses told me that, sir, I found a surgeon who came directly into the OT without the hand scrub. So what I told him, sir, no, I cannot give my patient. So the surgeon was good. So I don't know why this happened. So he again went, had a scrub, and then came into the OT. So she was very right. She didn't allow the surgeon to come to the OT without the scrub. So that is how the OT nurses should be. Actually, you are the boss of the patient. The surgeon cures the patient, but the patient are under direct care of you, the nursing, the OT. So you are. Surgeon will do the surgery. It's more of technical, but you are all the emotional, all the well-being. The patient will be asking the nurse, not the surgeon. So you are the people who make the difference there. So our triclosan, the antibacterial which AHSCON gives, it's not the common, it is a triclosan studied over 40 years, and it is not the generic triclosan available in the market. What we did is, we went to the company who manufacture 99.99% pure form of triclosan. And that triclosan is used in the antibacterial across the suture. So we never take chance by going into the generic triclosan. We patented it, name as Irga Care MP. That is the antibacterial triclosan we are using across all our suture. Okay. So developing antibacterial mechanism of action. So we will not go much into it. So already we explained how about the infection, the antibacterial effect, the EMR assay. Okay. Now see the suture. See, this is how the triclosan treated suture. So the right side picture is triclosan coated suture. The bacteria are not there. The left side suture is untreated suture, which all the bacteria are on the suture material. This is how they colonize. You can see the dots there, white. This is how they colonize. They become larger. They spread, they colonize. Then they start to create a biofilm. Once the biofilm is there, your antibiotics will not work on the patient. So surgeon has to go manually to the site of infection. Then he has to remove everything, what we have done, all the layers. Now remember the layer, skin, fat, peritoneum, fascia, everything sutured. Everything has to be removed. Cost of again the suturing. Cost of again all the prolapse. Again he has to do all the irrigation. Again he has to administer the patient all the antibiotics. Patient had to stay inside the hospital, longer time and additional stay. So those are the data. So this is what it is explaining. So what we did was, when 2016 WHO said you had to use antibacterial suture, we took a petri dish. So we took a petri dish, infected it with the bacteria, incubated it for 14 days, and we put one antibacterial suture inside, and we took to the surgeon. We showed the two petri dish. One was infected with bacteria, untreated suture, and another was treated suture. And we showed to the doctor, very hands-on. We told them this is how the antibacterial will work. So that you can see the black area surrounding the suture, that is antibacterial treated suture. The bacteria will not come even near to the suture, So that is all the bacteria is covered. That was a real petri dish we did. And you see this yellow, this is also coated antibacterial. You can see there, coated. All the petri dish is covered with bacteria, and only the suture is been saved there, entire suture. This is called like a soap effect. You see in the bathroom when you are having a bath, the soap fell down in the tile. What you see? The water goes away, no? So that is the effect it called, the antibacterial suture affect the area of tissue in that way. So near the suture, it create a zone of inhibition where the bacteria will not even come there. Okay. So quickly, lot of evidence are available. You can contact us. We'll give you all the evidence on this if you want. If you're doing any projects, we will help you on those evidence. Okay, published evidence, clinical study done with all the top surgeons, the top names in entire world. Not sponsored by AHSCON. All are independent studies. So again, our brand name, Monocryl PDS Vicryl. Thank you, everyone. So just a minute. We brought you the needles, the sutures. If you want to do the suturing, we have the chemoid drum also for you. If you want to know the needles, how it really looks, everything is there. You can spend time here on this table and you can see. Any questions also you can ask, I'll be sitting here. Thank you everyone. Any questions you can ask me. Okay? Good. Thank you. Finish. Thank you.
sharing your knowledge and making our event a grand success. I request Padma Shri ma'am to hand over a token of love and respect. Heading towards the next session, that is Anaesthesia Workstation by Mr. Pradesh CB, Sir, National Product Manager, BPL Medical Technologies Private Limited. Mr. Pradesh CB, Sir, currently working as a Product Manager, Critical Care and Anesthesia in BPL Medical Technologies Private Limited Company. He is dedicated, resourceful and innovative profession, offering 26 plus years of experience in medical equipment, trade product management and service in various organizations in different capacities. He is recognized as Best Product Manager Award in the year 2015, 17 and 18, and also he is awarded as Product Growth Award in the year 2016, and he has received many more awards. I extend a warm welcome to you, sir, and his team.
Thank you. Oh, thank you
Over to you, sir.
for that introduction. Very good morning. In fact, actually, it's good afternoon right now. Okay. So, yet another topic, I would say, and very important, and it is more of, like a machine rather than, something clinical. So you'll be very much interested to see how, this machine works. And most of you might be doing a lot of troubleshootings or maybe a lot of operations or pre-use tests, whatever it may be on this particular equipment. And in an anesthesia, especially in general anesthesia, the most important product is an anesthesia workstation. So, anesthesia workstation is something like, there are so many, you would have nomenclatures, I can say, like Boyle's machine, anesthesia machine, anesthesia delivery system, anesthesia workstation. Why this noise is coming? Fundamentally, we can call it as like anesthesia machine, okay? So we are going to have a very detailed presentation on anesthesia machine, okay? So you all know what is anesthesia machine, right? How many of you have seen an anesthesia machine? Okay, very good. How many of you have actually operated an anesthesia machine? Okay, that's quite less. No problem. I can tell you, it is one of the easiest, machine to understand. But it is slightly tricky as well, I can tell you. It's nothing but, gas is flowing from one place to other place. Nothing else, I can tell you. Okay? Gas flows from the machine to the patient. It is probably controlled by the machine. That's it. So, nothing else, there is no rocket science in that, I can tell you. So, anybody can. After this presentation, I can tell you, anybody can understand anesthesia machine. Okay, let's start. So, the aims and objectives of this session is, we can see this. We will try to finish everything on time. We have got very less time, hardly an hour. But actually speaking, this time is not sufficient to explain the entire aspects of an anesthesia machine. I'll try to make it slightly fast. But if you have any doubt, you can definitely raise your hand and ask questions. Okay? Let's make this more interactive. Okay? I don't want only one person talking each other. If you have any doubt, you can ask any point of time. Okay? So these are things we will go through the components: high pressure system, intermediate, low pressure, safety features, mechanism of an anesthesia machine. I'll try to show you a block diagram, probably a kind of a simulation also. And of course parts, ventilator, very important aspect of any anesthesia machine. And how to check the machine, that is also very important, because as an OT technician or inside an operating room, the most important factor is now how to check the machine. Once the machine is tested and it is done correctly, nothing goes wrong. So you will not have any problem when the patient is being anesthetized or ventilated using the anesthesia machine. So what is the need? You all know, correct? No? Is it understood? The need of an anesthesia machine is to deliver gases, as I mentioned, nothing else, okay? But it will also, like the most modern anesthesia machines, will also do a mechanical ventilation as well, okay? So this is just, maybe we can say pressurized gases are supplied by cylinders. So you need a source of gas like cylinders or pipeline. Then that will be regulated by the machine, which is controlled by the machine, and then it is given to the patient through a circle system or a breathing system. So originally, if you say maybe 1917 probably, okay, the anesthesia machine was first invented by a great gentleman called Mr. Boyle. So it's called Boyle's machine, okay. This is something like a Boyle's machine. You would have seen this kind of machine, right? Very simple anesthesia delivery system, I can say. This is probably a much detailed, what is called explanation of an anesthesia machine. Don't worry, we'll go component wise, okay? This is just to show you how was an anesthesia machine earlier. Now, how will be an anesthesia machine now? So this is very important, what you can see. See, what you see here. Okay, my key. Okay, so these are the key components, I would say. So you are seeing actually some components are highlighted in red actually. That means those are high pressure systems. Okay, so you have gas supplies, you have pressure gauges, because whenever there is a gas supply, you need to understand what is the pressure of each gas supply. So you need a pressure gauges. Of course, you need regulators, because the pressure of the cylinder or pressure of the pipeline, the gas source rather, is quite high. You cannot straight away deliver those gas to the patient. So you need to regulate it. So you'll have a lot of pressure regulators inside the anesthesia machines. Then of course rotometer, or we call it as flow meter. You know this, right? Flow meter? Yes? So you will have a flow meter which is actually used by the anesthetist to set the dosage, how much flow to be given, okay, depending on the case or depending on the mode of operations. Then of course we have a vaporizer back bar, or we call it as a vaporizer station, because you need to add the anesthetic agent, right now, along with the gases, okay. Then of course you need a vaporizer, and there is something called a fresh gas outlet, or there should be an outlet now which we need to connect to a patient. Usually in anesthesia, the common terminology is common gas outlet, okay, CGO, or in some machine you will see ACGO, auxiliary common gas outlet. Then of course you need a O2 flush. What is the function of an O2 flush? Why you need a flush? Yeah, please, louder. The function of flush is actually, you want to suddenly remove the agents or maybe the anesthesia gases from the circuit, you need to give a higher flow of gases. So flushing is nothing but probably removing just like a waste, okay? So you want a fresh gas to be delivered, then you need to use an oxygen flush. So it's nothing but it's a very higher flow. You should not be using this oxygen flush when it is connected to a patient, because when you press the oxygen flush, a high amount of flow, almost 25 liters to 75 liters of gas is flowing to the patient, which is very dangerous, okay? So basically it is to clean or clear the gas parts within your anesthesia machine itself, okay? That's called oxygen flush. Then you have open circuit operation as well as closed circuit operation. What is open circuit operation? Any idea? Yeah. Have you heard about a circuit called Bain circuit? Jackson-Ree circuit? Okay. So open circuit is nothing but, immediately after the common gas outlet, you just connect the circuit and deliver to the patient. Very simple anesthesia machine, okay? So you don't have any rebreathing, okay? That's an open circuit. Closed circuit means, you have the gases, going to the patient, again coming back to the machine. Going to the patient, again coming back to the machine. It's like a closed system, okay? You have pressure release valve, we'll see all those things. Another important component of any anesthesia machine is a breathing system. Sometimes it is also called as circle absorber, okay? Then of course you need a ventilator. Why do you need a ventilator in anesthesia machine? To ventilate. Why do you need a ventilator? Of course ventilator is for ventilating a patient. Why do you need a ventilator? Because patient is unconscious, patient cannot breathe, okay? But do you need a ventilator? Without that also can you do anesthesia? How? You can do a manual ventilation also. So most of the modern anesthesia machines will have a manual ventilation, also a mechanical ventilation. So what is the advantage of having a mechanical ventilation? Doctor, he did not do the bagging. You set the parameters on the machine delivers automatically. So both his hands are free, okay? So very key, a very important component in anesthesia machine, it is anesthesia ventilator. And of course, what do you understand by auxiliary O2 supply? Any idea? Have you seen this? What you see here, that is ACGO. But what I'm saying is auxiliary O2 supply. What is that? What do you mean by auxiliary? It's an alternate, right? No? Okay. Suppose in case your anesthesia machine fails, by chance, you are not able to deliver the gases or agents to the patient, what you will do? You need to give at least an oxygen to the patient. Very important. So for that, there will be a separate outlet on the anesthesia machine in case your flow meter fails, in case your vaporizer fails, or in case the gases are not going to the patient. There will be a safety mechanism called auxiliary O2 supply, which will be bypassing the entire system. So you can open the oxygen and you can deliver the oxygen to the patient. At least your patient will get oxygen till you bring a standby machine. Okay, that's called auxiliary O2. There are some other components which we are going to discuss in the coming slides. So you need to visualize this. Whenever you are operating any anesthesia machine, irrespective of the brand, okay? It could be, there are so many brands available in the machine, okay, like we have BPL, Penlon, G, Draeger, Spacelabs, Mindray. There are a lot of machines available in the market. But all these machines are working on this principle only. This is a simple block diagram of an anesthesia machine. If you are able to memorize this, then I think it is, very easy for you to understand any anesthesia machine, okay? So you have, I don't know. Do you have another pointer? No, that's pointer alone is enough. Which is a pointer? This one, no? No, it's not coming. Okay. See, you can see, these are the gas sources. What are the gas sources? One is the cylinder and also pipeline, correct? So you have an oxygen cylinder, you have a nitrogen cylinder also. Is there any other cylinder available? Which one? Huh? No. Other than oxygen and nitrous oxide, is there any other anesthesia gas? Huh? Air. Air, right? Have you seen any air cylinder? No, right? There is no air cylinder, okay? But anesthesia gas, basically it is, oxygen, nitrous oxide, and air. So it's a, if it is only oxygen and nitrous oxide, we call it as a 2-gas machine. Or if it is an oxygen, air, and nitrous oxide, we call it as a 3-gas machine, okay? So right now, I'm only showing you a 2-gas, machine. So you will have a cylinder, one for oxygen, one for nitrous oxide, mandatory, okay? And of course, you will have a connection for the centralized pipes also. So these actually combined, if you see, it combines here, okay? There will be definitely kind of a monitoring device, like, you have a pressure gauge here, okay? You will have pressure valves here, okay? Then you have a oxygen supply failure. Like, suppose if your oxygen supply fails in any machine, it gives an alarm, because that is fundamental, safety feature of any anesthesia machine. So you will have a oxygen failure alarm system. Then there will be regulators here, and it straight goes to the flow meter. So from your gas high pressure system, this is a high pressure, and this is the intermediate pressure. Then it combines here, and it goes to your flow meter. From the flow meter, it goes to your vaporizer, correct? No? From the vaporizer, it comes to your outlet, that is called common gas outlet. This is a very simple anesthesia machine. Every anesthesia machine works like this only, okay, single block diagram. If you are able to understand this, then probably you will understand much better in the coming slides also. So this always memorize, in your mind, okay, cylinder, pipeline. It's actually it will work only from one source. If one source is not available, it will take from other source. Usually, always, in a central, always the machine works on this centralized pipeline only. Whenever the centralized pipeline fails or the pressure falls, it switches to the cylinder, okay? Then it goes to your, there will be multiple regulators inside. So high pressure and intermediate pressure is converted to a low pressure system. So what you see here, from this flow meter till this end, everything is a low pressure system. So this cylinder is a high pressure, this is the intermediate pressure, and this is a low pressure system. Clear? So this, you can see a much better exploded view again. So you can see these are the high pressure system. You can see on the left side, all are cylinders. And you can see pipeline is called intermediate pressure, you can see, okay? Then you will see the flow meter, and you will see the vaporizer. These are the low pressure system, okay? So you can see it is combined here. Cylinder comes here, pipeline comes here, okay? This is for, nitrous oxide, pipeline comes here, cylinder comes here. So it joins here. Then it goes to your flow meter, okay? So this is how, high pressure, on the back side of anesthesia machine, most of the machines will have that high pressure system on the back side of the machine. We call it as a hanger yoke, okay? Yoke system. Have you heard about this word called yoke? Okay. Yoke is nothing but to which you are attaching your cylinders. And what type of cylinders we are using? What type? E-type. It's called E-type cylinder, or in general it is called pin indexed cylinders or anesthesia cylinder. There are different types of cylinders, A-type, B-type, D-type, okay? But what here we are using is, this is called a E-type cylinder, okay? We'll have a regulator, valve here, okay? You will be attaching the cylinder onto this machine like this. And these things are called yoke system, okay? This is also an, zoomed view yoke system. Can you see two pins here? Are you able to see? This is called the pins. Now it will be different for oxygen, it will be different for nitrous oxide. It's like a safety system. You will not be able to interchange an oxygen cylinder to a nitrous oxide. What will happen if you change the oxygen nitrous oxide interchange? What will happen? Instead of oxygen, you will be delivering nitrous oxide. Okay? So this is basic safety mechanism available on any anesthesia machine. That's called the pin index system, okay? And you also have a washer here. This is called Bodak seal. You need to always, whenever you're checking an anesthesia machine, please ensure this Bodak seal is present. If the Bodak seal is not available, what will happen? Heavy leakage, okay? So what happens now, why this Bodak seal is going up? Because one is because of the, usage. Second thing is when you remove the cylinder from the machine, sometimes this Bodak seal will stuck onto the cylinder. You will send the cylinder for refilling. So when you connect the new cylinder, now you will see the Bodak seal is missing. So you will not be able to use the machine on cylinder because of heavy leakage. So please ensure whenever you are removing the cylinder, okay, whoever is removing the cylinder, ensure that the Bodak seal is not removed from the machine because you can easily remove it actually. Okay, this common things which we have seen, in operation theater, and finally now we will have to supply the Bodak seals. Okay, you will have a key also. This is a key, like what you see on the left side is a cylinder opening key. You need a key to open the cylinder. And this is a pressure gauge. What you are seeing is, this is a pressure gauge. This is a pressure gauge, okay, for the cylinder. What will be the pressure of the cylinder? Any idea? How much? 2000? Okay. How much gas will be available in a cylinder? Any idea? What is the amount of gas available in each cylinder? This is important, right? When you are operating on a cylinder, you should know how many hours the machine will run on cylinder. Usually it is, for example, this type of cylinder, it is roughly around 660 liters to 700 liters of oxygen, if it is properly filled. It depends on the filling pressure also. So a thumb rule, I can tell you, a thumb rule is to understand what is the amount or what is the volume of gas available on each cylinder is the filling pressure into water capacity. For example, this cylinder is a 5 liter water capacity. Okay, I mean you can fill 5 liters of water into cylinder. Water cannot be compressed, right? How you can, in a 5 liter can, how can you fill 700 liters of oxygen? Because gases can be compressed. So your compression pressure, that depends on, how from your suppliers, somebody will fill at 140, somebody will fill at 145. So 145 into 5 is equal to roughly your capacity of the cylinder. That means 700 liters of, or maybe let's take 750 liters of oxygen. If you give a flow of 5 liters, 750 divided by 5, how much? Roughly, 150 minutes we can run. Okay? So this is the center line. Again, you can see the connection on the machine. This is the connection on the hospital. Okay? This is how it is connected. You can see the connection, how it is connected. On this picture, you can see connection. So usually oxygen is always white, nitrous oxide is always blue, and air is always black. Okay? So this is an international color code. We call it as ISO color coding system. So all the machines, will have the same color code. Okay? So you should not again interchange, but the hoses usually will not be able to do that because again it is indexed NIST or DISS. Okay? What is NIST? Non-interchangeable screw threaded. DIS is diameter index safety system. So most of the machines will be NIST. Okay? Some are still DIS only. Okay? So NIST or DIS, these are the, like in anesthesia cylinder pin index system, here it is NIST. Okay? So this is like, for example, what you see is the NIST. Okay? So you'll be connecting this to here, this oxygen to here, nitrous oxide to here, and air to here. There will be another yellow also. What is for yellow? Very good. Okay. So the pressure is 4 to 6 bar. Okay, intermediate pressure. So when both the supplies are connected to anesthesia machine, by default the machine will take the gases from the larger reservoir. That is nothing but the pipeline. Okay. So this is the pressure gauges. Okay, leave it. Regulators, leave it. Okay. Now next, okay, you would have seen the flow, the kind of the presentation in a flow like from a gas supply inside the machine, step by step to the patient. So if you are able to understand this flow, it will be easy for you to memorize the anesthesia machine. Okay. So this is the next stage is your flow meter, another important component in the flow meter. What is the function of the flow meter? To set the flow. Okay, that is one. Number two is it also mixes the gases. the flow meter actually also mixes, like the doctor is using oxygen plus nitrous oxide. So it mixes the O2 plus nitrous oxide and gives to the patient. Sometimes O2 plus air, okay? Or sometimes oxygen alone, okay? That's the second function, is to mix the gases. The third function is, no, you would have seen this word called hypoxic guard. What is hypoxic guard? What do you mean by hypoxia? Huh? Okay. So, hypoxia guard means avoid a hypoxia, as simple as that. Okay. That means it will be minimum of 25%. That means the machine will not allow you to deliver anything less than 25% of oxygen. That's called the hypoxic guard system, okay? So, there are different types of hypoxic guard system available. The link system, chain system, pneumatic system, electronic hypoxic guard system. There are multiple systems are available. So, this component, this flow meter, it's a very important component in deciding the machine, like is a low-end machine, or is a mid-end machine, or is it a high-end machine. This aspects changes a lot when you go for a high-end machine, like for example, 50 lakhs machine, 70 lakhs machine. This changes. For example, what you see on top, this is a mechanical flow meter. How do you read the flow? There is a bobbin here, which moves on a calibrated tube. So if there is 1 liter, so if the bobbin moves up to 1 liter, you are delivering 1 liter of flow. Okay? This is a 3-gas version. Okay? This is also a 3-gas, but can you see a different? You don't see any tube here. Instead, you are seeing a digital display. Have you seen this kind of machine? Okay? This is also called maybe an intermediate machine. So this is a mechanical flow. This is an electronic flow. But there is one more thing, the high-end system, that is called completely electronic mixing actually. Even the control is, you adjust the flow, everything is digitally mixed actually. So this is called electronic gas mixing with electronic hypoxic guard. Whereas this is an mechanical flow meter with electronic display only. Here you are seeing the bobbin, here you are seeing digitally. So it is easier to read the flow here, or it is easy to set the flow here. So basically there are 3 systems we can say: mechanical, electronic and digital. Okay? In digital now you can straight away set 2 liters, 3 liters. You just press and do, the machine will automatically deliver the 2 liters. You can also deliver the desired amount of oxygen just simply clicking and see 25%, 50%, 100%. That's it. You don't need to play around the knobs. Everything is controlled digitally. Okay? So electronic flow meters will have something called this one, you can see something like a digital depiction of the flow, something like a virtual flow meter we call it as. Okay? So next is your back bar. From the flow meter, the gas goes to the back bar, and the back bar you have the vaporizer. Okay? So back bar again, there are 2-3 types of back bar. One is the most commonly used one is a Selecta Tech back bar. There is another called plug-in vaporizer back bar. There is one more called the cage mount vaporizer back bar. So most commonly you will see Selecta Tech vaporizer. The thing is that why I am telling you, because the Selecta Tech vaporizer may not fit on a plug-in back bar or on a cage mount actually. Okay? So most of the companies like BPL, Penlon or G or Space Labs Mindray, they all are following this Selecta Tech back bar. Okay? Dragger is following a different system. So Dragger vaporizer may not fit on other machines. So this you need to take care of it. Okay? And another important function of this thing, when you are connecting 2 vaporizer, you will be allowed to operate only 1 vaporizer. You cannot operate in both the vaporizers simultaneously. By the way, what are the kind of agents available? Sevoflurane, isoflurane, desflurane, enflurane, halothane. 5, correct? Only 5 agents are available. Okay? So for that we are covering in the next. So these are the different types of vaporizers. So you can see how this vaporizer is mounted onto an anesthesia machine. You can see 2 are connected here. Okay? but you will be able to operate only one. The other one will be automatically locked. So it's called interlock system. Okay? That means two agents are never delivered to the patient simultaneously. But you can close one and you can operate other one. That means for certain amount of time, you will be delivering two agents to the patient anyway, okay, in closed system. So each vaporizer is agent specific, very, very important. You should never ever interchange a vaporizer or a drag. Like suppose if you are having a sevoflurane vaporizer, please fill only sevoflurane drag into the vaporizer. Do not use isoflurane or desflurane or halothane drag onto a sevoflurane or vice versa, okay? Because each vaporizer is calibrated for that particular agent. Understood? And to avoid that, now there are various safety mechanisms provided by the manufacturers. One is this called the key fill system. Second is called this quick fill system. So you will not be able to even forcefully deliver those agents to the different vaporizer. So those kind of safety aspects been taken care in the anesthesia machine. So vaporizer is a very critical component, I would say, because that decides the dosage or maybe the depth of anesthesia. So using a good quality vaporizer now will ensure a proper anesthesia, depth of anesthesia, probably the recovery also will be easy. If you are using a poor quality vaporizer, if the accuracy is not good, sometimes patient might wake up, or sometimes it will be delayed wake up, maybe a recovery will be delayed actually. So good quality vaporizer is very important in anesthesia. Okay? Again, after ventilator, very important component is the vaporizer. So this is an oxygen flush I was telling, and this switch is used for, this will be there in almost all the anesthesia machine. You put it either in circle system or you put in open system. That means when you are pushing this in this situation, suppose this position, the gas supply will be going to circle absorber. But when you are keeping it down, the gas will come through this outlet wherein you can use your Bain circuit or Jackson-Ree circuits or Magellan circuit, whatever it may be. So this is called the auxiliary common gas outlet. And another thing is after auxiliary common gas outlet, the next thing is not connecting the patient, but it's nothing but a breathing system, which is an interface between the patient and the machine. It's called the breathing system. Okay, so you'll have outlet. This inspiratory outlet, it is marked here. This expiratory outlet marked here. So gas will come from the machine to the patient. From the patient comes and comes to the front. And this is called the bellow, which is driving the the ventilator. And you have this, inspiratory and expiratory valve. There's a small valve here. Again, another important component, because if this valve is not operating properly, you will have the rebreathing issue. The carbon dioxide rebreathing issue might happen. So whenever there is an FiCO2, the inspired carbon dioxide value is going more than 2, 3, 4. Okay, you need to check whether these valves are actually operating properly or not. That means during inspiration, your inspiration valve will open. That time your expiration valve should be closed. Okay? During expiration, inspiration will be closed, your expiration will open. So you can see during a ventilation how these valves are acting in synchrony. So that's very important. If this is not synchronized, definitely you will have problem in rebreathing of carbon dioxide. You can quickly make it out actually. Why this happen? Because sometimes there will be moisture coming into this water, which can stuck your valve. So you have to open it, clean it, and put it back. Okay. Have you heard about this AGSS? Anesthesia gas scavenging system. Seen this? What is the purpose of this? This is to remove the excess gas which is coming out of the machine, throw it outside your operation theatre. Why? Why you have to throw it outside the operation theatre? That is because for safety, because you are also inhaling, because whatever you are delivering to the patient, a partial thing is also coming out of the anesthesia machine, which actually the staffs, the OT staffs or whoever is standing inside OT, you are also continuously inhaling it. And most of your life will be inside your OT. So inhaling is continually for days and months and years, can be a problem. So you need to have a proper anesthesia gas scavenging. That means you have to take out the gas and throw it outside your operation theatre. That's called AGSS. There are two types. One is active and other is passive. So this is something which we have covered on the anesthesia delivery part, okay, basic anesthesia machine. Do you have any doubts up to this point? Anything need to be clarified? Next we are going to ventilator. Any doubts? No? Clear? Everything is understood. Can I ask some questions then? Okay. So what is a mechanical ventilation? And as we discussed now, if the patient is not able to breathe, okay, then definitely you need to mechanically give the respiration, or maybe the artificial respiration you need to give. So for that now you need a ventilator. So whenever you are doing an anesthesia, especially general anesthesia, you are actually giving a lot of muscle relaxation. So your patient will not be able to breathe. So you need to support the breathing, okay, the respiratory system. For that now you need to have a ventilator. We call it as an anesthesia ventilator. Okay, it should be an integral part of the machine itself. You will not see it outside. Everything will be inside the machine itself. When you see an older generation machine, the anesthesia delivery is separate. You will have a separate ventilator. You will have a separate breathing system. That's called now like an old system, maybe old school of anesthesia machine. Now everything is integrated. You will see one equipment which will have everything like anesthesia delivery, vaporizer, circle system, plus your ventilator. So what are the basic parameters or concept of any ventilator? This is applicable even for an ICU ventilator also. Sometimes you will be taking care of the ICU also. So there are 4 fundamental parameters. Please, there is nothing else beyond that. I'm telling you honestly, there is nothing beyond this. There is something called pressure. What is pressure? It is a driving force to push the gas into the lung. Why need to push the gas into the lung? How do you breathe? You all breathe because of the negative force, right, which you are creating right now. But when the patient is not breathing or patient is given muscle relaxation, that means there is no negative pressure being created inside. So how you have to deliver the gas? You have to apply an external force, right now? Correct? Otherwise, no, you will not be able to deliver the gas. There should be always a pressure difference you have to create from the machine to the lung. So if the pressure is high, the lung pressure is low, the gas will flow from the machine to the patient. Okay? Suppose the patient, you have given the gas into the lung, then how the gas will come out? Are you going to suck it out? How the gas will come out? Or how, when you are breathing in, how you are breathing out? What is the mechanism? It is because of the elastic recoil of your lung. Am I right? Correct? Correct? So, when your patient is not breathing, that means your muscles are not acting. So, you have to push the gas into the lung. So, you have to apply an external force. That's what exactly a ventilator does. And the parameter is pressure. The force is pressure. So, when the pressure is exerted, the gas goes into your lungs. Okay? Now, what happens now when the pressure is stopped? When you are releasing the pressure, the lungs always has a tendency to recoil back, correct? No? So, it will just recoil and you will push the gas outside automatically. You are not taking the gas out. It is because of the recoil of the lung only the gas is coming out. So, what you see pressure, exerted pressure into the lung, that is called inspiration. Okay? And what is coming out is called expiration. Okay? So, one important factor is pressure, which is the driving force behind pushing the gas into the lung. Okay? Next is how much you want. Correct? Now, there is a driving force ready. But how much you want to push the gas? There is a limit, right? No? Depending on the lung size, depending on the patient category, maybe it is 100 ml, maybe it is 500 ml, or it is 700 ml, depending on the patient category. Correct? No? How it is decided? How much tidal volume of gas is needed for a patient? What is the fundamental formula? 8 into 8. Roughly, I can say, it depends, okay. Earlier it used to be 10 ml per kg. So if you are 50 kg patient, 50 into 10, 500 ml. Now, you know, it's actually 10 ml seems to be quite high, sometimes 7 ml, 8 ml. Some doctors are even practicing 6 ml also, but purely practice. So approximately 7 to 8 ml per kg. That means 50 kg patient means 50 into 7. That means 350 ml of gas should be pushed every time a breath. Okay, that's called the volume. So when you are delivering a volume or when you are delivering a pressure difference is created, which will create a flow. That is called flow. So the pressure difference will create a flow. That flow, when it goes to a chamber, your lung, it becomes a volume. Over a period of time, it's also very important how much time you should give this oxygen. That's called time. So basically all the ventilators works on pressure, volume, flow and time. Nothing else I'm telling you. Every ventilator manufacturers, including my company, we all are playing around these 4 parameters and tell this is volume control ventilation, that is pressure control ventilation, this is SIME, this is PSV, that is ASV. There are a lot of ventilation modes available in ventilators and anesthesia machine. Everything works on simple these 4 concepts only: pressure, flow, volume and time. Again, I'm telling you, pressure is the difference in the force which is creating the flow. The flow, when goes to lungs, it becomes a volume over a period of time. Okay, so these are the 4 fundamental parameters of any ventilator, whether it is an anesthesia ventilator or an ICU ventilator. So again, it's just explaining the force that creates the flow from the ventilator to the patient lung, and flow, the velocity of gas, which is usually measured in terms of liters per minute, and of course tidal volume is nothing but demand actually by the patient. Sometimes it will be 7 ml per kg, 8 ml per kg, sometimes it will be 9 ml per kg depending on the patient demand. Okay, the doctor, the anesthetist will decide how much the titration is needed for that. Then of course frequency, you understand what is a frequency. The breath rate, the machine will be, on the machine it will be set the breath rate, and very important aspect is the fraction of inspired oxygen. That's called FiO2. Any anesthesia machine you will see a value called FiO2. What is FiO2? It is nothing but the inspired oxygen concentration. Okay, how much, what is the amount of oxygen, what the percentage of oxygen going into the patient, which is usually vary from 21% to 100%. In our anesthesia machine, the minimum FiO2 concentration is how much? How much? We explained in the previous slides now. What is the minimum amount of oxygen concentration which can be delivered by an anesthesia machine? 25%. Your machine will not allow you below 25%. Okay? So you need to monitor it. You are setting on the flow meter. How do you monitor it? You have the FiO2 monitoring on the anesthesia machine screen. So this is a basic ventilator. Definitely everyone would have seen this. What I mentioned earlier, creating a pressure. This is nothing but you assume this as your lung. This is a cylinder. So you are applying a pressure, your balloon inflates. Okay. Now you just see when you create another part, you close this and open this. That's called expiration. Correct? No? This is a very simple ventilator, but maybe I can explain you again in this way. Like you have an inspiration, you have an expiration. This is your lung. So during inspiration, your inspiration valve opens, the gas flows to the lung. Okay? During expiration, your inspiration valve is closed, your expiration valve is open, so gas goes to the atmosphere or back to the anesthesia machine. This is a simple ventilator concept. So that's what now this valve, this inspiratory valve, this expiratory valve is very important in any anesthesia machine or any ventilator. If both are opening, then it is a problem. What will happen if both are opening? Suppose in this scenario, suppose this is open, this is also open, what will happen? The gas will go here, but the gas will also go here. Correct now? The gas will always take the easiest path. So if this is open, the gas can go here, the gas can go here. This is called leakage. This is a problem which you are going to face in most of the anesthesia machine. The biggest headache on any anesthesia machine is leakage. How to identify the leakage, which we will explain in the coming slide. So leakage is, we can easily identify it on the machine itself, by looking at the graph, everything. So, but if you are having, this is not closing during inspiration, definitely the gas will go here. But now it is coming here, but it will stop here because it is closed. But if it is partially open also, some leakage will be there. Okay? So this is really. These are the different, have you heard about the ventilation modes? Different ventilation modes? Are you learning in your curriculum? Types of ventilation modes? Volume control ventilation, pressure control ventilation? No. No need of this. Okay. No issue. There are different ventilation modes of ventilation like volume control ventilation. There is another called pressure control ventilation. That means in volume control, the name suggests a volume control ventilation means you are controlling the volume. You are setting a volume, machine is delivering the volume. Okay. When you are set in the pressure control ventilation, you are setting the pressure, not the volume. So machine is delivering the pressure. That's all difference. Okay. Now there is something called synchronized, like suppose a patient is breathing. Usually this volume control and pressure control is usually called as controlled mode of ventilation. Okay. The patient is not allowed to breathe. Whereas your SIME is nothing but the patient also can breathe. Patient is also allowed to breathe during the ventilation cycle. That's called SIME. Okay. PSV is nothing but the complete breath control is completely by the patient. Okay. So these are some of the aspects which we have discussed. Okay. The safety features like interchangeable. I think most of the things we have discussed. Okay. So this is a ventilator screen. Okay, this I think you should be very familiar. I just want to show you a practical ventilator screen. So what you see here, no? This area, every ventilator will have a control panel. Okay, every ventilator will have a reading panel. Every ventilator will have a waveforms also. Minimum this many will be there in any ventilator. Okay, so what does the control panel does? It controls the ventilator parameters like tidal volume, frequency, I ratio, PEEP. No, all those things are controlled by the control panel, and you can read it on this one. Sometimes in some ventilator maybe this on right side, or maybe this is vertically placed. It might change, the layout might change in different manufacturer. But every ventilator or anesthesia machines will have a control panel which is actually for controlling the ventilator parameters, and also these are the measured parameter. Like you are setting, for example, 460 tidal volume, the machine is measuring 450. You need to ensure whether the 460 ml is going to the patient or not. So you will have a measurement also. Okay. You will have alarm parameters here, coming here. Okay. You will have other settings also here. So this is a typical ventilation screen. Screen size might vary, 8-inch, 10-inch, 15-inch, 19-inch, different screen size will come. But all the screens will have minimum these three areas. This is a waveform, pressure, flow, and volume waveforms. Okay, minimum these three areas will be there in any anesthesia machine. So this is a ventilator setting. So what are the main settings on any ventilator is, one is of course the tidal volume, very important in any anesthesia. Most of the anesthesia machine, or not every anesthesia machine should have the volume control settings. Of course, another important thing is the frequency. I mean, how many times in a minute you need to deliver the tidal volume to the patient. 14 times in a minute or 15 times in a minute. Depending on the clinical situation, the anesthetist might increase or decrease. Okay, that is called the frequency. I ratio is nothing but the inspiration time and expiration time. So how much inspiration time, how much expiration time. Usually expiration time is always higher than inspiration time. What is the reason? Why in every ventilator, in every patient, I am telling you almost 99% of the case, the inspiration time is always less than expiration time. Any guess? Any guess? Because your inspiration is forcing, you are forcing, it is active. Expiration is passive. That means because the elastic recoil only, the gas slowly comes out. The expiration will be slowly, it will be slightly slow. So you need to give more time to empty the lung. That's it. So inspiration time is always less than expiration. There are some certain clinical application, you will just reverse it also. It's called inverse ratio ventilation. That's some clinical application is there in ICU and all. Sometimes you will use an inverse ratio also. That means inspiration is more, expiration is less. That's also there. Okay. But that means that is the reason we are having a control of IE ratio on any ventilator. Of course, PEEP is nothing but positive and expiratory pressure to keep the lungs open to avoid an alveolar collapsation. Okay, that's called the PEEP function. So now, I think most of things are covered on anesthesia machine. I'm talking the basics of things. Now, what is more important on anesthesia machine, being an OT technicians or anesthesia technicians, what you should know is, I was talking in the beginning, what are the different check mechanism available on the machine? Because this is very important, because when your machine is tested and it is perfectly, all the tests are passed, that means your machine is, you will not have any problem during the course of anesthesia. If you are not doing the test, 100% I can tell you there will be some problems coming during the anesthesia or during the ventilation or during the maintenance part of the anesthesia. So it is important now you do a pre-use check on every day, actually, every day morning. And of course, you will definitely check whether the power supply is available, the main supply is available, machine is working on battery, because the main supply is lost. Sometimes in many operation theatre, your main supply is lost, the machine should work on battery. Correct, no? So you should also check whether the machine is working on battery. Just remove the power plug, whether it is working on battery or not. Okay. Ensure there is no gas leakage, because when you are connecting the gas supply or onto the machine or from the sink, there should not be any hissing sound, kind of sound. If you are hearing it, get it corrected by the maintenance guy, biomedical guy, or maybe the maintenance person or the gas supply. Okay. Flow meter control is very important. You have to turn all the flow meter and see whether the gas is coming or not. Okay? Because if you have connected the gas onto the machine, that doesn't mean that now you will get the flow on the flow meter. You need to ensure by opening oxygen, opening nitrous oxide, opening air, whether the gas flow is coming, sufficient amount of at least 5, 6, 7 liters of oxygen or nitrous oxide air is coming on the flow meter. That please ensure that. And of course, another important thing based on my experience in the field, the vaporizer is one component which is variable, which can be taken out from an anesthesia machine. You can easily remove it and you can easily fix it onto an anesthesia machine. So what happens now, it's a big variable factor. Many times now from OT1, you remove the vaporizer and put it on OT2 machine. From maybe OT2, you'll remove it on OT3 machine. The vaporizer is actually like, going in different OTs. So what happens in a hurry-burry, we'll remove the vaporizer. Sometimes when you're fixing it onto the machine, you will not fix it properly. So there will be a leakage. Okay? Because what do you mean by leakage? Leakage is a big problem in an anesthesia machine. Leakage means whatever you are delivering is not reaching. It's as simple as that. You are delivering something from the machine which is not reaching to the patient. That is called leakage. So leakage can lead to different, one is a hypoventilation. The ventilation may not be adequate, number one. Number two, your anesthesia delivery itself will be highly compromised. So, the patient depth of anesthesia or probably the inadequate delivery of, anesthetic agents can lead to, even under anesthesia also. So, leakage is a big problem. So, when you are doing a pre-use test, you ensure that there is no leakage in the system. That is the reason I am telling you it is so important to do a pre-use test on anesthesia machine. Every anesthesia machine will have this procedure. And it will be written very clearly, step by step, 1, 2, 3, 4, like that. It will be with the amount of a picture that will be mentioned on every machine. Some are manual, some are automated, some are automatic, fully automatic. Automated means manual plus automatic. Some are fully automatic also. So there will be different, every anesthesia manufacturer will have a pre-use test procedure mentioned when you start the machine. Please do that every day when you start the OT. It might be 2 minutes or 3 minutes, sometimes 30 seconds only. Okay? Ensure that now all the tests are passed. Then I think if you are using the machine, nothing can go wrong. Okay? Check the oxygen flush. Okay? Again, another important thing is soda lime. You know what is the function of soda lime? What is the function? To absorb the carbon dioxide. Okay. So, again, what is the interval that soda lime need to be changed? Any idea? Color change. Okay. It is what we have been taught. Color, when the color is changed, change it, right? No? Yes, it is true. I would say it is partially true, but it is not fully true. Because you need to also check with the manufacturer of the soda lime. So, because soda lime is not produced by any anesthesia machine manufacturing guys. It will be separately driven by some other company. Please check with them how many hours we can use a soda lime. How many hours? That's very, very important. It is not based on the date. It is definitely not the base, because I have seen many times on the anesthesia machine, they would have put soda lime replaced on so and so date, 27 2024. After 10 days, we will replace soda lime. That's not the right practice. The right practice is how many surgeries or how much time you have used soda lime. So I can give you a rough example, maybe a thumb rule again. 1 kg of soda lime, usually every anesthesia machine will at least take 1 kg of soda lime. 900 grams or 1 kg or 1.3 kg depending on the soda lime canister capacity. 1 kg soda lime will last for 8 to 10 hours only. That means if you do 2 procedures, like 4 hours procedure, 1 day you will have to change. If you do 1 procedure which is lasting 8 hours, you have to change immediately after the, probably, the soda lime you have to change after surgery. There is no relevancy in terms of date and all. After 10 days, maybe in 10 days you will be doing 10 procedures, which is almost 40 hours maybe. Each surgery, let's say average 4 hours, 10 surgery means 40 hours. 40 hours means you should have changed the soda lime 2, 3, 4 times. So it's very important, the soda lime is changed timely. Again, I'm telling you, it depends on the quality of the soda lime. The absorbing capacity of soda lime, that is properly defined by the manufacturer. So please, this is very, very important because we are facing a lot of challenges. As an anesthesia manufacturer, I can tell you, we are facing a lot of challenges. Soda lime is not changed timely. Because of that, rebreathing happens, carbon dioxide, EtCO2 value builds up. This is a problem which we have commonly seen on anesthesia machine. Of course, another important thing is the ventilator leak test, because this is something automatic manual leak test. The ventilator leak test to be tested on every day. And also, after doing all the tests, it is better now you run the machine at least for 5 minutes on a test lung. You have a test bag provided along with every machine. Just it's like an artificial lung. You connect it and just run it for a few minutes, maybe 2 minutes, 3 minutes, 5 minutes, ideal. Then I think you see whether the volumes are achieving, graphs are coming, values are coming, everything is coming fine. The machine is ready for use. Okay. These are the do's actually, but there are some important don'ts, which actually why I am specifically including this. You guys are going to be maybe working in an OT environment. And what is do's and what is the don'ts are very, very important, which is actually helps in improving the life of the machines which you are working with. Okay. So don'ts actually, number 1 is you see, don't leave the anesthesia circuit when you connected to the main supply for overnight. Everybody will tell please for charging keep it plugged, battery will charge. But it is not recommended if the machine is overnight plugging it. It can, so many things can happen. Some electrical fluctuation can happen, battery overcharging, battery heating, unnecessary power waste, everything can happen. So it is not recommended to connect the machine onto the power supply overnight. Okay. And the gas supply, suppose again the gas supply is high pressure. You are from a high pressure source, you are connecting to the machine. It's a high pressure source actually. You are always applying high pressure into the regulator. Why do you want to strain the machine regulators? Maybe the machine is not in use. You can just disconnect the gas supply. Okay. And agent, again anesthesia, we have mentioned about the anesthetic vaporizer. You need to fill the agent like it comes in a liquid form. You have to fill into the anesthetic vaporizer. It is not recommended to fill the vaporizer when it is being used on a patient, because it can lead to probably leakage sometimes, or it can lead to the over delivery or under delivery of anesthetic agent. Okay, because the vapor pressure which is building inside the vaporizer will take some time to achieve that proper vapor pressure. So if you pour it and immediately start delivering it, you may have problem in delivering the anesthetic agent accurately. Okay, so it is not recommended to change the vaporizer agent at the time of machine is being used. Do not tilt the vaporizer. Very important. The vaporizer always should be kept vertically. Suppose if you are taking a vaporizer in an emergency from one OT to other OT, please keep it vertically and handle it very carefully. Do not tilt it more than maybe 45 degree means gone, because your agent is also tilting inside more than 45 degree, which can create problems in when you connect into the next machine. The delivery may not be exactly accurate. So please, when you are moving a vaporizer, that too with filled agents, please handle very carefully. Soda lime, again, very important, because there are good quality soda lime, there are average quality soda lime, there are poor quality soda lime. How do you understand that? Poor quality soda lime nothing but dusty. The more dust, the quality of soda lime is not good. So you need to always see the dust-free soda lime, because dust will always obstruct your gas flow. It will create a resistance. Also, if you are not using a filter, the dust can go into the patient lungs also. Okay, there are protection mechanisms within the canister, there are filters, but if you sometimes overfill it, there are possibilities the dust can go into even patient lungs also. So better now, when you are filling also, remove all the dust. Definitely there will be some amount of dust in every soda lime, but remove the dust and fill only that granules. You have seen soda lime, right? Okay, use only that granules. More soda lime, more dust means, you know what happens actually if you are dusty soda lime, the gas cannot penetrate through the soda lime. Because you know your gas come from bottom, goes up, during that time your CO2 is absorbed. But if you are between your granules, if there are a lot of dust, now what will happen? It is obstructing the movement of the gas. So you will not be able to get a proper CO2 absorption if it is too much of dusty soda lime. Again, AGSS sometimes, again we have seen there is a obstruction, there is a exhaust on every machine. Okay, what are the exhaust gas? Because it's a closed system. There is only one way of gas going, there is only one outlet that is behind the machine, that is called the gas outlet. Do not obstruct that port, because if you obstruct that port, now the patient will not be able to exhale. You are delivering a gas, just imagine you are taking a gas, you are holding it, you are not able to exhale it. What will happen to you? You understand right now? So if you are obstructing the AGSS outlet, it is as good as you are stopping the exhalation of the patient. Okay. So please, I think this is on the back side of the machine. So for example, I can show you that. So this is a port. Can you see this is a port? Okay. There will be a port like that, and it will be written here, AGSS is no obstruction. So please ensure now this is not obstructed. Okay. Okay. Then of course cleaning, you need to use a proper cleaning agents. Do not use any floor cleaners or high chemical content for cleaning the anesthesia machine, which can create rusting or other things and all. Use a mild alcohol, maybe up to 70% maximum. Okay. I think I'm done with the presentation. Now if you have any doubt, you can ask any questions. Anything you can ask. Any question? No? Everything is understood? Or nothing understood? Now you can have questions only, if you are not understood fully, maybe you'll have question. If you understood fully, also no question. But if you're not understood, nothing, also no questions. So is there any questions I can address? Probably, if I know, maybe I can address it. Okay. No. That's it. Okay, so thank you very much for the patient listening. It was a very, I can tell you, very fast session, because I used to cover this topic in half day, okay, around 4 hours, something like that. But I could, I had to finish in just probably an hour time. So it was a very, like a super fast, Sorry if I, missed any point. That's why I was telling you, if you had any doubt, if you want me to explain something, you can ask that. But I hope something is, clearly, some message is communicated to you. Yes, sir.
Excuse me.
Yeah.
I'm Dr. Ganapati.
Hi, doctor.
Hi. I'm an
Thank you,
anesthesiologist.
Yeah.
I don't know whether you have covered this particular topic, which it's probably important for the students and the budding OT anesthesia technology students.
Yeah.
The anesthesia workstations that I've used, various anesthesia workstations. I've used Draeger, I've used the SDU care station, I've used BPL, you have top end also, lower end also. I have used the UK machines. I've used many machines. Please remember that all these anesthesia machines are calibrated to work at sea level. Probably I have come across only BPL machine in which there is a calibration for height also, that is altitude. I have not come across that particular feature in any other machine. Your machine only I have seen that while calibrating and doing the chucking of the machine, when doing the whole process, there is one step where we can calibrate the machine to a particular height. Usually it is set to 100 meters at above sea level is where we usually calibrate it. It's important that what we calibrate, the machine that we use here at sea level, if you take it to, let's say you take it to Rotang Pass or you take it to the highest motorable road, some hospital in some high altitude, it won't work. It will not work. It will not give the same amount of oxygen. It will not give the same amount of nitrous or air, or it will not give the same amount of even vaporizer. They all are calibrated at sea level. Please make sure wherever you go, if you're working in a high altitude, make sure that machine is calibrated to that altitude. BPL machine is the only one which has that particular advantage where you can calibrate the machine to work at that level. Even the torpid tube, I don't know whether it's covered. I've come across where people, when repairing these machines, have switched torpid tubes. Everything is in liters. It is not marked there, whether it's for oxygen or whether it's for nitrous or oxygen. Please remember, the torpid tube is meant for a specific agent. It is agent specific. The torpid tube which is meant for oxygen cannot be used for nitrous oxide, and the torpid tube that is meant for nitrous cannot be used for air or other way around. So please remember, all these are agent specific. Whatever we have in the anesthesia workstation, these are agent specific. And those of you who lived through COVID, remember, anesthesia workstation is also a ventilator. That's why today we have these excellent anesthesia workstations. We're working in a hospital, they're running short of ventilator. Just pull out an anesthesia workstation, use it as a ventilator. It's the easiest access to a ventilator that you can have is an anesthesia workstation. Today's modern anesthesia workstation, BPL is one of them. Many of these can be an ICU ventilator as well. During COVID, last COVID, I've used 4 anesthesia workstations as ventilators in the ICU. I've even used them in the ward. You just need oxygen and air and a good anesthesia workstation. So please remember this, wherever you come across one more calamity like that, remember you can contribute to the ventilator part by using your anesthesia workstation. Thank you.
Okay. Thank you, sir. Actually, it's a valid point doctor has raised. Whenever the altitude changes, your measurements, like especially pressure measurements, changes. So what we do, actually, whichever machine is not having this facility, like in our machine, there is no need for any calibration. You just set the height, it will automatically calibrate at that height. But other machines, if it's going to maybe, like for example, Leh, Ladakh kind of place, they need to calibrate that sensor at that pressure level. So it's a easier process. But in our machine, it's not required. It varies from manufacturer to manufacturer. It is a job which will be taken care by the manufacturing company. And as you mentioned, the agent specific, I explained different agents because sevoflurane vaporizer is calibrated for sevoflurane only. You cannot use it, an isoflurane into sevoflurane. It might deliver, but the accuracy may not be guaranteed. So those things I have covered. This altitude, I have not gone into that in depth actually because I covered only the basic part of it. To understand, how this machine actually works on a real-time situation. Because if you know the flow of how the gas from this place to this place and this place, probably when you're running the machine, something goes wrong, it will be easy for you to understand where exactly the problem is. So that way, I used this presentation for my engineer, which is used to be a 4-hour session, but I got only 1 hour, so I was a little faster also. But any doubt, definitely I will be happy to answer. And thanks, doctor, for bringing this topic.
Drive gas?
No, I did not. Do you want me to cover?
I'll just explain briefly, then you can cover it up. Always remember, any anesthesia workstation, there is a bellow, and the bellow is moving up and down. If you see, there are 2 kinds of bellows, the movement of the bellow. One is electrically operated bellow, and other one is gas-driven bellow. I'm sure he will be able to give better explanation of this than me. Remember, electrically operated bellows will work irrespective of whether there is gas flow into the chamber inside of which that bellow is situated. If you look at Draeger, that is, they have Draeger, Fabius and all have electrically operated bellow. So it doesn't require any additional drive gas. Remember, drive gas. Drive gas means that it can be, usually all these anesthesia workstations come with a drive gas, which is, they use oxygen as a drive gas. So supposing, let's say you kept 500 ml tidal volume to a patient with the respiratory rate of 15, apart from that much oxygen going into the patient, inside the bellow, equal amount of oxygen is used outside of the bellow to push the bellow down. The bellow will go up with the tidal volume of the patient, that is inspiratory flow, and the bellow is being pushed down by an additional equal amount of oxygen that is equivalent to the tidal volume. There are machines in which you can use oxygen only as drive gas, or there are machines in which you can use air from a compressor as drive gases. The advantage of using air is that you can save on the price of oxygen, but there is a disadvantage of using air. If the bellow develops a hole, there can be mixture of the air with the oxygen nitrous mixture, and patient can get hypoxic flows. Patient can get much less oxygen that we have kept. That's one. Electrically operated bellows are much safer from all this, and they don't need drive gas. So always remember that part of the amount of oxygen that is used for drive gas, we consider it as wasted ventilation. So that adds to the cost of the anesthesia workstation. That much oxygen is actually being wasted, so it is called wasted ventilation. This works even in the ventilators also. That's one thing which you should always remember. Bellows, of course, we have descending bellow, ascending bellows, and there are bellows which have very small diameter and bellows with larger diameter. Larger diameter bellows are ideal for adults, but smaller diameter bellows are ideal for pediatric patients. There are anesthesia workstations in which, supposing you're shifting from an adult to a pediatric patient, they say you need to change the bellows and the chamber for the bellows, because if the diameter is small, then the displacement can be seen. If the diameter of the bellow is large, you keep a tidal volume of 100 ml or 150 ml, the displacement won't be seen at all. You may think patient is not getting ventilated, but patient is getting ventilated. But if you use a smaller bellow, smaller diameter chamber, then you can see the
Exactly.
You can see the
That's what now you can see. There's a graduation on this bellow bottle, starting from 300, 600, it goes up to 1500. As doctor was telling, if it is a smaller volume, you will not see any movement of this bellow, because movement of the bellow is an indication of ventilation. Because you know how much that bellow is drifted or deflected, that corresponds to approximately the tidal volume. So this is, you know, in bellow drone system, this is called an ascending bellow. When I say ascending bellow, during expiration, the bellow will goes up. Descending bellow is just opposite. Okay. So this bellow, if you just keep it ulta, that becomes a descending bellow. But descending bellow technology is nowadays not being practiced because of some safety issues. So all the anesthesia machines currently available in the market, all these machines are with ascending bellow. And doctor also tell another point, actually this mechanism of ventilation, I mean how you push the gas into the, I was explaining in the beginning, how you push the gas, you need a force. That force can be anything. It can be a drive gas, the gas force. It can be a turbine, like a fan running inside the machine, or it can be, as doctor said, it can be a piston also. Okay, there are a lot of technologies available. So always there is a debate going on which is better, okay, but my products are always with bellow. As doctor said, no, this bellow actually consumes gas, actually, because it's almost equal to 1 minute volume, we usually say. Like depending on the breath rate and tidal volume, suppose we are setting 500 ml tidal volume and 10, like almost 5 liters per minute, actually 5 liters per minute oxygen is wasted. So whereas in piston system, you are actually driving because of the electrical force, actually, because there is always, you know, an energy required, no, to generate a force. We have all learned in our school days, like, no, energy neither can be created nor can be destroyed. It can be only transformed from one form to other form. So what we are doing, the force what is needed for an anesthesia machine which is having a bellow system, you are using the force of the gas. Whereas in the piston system, it is using the electricity, that energy which is converted to the force, actually. So we have a electricity consumption there. Whereas here there is no electricity consumption. So it is like a balancing of this thing. We are losing oxygen, probably more oxygen, whereas in other machine you will be using more of electricity. So in either way, if you really look at the overall costing, probably, you know, if you look at the cost of oxygen plus the cost of electricity, maybe it will become almost same. That's the one thing, okay? And one more thing, if you are using an air-assist driving gas, yes, definitely it is a better option. You will not have the oxygen consumption also, but there is a risk of, if the bellow ruptures, your driving gas can mix with your fresh gas, your FiO2 level can go down. But most modern anesthesia machines have this FiO2 monitor. It will immediately warn the user there is a hypoxia situation being created, oxygen level is going down. You can see it on the anesthesia machine screens itself actually.
As a last point, I would like to add that, remember the routine anesthesia workstations that you see in whichever theatre you are working will not have scavenging system.
Yeah,
so in case you need to add scavenging system, that is an additional part which they have to connect. They have shown that. That's a scavenging. I hope you have covered that.
I covered it. Yes.
You covered. So it's
I
very
explained
important.
what are the risks actually if you're having, if you're not having scavenging also.
I'm sure slowly people will be aware. In our hospital, we have installed scavenging system in all the theatres. It is to protect us. It's very important we protect ourselves from these volatile anesthetics and nitrous oxide, which can give rise to long-term health hazards. So it's important that we protect. Slowly, wherever you're working, ask them slowly, can we add scavenging system? It's probably more important even for the girls during pregnancy to avoid exposure to volatile anesthetics. That slowly you need to convince the theatre people, the managements to add scavenging to the theatre and make sure the scavenging system is provided with the anesthesia workstations that you're working with.
Yeah, I just want to add one more point here. The scavenging system, the output, what you are getting, whatever the exhaust gas coming out of anesthesia machine, purely depends on how much you are delivering. See, the more you deliver, the more gases will come out. Like for example, when you are, there are a lot of practices followed in anesthesia, low flow, high flow, medium flow. If you are using a low flow anesthesia, just less than your minute volume, probably the kind of exhaust what you are getting from the machine will be a little less actually. But if you are using a high flow, you will get more waste coming out, which will be more dangerous actually. So it is almost, it also depends on the practice, like low flow, high flow or medium flow. Most of the modern anesthesia machines are actually low flow capable. That means you can use 1 liter flow. So 1 liter is actually less than your minute volume. Like if you are ventilating an adult patient, 5 liters is the minute volume, you are delivering only 1 liter. So it's actually less than the minute volume itself. So you will be having less of wastage. But if you increase the flow to 5 liters or 6 liters, you will have more gases coming out. That's it. It's as simple as that. It's like, a reservoir, you are adding something, something should come out. You have fixed volume, for example, 5 liters. You add 100 from there, now the 100 will go out. It's as simple as that. So the more you deliver, the more will come out. It's very simple, So something will be consumed by the patient, the rest has to come out of the machine itself. So low flow anesthesia will be very useful in this application. But it is always safe to use an anesthesia scavenging system. I have not seen it more than 90% of the hospitals. Good that now you are following it, sir, actually, because at least you are taking care of the safety of the patients as well as your staffs also. But never, not even seen in corporate hospitals. Yeah. It's costing, sir. It's almost a lakh rupees, it's expensive also. You need to also have an AHS system installed in your hospital.
Yeah, the AHS, that component of the AHS, where it has to catch where we have the drive gas. Again, it requires compressed air to come through. We make use of the Venturi phenomena, Venturi principle.
Okay, yeah.
And that you need the same compressed air that we use for ventilators. We need that. We need to have that. And to scavenge that port, that one port alone costs about, I think, 1,50,000 rupees to connect it.
Yeah.
Probably the cost factor which is preventing many,
exactly.
And probably awareness. Many are not aware that scavenging is required. If you go abroad, veterinary hospitals have scavenging system. So that is why I thought we should be better than the veterinary hospitals abroad. That's why I've installed a scavenging system in my theatres.
Yes, yes. It is mandatory, sir, actually. But not much bothered about this aspect. I am seeing it now, very less. Because I can say, from my sales itself, I can understand only 5% of total sale is with AGSs. Rest everything, 90% is without AGS only. So that is actually required. One more thing, I can tell you one more crude method many hospitals are using. What they will do, that AGS outlet is there. From that, they will connect a tube and just keep it outside the OT. Very risky actually. Very, very risky because, the patient is exhaling. Suppose somebody is standing on that tube, the patient will not be able to exhale, it will create an autopeep also. So I've seen that also.
Yeah, I've seen that happen too.
Yeah.
Before I installed scavenging, I was doing that. I had put a tube and I keeping it outside the theatre door and things like that. And I realized one day one of the technicians has pushed the machine itself on the tube. Tube was blocked and the patient was getting high pressure.
Patient will not be able to exhale.
Yes.
And finally, when the pressure builds, you have been exhalation valve opens, but by the time the pressure would have gone to almost 70, 80 centimeter, that level. So it is risky also. Okay, so I think, thank you doctor for giving those insights as well. I really opened a different discussion as well, really good. So thank you very much for the patient listening. I'm sorry I've taken a lot of time, lunch time actually. Okay, so all the very best, okay, do well. And take care of your machines, I'm telling you, it's very important. These machines are critical care, life-saving equipment. Please handle it very carefully, okay? You have to treat like your own babies or your family members. And any machine, I'm telling you, which is investing, 10 lakhs, 20 lakhs, 30 lakhs, it's a big investment for the hospital. So, handling that machine, and also the proper testing, pre-use testing, everything is very important for a patient's safety also. So, cleaning, everything is very, very important. So, it's a huge investment. So, you will be playing a key role because you will be mostly operating those machines. So, your role is very important to have a long-lasting, life of this machine, because every machine will have at least 10 to 15 years of life. But if it is not handled, within 7 years or 6 years, you will have to replace the machine also. So, with that, let me conclude my session. Thank you very much once again. Okay, right. Yes, sir.
My thank you to Dr. Ganapathy P. Sir. It was a pleasure to have you with us. I extend a big thanks to CB Pradesh Sir. Thank you so much for taking the time to speak at our event. Your insights and perspective were truly valuable. Now I request Dr. Ganapathy P. Sir to hand over a token of love and respect. The last session of AHSCON 2K24, that is Basics of Laparoscopy Instruments by Dr. Rahul Pandey. Dr. Rahul Pandey, Course Director, RK School of Endo Skills. He is a renowned laparoscopic surgeon with immense passion and great experience in providing training. He completed his education from Nepal Medical College under Kathmandu University in Kathmandu, Nepal. After his training in laparoscopy, he has dedicated his entire time and efforts in teaching laparoscopy to aspiring surgeons, gynecologists, and assistants. He has been providing laparoscopy training to doctors from different countries over the last 8 years, and he is a proud trainer of more than 1,000 doctors through different training programs. Currently, he is providing training through RK School of Endo Skills as the Chief of Training Program and Course Director. I extend a warm welcome to you, sir.
Thank you. Thank you so much.
Over to you, sir.
Good afternoon, all of you. So I was here last year, but I don't know if you all were the same or things have changed or we all are here again back. The thing is, like, I'm sorry for the post-lunch session can be boring after your good meal and all, but I'll try to make it interesting and will help you out in understanding this a very complicated thing, I say, when it comes to minimal access surgery or laparoscopic. My sound is clear, right? You can hear me, you can okay. Now, I have been running a training center where I mainly train surgeons and gynecologists who wants to know laparoscopic, right? Who wants to learn laparoscopic, but it's that the difficult part is that they don't have a trained assistant. How much I train them, how much I do for them, it's like we run a 10, 15 days, 20 days courses for them after they completed their masters, okay? Not like undergraduate or anything. But also the difficult part they have if you see a laparoscopic thing, it's totally technical, right? And as I have been here last time also, and we discussed a lot about many things, the things that you need to learn as a OT technician and anesthesia staff or nursing is, you trust me, the surgeon or a gynecologist will 50 to 80% will be dependent upon you. After you complete your training, you join somewhere. I don't know how many people are from Mangalore or the nearby area or wherever. Mangalore is a hub of hospitals, and personally I go around 4 to 5 hospitals every day or in a week. Yesterday I had a case in a SCS hospital that is in Mangalore. This system are too standard, okay, very high quality, and you trust me, none of the surgeons know how to operate that. The training, the OT technician there is really good. So what I'm trying to say here, whatever the conference or the workshop that Mangala has organized, you have to use maximum to you. Like, because a lot of people learn on their own, but that learning curve is really, really high. High in sense, it will take a lot of time to understand if you don't learn under professionals. Right? You will, when you, like suppose you have graduated from here, or you start your OT technician practice or nursing practice, or you are an OT nurse or OT technician. For 6 months or a year or more than that, you will be lost what it is happening, first of all. Second, the whole set, in open surgery, you don't have a lot of range of instruments. You know 5 or 6, the job is done. But in lab, it's not like that. And trust me, your hospital management will, like they will feel you should know about the laparoscopic instrument in a very good way. If you're not able to, you'll keep on hiding when the surgery is happening. You will be totally dependent upon your chief to do that. So I'm here to easy that scenario so that you don't get scared of the term laparoscopy, neither you get scared of seeing all the laparoscopic instrument. Right? So we'll start with our session. First, I need to introduce you to this thing. This is what we call as a laparoscopic tower. I'm here for the laparoscopic instrument, but let us discuss this also. Here, if you see here, first let us understand what is laparoscopy. In simple way, what I say is, it's not a real surgery. In open surgery, what you do, you open up the abdomen or you open up the things and you feel the real tissue. You are dealing on the human body and you are holding that. But here, whatever you are seeing on the screen. What we call as not a real surgery, we call it as a virtual surgery. Now, if anything goes wrong here, none of the surgeon will be blamed. Because they think it's a part of the OT technician to maintain all the tower system that you see here. Let it be the monitor that stand on that at the top, or the camera system, this one, or the light source, or the energy cautery machine, or insufflator, whatever. Like this all are whole thing to be learned, but at least you should have an idea of it. A basic idea of it, what the laparoscopic tower contains. So again, I'm repeating here, this is a monitor where you see and do the surgery. This is going to be your camera, which will be connected to a telescope and which will go inside the body with all the instrument that is needed. Again, inside the body, you don't have any light. That's all closed. So what you do, you have to have a light source. Right? After that, normally you can't just put can you see the length of this instrument? This instrument get inside the body. Understand this. This instrument get inside the body. Now imagine if I'm going through and through, will it not go and pierce and come out? Is it possible to directly put this inside the body? No. So how you do this? Have you seen an open instrument? If any open instrument is there, I think you must have been doing suturing. It's just this length. It doesn't go inside the body. But imagine this instrument going inside it will come and pierce and come out. So how do you do that? There's something called as this one, insufflator. This one. What does that insufflator do? It pumps your abdomen. Means it will put the gas inside it and it will get pumped, and then you'll have a space of walking it. Right? So I'm just trying to say that you need to have an idea of this. A great idea of what the, if you're interested in minimal access part. And trust me, it's a high demanding thing. Mainly in the places like a Mangaluru, where you have 8 to 9 medical colleges in and around the Mangaluru area. Right? And this should be like, if you know it, you'll have a really easy job happening. And trust me, surgeon will not start the surgery till you are not there in this theater. They'll wait for you. And I coming from north, I have seen OT technician doing what you know. They'll have that whole tower under the van, and they go from places to places, and they conduct the surgery for the surgeons and the gynecologists. They do that also. Right? But let us not go in that deep. We'll start with the important things that we are here for. Laparoscopic instrument. Before that, again, a small basic of laparoscopic that you all need to understand is, which is mainly important from the, what we call as the OT technician point of view, is a basic of laparoscopic, just to understand two things, not the much, just the two things. All our others are for the surgeons, but this is for you all, okay? We something called as a coaxial alignment. Means, as I told you, the laparoscopic tower, right, it's away from the patient side. Suppose this is the patient table and the patient is lying here. Laparoscopic tower will be something here. Right? It will not be attached to the patient. Now, what important is that when a surgeons operate, when I'm talking to you, am I talking like this? No, what I'm doing, I'm seeing you, my laptop is there and I'm seeing you. Means what I'm seeing, I'm in a coaxial alignment to you. I'm in a coaxial alignment to you. If I do this and start talking for half an hour, my neck will start paining. Correct? I can't turn like this and talk to you. I should be straight. It should be straight. This is what we call as a coaxial alignment. Now, why this is important for you? Because see, what I'm trying to say, if that tower is like, if the tower is not there and if it is here, the surgeon will have to turn their head like this and do the surgery, which is not possible. Right? So you should understand that thing and you need to replicate that. Means you need to understand where the laparoscopic tower should stand, which surgery is being performed, how to set the OT table for that, how to set the instrument table for that, what are the instruments that are needed for certain surgeries, because every surgery doesn't require all the set of instruments that you see in front of me. Right? After that, how far should this tower be from you or from the surgeon? Suppose again this is the OT table, how far it should be? It should always be 5 times the distance of the monitor. 5 times the distance of the monitor. Like if, like in your home, what is the size of the TV that you use? Like we heard, it's like 32 inch, 42 inch, 55 inch, 65 inch, right? Now, when you see that, what does that inches mean? How is that measured? Normally, nothing is measured like this. Like if you see it, the measurement doesn't happen, if this is the monitor, it doesn't happen from here to here. Means it goes diagonally. You can go and check if your company is saying 32, you measure from here to here, it will not work. You measure from this end to this end, it's not going to be 32 inch. It's going to be 32 inch from here to here. Means the diagonal length. Now, if normally, let us take any advanced laparoscopic set like Storz, Stryker, Olympus, it goes around 26 inch monitor. So how far that monitor should be from the surgeon? Simple, 26 into 5. That's the distance. Because when you do that, what you see, you just see the monitor. You don't see the ceilings, you don't see the, what we say, the floor and all that. You will just be focused on the monitor. That's why when you book a ticket also during a movie session, what do? Do you take the front seat? When you book a ticket, do you take the front seat? No. Why? Because if you take that screen will be too big for you. Am I correct? When you book a ticket in front seat, the screen will be too, if I stand there and ask you to see that monitor, it will be too big for you. Same way when someone is at back of that chair, can they see the screen very clearly? So normally if you measure this will be 5 times where you all are sitting, around roughly. That's why don't we have a chair here? It would have been much easier to see, right? But just measure that distance and measure this distance, you are easily able to see very clearly. The adjustment is that good. Same happens to the laparoscopic tower also. Again, I am saying it. Laparoscopic is not a real surgery. It's a virtual surgery. You are seeing the screen and doing it. And that is where the engineering, the technical part and all other comes in practice, right? So this was just an important thing to start off with, right? Now, let us go to the individual instrument. Like every instrument that you see in laparoscopy, it's either disposable or reusable. In open surgery, maximum time you will have a reusable instrument. The importance that you need to understand what is different between a disposable instrument and a reusable instrument is, reusable instrument can be reused. Why? Because they can be disassembled or they can be washed. They can be cleaned, they can be sterilized. If that is not happening, you can't say that's a reusable instrument. It's very, very important. If you see here, this is what we call as a disposable instrument. I'll tell the name and all afterwards. And this is what we call as a reusable. So, rich use this. Means the hospital which are very rich, they'll use disposable. They will use it. Can you use a syringe second time? No. What do? You throw that, right? So, same way. You use this and throw this. Poor people use this reusable. What they do, they use it, they clean it, they again reuse it. Very poor use this again and again, which is not good. From the patient point also, from the surgeon point also. We should not be using any disposable instrument twice because they have made it that way. Is that okay? Now, coming mainly to the instrument part again. Understanding the things. For any instrument, I'm just talking about any instrument, let it be laparoscopic open. What are the things that you need to understand in an instrument? First thing is always the name of the instrument. What is the name of the instrument? Second, use of the instrument. Use of why it is there. What is the use of that instrument? So that when your surgeon asks you for that, you are ready with that. The third is it a disposable or a reusable? And if it is a reusable instrument, how can I clean that? Because again, the major part comes to you all only. I'm not talking about a proper run medical college, but you are at a clinic setup or a small level hospital setup. They want you to know the instrument. They want you to know how to clean that instrument. They want how to OT table or the OT instrument is arranged. They all are important for you, right? So name, use, how to assemble and deassemble a laparoscopic instrument, and is there any alternative use of that instrument or not? Or if that is not there, can I offer my surgeons any other instrument or not? That's our important thing to be learned, right? So we'll start with a very small instrument called by the name of Veress needle. Called by the name of Veress needle. Can you see here? This one. Right? This one. This is what we call as Veress needle. Now, do you all know the name now? So you can recognize this, right? This will be your Veress needle. What is the use of it? As I told you at the first only, when you do a laparoscopic surgery, the first thing that you need to understand is how does the abdomen get inflated so that you can put your instrument, put your telescope, camera inside and do the surgery. This is one of the instruments through which the gas goes inside. Laparoscopic surgery is done when abdomen is inflated with the gas. You get a good dome of the abdomen and then you put ports and other things, then you start with this. This is varus needle. Now, it comes in different length. It comes in length of 8 centimeter, 12 centimeter, 15 centimeter and 20 centimeter. 4 length of this instrument. 8, 12, 15 and 20. Right? Now, can you analyze why that length is there? Anyone? Why that length? 8 is for smaller babies, pediatric patient, less than 8, 10 years. 12 centimeter is for adult patient like us. 15 centimeter is for bigger patient, big patient. 20 centimeter like morbid obese what we call, whose BMI is more than 40 because, sorry, abdomen. I hope we know the skin layers and thing. Let us see this way. What you see in my hand, we consider this as an abdomen. As an abdomen. Okay? So this is the skin or the umbilicus area, you can say. Skin or the umbilicus area. This is the layer of the abdomen and this is what we call as a peritoneum. It is inside the abdomen. This one. Now you imagine if this varus needle is small, what will happen? It will just go and be stuck here. This can't go inside. That's why you need to understand, like if a surgeon is performing a bariatric surgery, will you give him or her with a 8 centimeter varus needle? No. You have to give them 50 to 20 centimeter length of the varus needle. Is that okay? Get the concept of the length because this is the first thing that goes inside. When the surgeon is performing, this will be the first thing that surgeon will ask you for. They will ask, when they start the surgery, when the draping and all is done, we have cleaned the patient, the drip is put on. Now we are starting the surgery. If the surgeon is performing a laparoscopic surgery, this varus needle will be the first thing that they will ask you. You need to have this at your OT table. Again, deciding the size, which size of the patient it is, not depending on the age, it's on the size. If the patient is smaller, bigger, huger, or what we call as a morbid obese, this is what we call as a varus needle. After that, so now suppose this is the abdomen, surgeon has gone this way and all that, right? Now, does the blood touch here or the tissue comes here? Yes. So now, is it a disposable or reusable instrument by seeing it? What do you think? Reusable. So after surgery is done, will we throw this? So you need to clean it, right? Now, how to clean it? How to clean this? If you direct put it here, it has already. Now you need to learn how it get disassembled. It goes open like this. The thing on my left hand is called as a needle. The thing on my right hand is called as a stylet. Stylet. See here, can you see an eye on this stylet, this one? Can you see that? Did you see this one, this opening here, where my finger is pointing? Can everyone appreciate this? Now, why is that eye there? What is going through this varus needle? Gas. Am I correct? To fill up the abdomen. You need to understand that. When a laparoscopic surgery is done, abdomen should be filled with the gas. Your abdomen should act like a balloon. Okay, now, when first surgery was done, if you don't know how to open this, and if you don't clean this, will the gas pass next time from here? No. Surgeon will have a tough time. As soon as he's done with the surgery, he'll blame you. He'll shout you like anything. Can be his mistake, but it's always the OT technician that gets the blame, or the nurses, or the scrub nurse. Please make sure that this is patent. The fluid or the gas passes through this eye. Nothing is there, it's clean. The blood drops are not there, the clots are not there, the tissues are not there. This is what we call as a study. The whole thing happens from here. So how you check it? You take a syringe just before the surgery, pass it through it. If the fluid is coming out in a good way, this is what we call as a patent. This is patent. Another thing comes here is a spring. Spring here. Now, again imagine something, okay? A small thing, when you are attending a kind of workshop, after the workshop, you should have a concept what was taught and why it was taught. It should not like you just tell the things, go back, nothing is happening. No. See, what is happening here? What did I show you? I show you a stylet and a needle. Now see very closely here, okay? When this is getting inside the abdomen, what is happening is, the stylet is going back, and what is coming in front? Needle. You got this point? See here, a stylet is going back and the needle is coming in front, correct? Why do you think, why is that mechanism happening? Can you hear this sound? This is because you have a spring there. Am I correct? You have a spring there, that's why this mechanism is happening. This way. Now you imagine, if the spring is not working, what will happen? This will go back, but it will not come. Am I correct? If that spring is not working. Now you imagine, as I told you, what is this again? Can you repeat with me? What was this? Skin. What was this? Abdominal layers. And what was this? Inside the abdomen. So just inside the abdomen, what will be here? I can't hear you. Intestine? Bowel? If I'm going through the umbilicus, what will be here? Inside the abdomen? Organs? Right? Now you imagine, if this is pointed like this, and it touches inside, what will happen? Will that organ get damaged? What does the rule says is, when you are piercing it, it should be pointed. As soon as it is out, again the blunt part should be out. Got my point? What I am trying to say is, the stylet or the blunt part should always be out. The needle should only be out when I am just piercing it. It should not be after piercing. It should come back. It should come back, so that if it touches anything inside also, see, nothing is happening to my hand because the blunt part is out. If I do like this, I will not do. It will hurt. Got the concept? That's why two things you need to check in a varus needle is this needle patent or not? Is the cleaning done properly or not? The second will be, is the spring action. See, you just do this and you see the movement. Is it coming quickly or not? If this is not there, change the thing. Ask the management to change the instrument. This can be lethal to the surgeons also, to the patient also. Because if this needle pierces the viscera or the organ, both the surgeon and patient will have a hard time. Surgeon will never check for the instrument, trust me. How big the surgeon is, if they haven't had a proper laparoscopic training, they just believe you formally. And a person like me, what do? They're doing freelancing. I'm not confined to a single hospital. Today I'm working in Mangalore, the next day I'll be in Kasaragod, the next day I'll be in Kannur. So I don't know the technician there, I trust them. right? So it's your job to take care of the instrument. Okay with this Veress needle? Anything you want to ask about it? Can be a new instrument, but you need to learn this. If you're planning for a laparoscopic thing, you have to understand the instrument, right? So Veress needle, right? After this comes this one, ports. Now you can ask the question like, the Veress needle has been done, how does this instrument goes inside? Or how does it works? It's always about passing through the port. Right? Normally, what do you understand by port? Normally, a port means a place from where you can come in or come out. Like airport, like seaport or the port, P-O-R-T, port. Same thing is this one. We call it as a port. Individually, when you separate this, this becomes cannula and this becomes trocar. This becomes cannula, this becomes trocar. Combination, we call it as a port. Talking about the size, it has the same size of Veress needle. Same size of Veress needle, but diameter. The diameter of this instrument is different. So if anyone asks you, like when you are doing a surgery, your surgeon will ask for 5 mm port, 10 mm port, like that. So what are the ranges of that port? Very commonly used is 5 mm port. So you have a 5 mm port, or again you can call it cannula, trocar, whatever, but you have to understand. Cannula, trocar, port. But 5 mm port, 10 mm port, 12 mm port and 15 mm. So if you see here, this is your 5 mm port. Okay, you can differentiate the size, okay. This is your 10 mm port. Then you have a 12 mm port. And this is your 15 mm port. You have different sizes of the port. Now you can ask me, what are used for 5 mm? What are used for 10 mm? What are used for 12 mm and why 15 mm? All the instruments that you see here, these all are 5 mm instrument. So definitely this can't go through 10 mm. It should go with a 5 mm port. So 5 mm ports are mainly used for instrumentation. Instrumentation. 10 mm port, how many of you have heard of telescope? Can I raise your hand? How many of you have seen or heard of telescope? Telescope is a thing that goes inside the human body and you can see the thing on the monitor. I'll show you a video of that. Let me complete with the port and then. Is that okay? So your 10 mm port are for telescoping. Right? You have to have a telescope that goes inside the human body and that will reflect the image on the monitor. So 10 mm ports are for what we call as telescope or any other bigger instrument like this. This all are 10 mm instrument. You can differentiate the size. See? So can this go with 5 mm port? No, it will not fit. Right? So you need to have a 10 mm port for this. 12 mm ports are again now, suppose you have been into this lap surgery for like 2-3 years. Your surgeon has now decided to start a bariatric surgeries, like a surgery where you lose fat and weight. For that, a very important instrument is what we call as a endo-GI stapler. Endo-GI stapler. This stapler will never go from 10 mm or 5 mm port. You have to have a 12 mm port, which is this one. I can just show you here. Right? Everyone can see from here, right? If I do this way also, you can see, or you want in a monitor. Monitor or monitor. Right? So if you see here, This is 10 mm port, and see, it will not go. Can you see here? This is not going through the port. So you need to have a 12 mm port. Now see here, it will easily go. So your 12 mm port are used for endo-GI stapler. Endo-GI stapler. Same way, this 15 mm port are used for one thing that is called as morcellator. Heard of fibroid surgery? For the female patient who are not able to conceive or having an infertility problem, or later on also in the life, if you are learning about fibroid surgery, the fibroid have to come out, the uterus have to be preserved. So how do you take a fibroid out? For that you have another instrument called as a morcellator. That morcellator only goes with what we call as a 15 mm port. Right? You can't use any other port for that. Is it clear with this one? Clear with the size of the, not the length, but the size, diameter of the port. Okay with this one? Clear with all that 4 things? Now one exception you have to take care is of a 7 mm. 7 mm, because there's one instrument which gynec use very frequently, and that instrument size, see, as I told you, what do you mean by port? A place from where you can come in and go out. What is coming in and go out? The instruments. So whatever the company has made the instrument, same way you have to go for that. You have to depend on the same thing. Right? So if they are giving you 10 mm instrument, you have to go through the 10 mm. If they are giving you a 5 mm instrument, you have to go through a 5 mm port. I don't know why the company has made a fallope ring applicator, which is done for tubal ligation surgery. It's 7 mm. This one. This is used for tubal ligation, like in Kasaragod area, Kerala, every month you have a camp where a gynec do a camp for like 100-200 patients in 2-3 days. They use this instrument, what we call as a fallope ring applicator. This fallope ring applicator, the diameter is 7 mm. So it can't go through 10 mm. Why it can't go through 10 mm? Again, when you do a laparoscopic, what you put inside the abdomen at the first? What did I tell? What should go inside the abdomen of, and why it will act like a balloon? What is inside? Gas. What is the size of this port? 10 mm. What is the size of this instrument that I discussed just now? 7 mm. So if I'm taking this instrument through this, what is the gap? Gap of 3 mm. So what is inside the abdomen? So what will happen here? It will have a leakage. That's why you can't directly put this inside a 5 mm or 10 mm. 5 mm it won't go only. 10 mm if you put, what will happen? Gas will leak. So if gas leak, what will happen? Will you be able to see on the monitor? No, abdomen will collapse. To perform a proper laparoscopic surgery, a good amount of gas should be inside the abdomen. Very important. So you have one more addition port that we call as a 7 mm port. It looks same, but you need to understand it. So, like what are the size that we discussed? 5, 7, 10, 12 and 15. That you should be very thoroughly. One more I'll add. If a pediatric surgeon is walking with you, he can demand of 3 mm port. Again, the pediatric abdomen is too small. So just at the side you can write 3 mm port for pediatric surgery. Otherwise you hardly use it. You hardly use it. Is it okay? Clear with the size of the port? See, they will definitely ask you. What they do when the surgery starts, surgeon will say, I need 5 mm port, like 3 5 mm port, 1 10 mm port. You need to recognize it first. Second thing will be, you need to understand why he is asking that. You need to tell if the surgeon is planning for a tubal ligation surgery, you should have a back of it. I need a 7 mm port. Is that okay? Now, let us again come back to trocar. Okay. So what did I call? What is this? What is this? Trocar? What is this? Cannula. Let us learn this again individually. This trocar is again getting inside the body. You need to understand that. After the varus needle has done, the gas has gone inside, you will put your trocar. Right? You go inside and then this will be acting as your eye. Eye means you will remove this and the telescope that I was saying. Sorry. The telescope will go inside this. And then you can see the things on the monitor. Right? Now, for that, what you have to do, this need to be sharp. So you have different kind of trocar. You have different kind, I'm not touching the cannula, you need to understand this. We are just discussing about trocar. You have the thing on mind, and the very common is pyramidal trocar. If you see here, it's not proper conical or what we call as a triangular. It has a shape and it's very sharp. If I puncture here, it will get through and through my skin. This is what we call as a pyramidal trocar. After that comes a blunt trocar, and another is a safety trocar. Safety trocar. Blunt trocar mainly is done when you don't use a varus needle to inflate the abdomen. It's called an open technique. I'll not cover that, you will get confused with that, but this trocar are also used to get inside the body. Another is what we call as safety trocar. If you see this safety trocar very carefully, it has the same mechanism like a varus needle. If you see here, can you see the blade coming out? Can you see the blade coming out? So when you are pressing it, the blade will come out. When you release, the blade should go inside. So what mechanism is that? Spring mechanism. So if you open and see here, here also you will have a spring. Here you don't have anything. Here you don't have anything. Now, you imagine if this spring is not functional. This spring is not functional, or for any reason it has been damaged, and the whole this blade is inside the abdomen. If it touch anything, the patient will be into deep trouble, and the surgeon will be into more trouble. So it's your job to make sure that your OT environment is maintained. You have to check this. Okay with this one? So 4 type of. One is pyramidal, and in the same form, if you have a very straight conical trocar, blunt trocar and safety trocar. Safety why? Because as soon as the skin is punctured, the blunt part. See, I can easily touch this. I am not getting harm. But can I touch this? No, it will hit a small nick and you will have a bleeding from here. Is it okay? Clear with this? Now, how to clean it and how to understand this. See here. Can you see an opening here? This is called as an eye of the trocar. Eye of the trocar. It's just not there as, it's not there like SE. It's there for a purpose. It's not there that let us make a hole there and leave it there. What is happening here, this eye, can you see the opening here, right? Everyone can see that. This opening is communicating here. If you blow from here, you can feel the air coming out from here. After the session, you can just try that. Now, why is this important? Why did I take a lot of effort to know you this? Again, let us go back. My favorite thing, okay? What is this? Skin. What is this? Layers of the abdomen. What is this? Inside the abdomen. So, first, what did you put inside? Everything has a step, okay? If you follow, it's easy. What do you put first? Varus needle. What do you put inside? Gas. Now, are you able to see on the screen anything like during the surgery, during this thing? No, because you haven't put the camera inside. Am I correct? So can we consider this as a blind? We are going blindly, right? We haven't seen anything till now. Now, the gas is inflated, the abdomen has been inflated. Now what you are doing, you have increased the incision, means the surgeon I am talking, they have screened the incision and now they are going it inside. Now when they are going it inside, how they will know that they are inside? Where to stop? What is here? Gas or bowel? Because this has been put in after what? After varus needle has put in and gas has gone inside, right? So when the gas is there, as soon as this eye will come in contact with the gas, what will happen? Gas will leak from here and you will hear it from here. So as soon as you hear the, what we say that sound of the gas leaking, you will remove this and you will push this. The surgeon will push this. Why I am showing you this is, because I hardly think anyone knows about this. The company people will never give you a tutorial of this. Now if you just imagine, if you don't clean this, this is block. Will that surgeon will get the sound of gas leaking? So what he will do, he will not listen that and he will keep on going inside. Imagine this getting inside the bowel. The surgeon career is gone. Trust me on that. Because this, see, if I get damage with this, it's 90% chance that nothing will happen to the patient. Because it will be like, if I want to repair that also, I have to take a bite. So it's okay. You imagine this shape of the knife piercing your bowel. You have to do what we call as a segmental resection of the bowel. Means you cut that part of the bowel and attach with the other, because that bowel, that part is useless now. Means I'm just trying to not scare you, I'm just trying to say with a small mistake, the career of surgeon can get over. And if he is doing just his second or third laparoscopic surgery, then he will, for 5 years, he will not touch a laparoscopic case. He will not have that, what we say, confidence to do that. Again, I am saying here, these small things in laparoscopic surgery always have a meaning. This is called as an eye of the trocar. It communicates here at the head of the trocar. Am I clear on this one? So when we are cleaning the things, when you are arranging this thing, make sure that this is also clean. You wash it from here, pass the water from here. Is this okay? Clear on this one? Okay. Then comes the cannula part alone. The cannula part alone. Okay? This cannula has two parts. One is what we call as shaft. Shaft. This doesn't have much thing to do. If you can see, you see this part is shining and this is dull. Like you just have to know why it is there, not a major thing. This is shiny, right? Can you see the light is reflecting from here but not from here? This is there because this part is inside the body. And what do we put inside to see? Light. So reflection should not be there. It's for that thing. If someone asks you, in previous time, they used to color like this. Can you see this one? This is inside the body. Why black? Black doesn't reflect light. So if light falls on, so reflection will not be there. In lab surgery, if reflection is there, surgeon will will have a hard time to do the surgery. So black, or nowadays they have done, make it dull. No shiny part. Right? And then we have something called as air inlet. Again, air inlet. Means if this is your major primary port from where the gas is going, this have to be opened so that the gas line is connected here. Otherwise, all other ports should be closed. If it is parallel, this is open, this is closed. Okay, open, closed, open, closed. Okay, so only from where the gas is going inside should be open. All other ports or all other cannula should be closed. If it is open from other side, what will happen? What will leak? Gas will leak. If gas is leaking, what is the major problem? Abdomen will go down, surgeon can't see the vision. So surgeon will be busy in their surgery. It's your job to check this valve opening or closing. Make sure if it is half also, make sure it's all properly 90 degree. Open, closed. Okay with this one? This is about the shaft of the cannula. Then comes the major part, is called as the valve. This is called as the valve of the cannula. Again, like trocar, this valve has different types. This valve that you are seeing here, can you hear the sound? It's working on a rubber mechanism. This is called as a flap valve. This is flap valve. Means it is going down and coming back this way. Flap valve. Then in this kind of instrument or the cannula, you have something called as magnetic valve. Magnetic valve. If you see here, this valve open up. Can you see this one? This is magnet. This is called as a magnetic valve. Magnetic valve. Right? Then in what we call as this disposable cannula, you have this rubber unidirectional or self-dilating valve. This one. Can you see here? This is the valve. Valve of disposable. Then you have a magnetic and a flap. Now, just a question to you all. What do you think this valve does? Any idea? What does this valve does? Again, just have, like, you can use a small thing. Where is this cannula inside? Where is this cannula placed? Sorry to again come with this. It is inside the abdomen. Am I correct? Again, what is filled inside the abdomen? Gas. If that valve is not there to close, what will happen? What will happen? Gas will leak. That's why that valve is there. Let it be any valve. Can you like make it out now? Can you see this one? See. I'm opening the same thing now. Can you see through and through? Gas will leak. So what is preventing the gas to not to leak? This valve. Am I correct? So that's why this valve is important. If this valve is damaged, you can throw away the cannula. You can ask the management to give the new one. Otherwise, I'll get scolding from the surgeon. Now, how to know if that valve is damaged or not? In like maximum place, you will have this kind of cannula only. Nowadays, hardly we have this magnetic valve. Again, if they are using this disposable one, it's fine. But again, how many times they are using, it's matter of concern. Right? Like at the major places, you'll have this kind of cannula only. So what cannula is this? What valve is this? Flap valve. Flap valve. Okay with this one? Now, how you will know that this valve is damaged? Again, can you see this? Like, I'm sorry that both the thing is orange, not this orange. Can you see this orange inside the valve? That's a rubber. Like we have seen that rubber in the pressure cooker, right? The black one. If that is not there, will that cooker is airtight? No, it keeps on leaking or you will not hear that sound. So same way, what happens, if this rubber is damaged, this will not close properly. It will be like half closed. It will be half closed. No one will tell you this, trust me. No one will tell you this. And what will happen now, you will feel that everything is fine, but the gas will keep on leaking. Gas will keep on leaking. Again, one small question to the audience, like a group. What is the gas that goes inside the human body? What you are using? Carbon dioxide? Sure? Okay. Now, you imagine, if gas is leaking, are you putting a lot of carbon dioxide inside the body? Because we have to maintain that pressure. Correct? Advanced question. What do you think, if a lot of carbon dioxide goes inside the body, is it good for the patient? Heart of respiratory acidosis, the patient will go into that, is a secondary or tertiary thing. First of all, have you ever feel that carbon dioxide? Have you ever touched that carbon dioxide? It's cold like anything. Luckily, we have a very good insufflators and all that help you out. But that gas is cold, dry. When it hits the body, the patient can go into hypothermia. That hypothermia can lead to ventricular fibrillation and patient can die on the table itself. I haven't seen, touch wood, I haven't seen a patient dying that way, but I have seen a lot of animal dying that way. When I was in Delhi working for an organization and doing a workshop, we had a permission and we were using a pigs for a laparoscopic workshop, like normally you do with a dead, like a tissue, but there we were using a live pig. What they do, they didn't give us a well-maintained insufflator, they just use a compressed air, like we use for this puncture thing is there, na? That big compressed air is there. Na? We use that. As soon as that gas went inside the body, the pressure was so high that the vena cava, inferior IVC got compressed and the pig was dead in no time. The whole, obviously they performed the surgery, but what I'm trying to say is leaking of gas can be dangerous to the human body like anything, because it's not a normal gas. You are not using compressed room air or oxygen like thing. Carbon dioxide is absorbed by the body in a very good way by the peritoneum, and the patient can have a tough time. Recovery can be difficult and lot of things can happen, like lot of complication happen. Like someday if I get a time, I'll ask the Mangala team to call me for the insufflator thing so that I can explain you that. But trust me, gas leaking is not a good option. So now what I'm trying to say is, this is inside the human body. The valve is damaged, right? Because of what? Because of that rubber. So is this valve closed properly? Is it airtight? So what will happen from here? Gas will keep on leaking. And when the gas leaks, the insufflator will keep on pumping the gas. That is not good for patient, not good for doctors and the team also, because that leak gas will come towards you. Right? So this should not be done. So you have to check the valve like this. Check if this is not closing properly, check the rubber. Replace this or ask the team to replace the cannula. Okay with this one? Then comes another rubber thing, is what we call this. This is called as washer. It is not there to give the color coding. No, color can be anything. But this rubber has a very big role to be played. 5 mm. 5 mm. What was this cannula that I told you? What was the size of this cannula? 5 mm. Correct? Is it still 5 mm? how it is becoming 5 mm is important to be known, okay? Is it still 5 mm? It's going, but this will lead to your gas leak. Can you see the space here? This 5 mm is made by this thing called washer. Washer. So understand one thing very clearly. If your cannula is leaking, if the instrument is not there, it's the fault of this inside valve. Just write it down, okay? Later on you will keep on understanding it. It's a slightly tricky thing to be understood, but just keep it at the back of your head. If surgeon is doing a surgery and this cannula is inside and the surgeon hasn't put any instrument, inside and it is leaking and you check the air inlet and all, it's all good. Then the fault is from the valve side. Okay, now if a surgeon put the instrument inside, again feel when the instrument is getting inside. What it is hitting? Got the concept? See here. When this is going inside, what it is touching and going? What it is touching? I'll take the another instrument, just wait. What it is touching? What is here? Valve. So is it opening this valve and going? Yes. So is that valve open automatically? A simple understanding. This is saying that if it is open, it can't leak. Definitely you have already make it open. So the gas is leaking from here? No. So when the instrument is inside and the gas is leaking, the problem is from here. The washer. What the body is doing, what the thing is happening, this is inside, gas is all around, gas is passing through this, it's passing through the valve, but if the instrument was not there, what was happened to the valve? It would have been closed. But the valve is open, so gas is coming up to here and it is being held by this washer. But if your washer is damaged, what will happen? Gas will leak. So understand one thing. If instrument is there, gas is leaking, change the washer. Change the washer. And you will have, like the company will give you 10-15 pieces of extra of this. Just change it. Like change it. This is intact. I'll show you the damaged one if I have it. I'll just check that. Like it is a rubber thing, it gets cracked actually. It's intact. Otherwise, it's get cracked. Okay with this? Okay with the trocard? Right? Now, let us see how Veress needle is used, how it goes inside and all, right? We'll go with, because again I'm telling you, like except for the proper functional medical college, maximum place, they will be, like they want you to know things rather than the surgeon and the things, right? So if you see here, this is a real patient here. So what we are doing, see nothing is inside, okay? Till the time it's just the beginning of the surgery. So what you do, this is the Veress needle, this is the disposable one actually. So you lift up and this is the Veress needle that goes inside. Right? Here this all is been done by the scrub sister or the OT technician. Right? After that, there's a way to confirm where the Veress needle has landed. You don't have to worry for that. It's a surgeon's job. But you need to know Veress needle, how it is inside and all that. After that, these are the tests that a surgeons do to confirm where the Veress needle has landed. Right? And when it is done, you'll connect the gas. Right? This is the way you take a Veress needle inside. After that, see again the same thing. The abdomen has been inflated by the gas Now, what you are putting? You are putting the trocar. Did I tell the same thing? Trocar and cannula. You are putting the port inside. So here, see, till the time no camera, no laparoscope, no telescope, nothing is intact. So the thing that you have to trust will be that leaking sound of the gas. You go inside. Right? And then you release the trocar, cannula is there, you attach the gas, and then you take the telescope inside. When it is inside, you are safe. The eye is inside. This is the way it's seen inside. And that will reflect on your monitor. That will reflect on your monitor. Is it okay? Clear on this trocar and cannula? Anything that you need to understand? Or you want to ask me? Right? So again, coming back to the basic. These two instruments that we discuss are called as access instrument. Access instrument means the instrument that will help you to get inside the abdomen. Get inside the abdomen. Okay with this one? Now, let us come to the walking instrument that we deal. What are the different types? Surgeon will, like in open surgery also, they keep on saying Caesar, artery, Babcock's, this, that. Same way, you have a lot of what we call as laparoscopic walking instrument. First, let us go to the length of that instrument. Length of that instrument. The length of laparoscopic instrument is 20 centimeter, 28 centimeter, 36 centimeter, and 45. Again, now we can say, now you know the length, right? Why it is 20 and why it is 45. 20 will be for junior pediatric, patient less than 10 years of age. 28 will be senior pediatric. 36 is the same length. Right? 36 is the same length. This is for adult, like us. 45 is for bariatric patient. If you see here, Sunil, वो है क्या? इसका cartridge. Right? What did I tell you? Why was this used? For bariatric patient, right? So if you see here, right, if you measure this very accurately, can you see the length? Is it the same? No, see the difference. This is 36, this is 45. This is for pediatric, 45 centimeter. Okay? Again, same way, in all the instrument, you have this is what? Disposable. This is reusable. Disposable and reusable. Now, let us understand the parts of the instrument. This is laparoscopic instrument of 30. I'm not going which instrument it is. I'm not coming to that point. I'm just generally describing a laparoscopic walking instrument. This what you see here, this is called as handle. Handle. This is handle. This is knob, it's rotate. Knob. This is the cover. This is what we call as a shaft. And this is tip. Again repeating it for, and if you have seen an open surgery being held, because of this this handle, it's held in the same way. Like the thumb goes here and the ring finger here. Thumb here, ring finger here. Handle, knob with the cover, shaft and the tip. Now, this type of handle is called as a shank handle. Shank, S-H-A-N-K, shank handle. This type of handle, see, same laparoscopic instrument. Is it same? Is the handle same? This is called as rod handle. Same laparoscopic instrument. Is the handle same? This is called as axial handle. axial handle. This is called as piston handle. Piston. Piston. Piston, axial, rod, and a shank handle. Okay with the parts of the instrument and the name of the handle of the instrument? Now let us come to the another part. Again, I am not going in a detail of instrument, I will come that later. But let us learn how to assemble and disassemble this instrument. So again, you hold it like this and you rotate this. This opens up. This opens up. And then you can just release the instrument. This is handle, this is your shaft. Now, this shaft can also be taken out. Now, this is called as insulator, this is called as insert. If you are just taking the instrument and putting in the side X like this, you are not disinfecting the instrument. No, you are just making like your duty, you are just completing your duty hour that I called. You have a 6 to 6 duty, at that time the instrument has come to you for the cleaning and you just put it in the water and wash it up. No, it should be deassembled this way, the whole thing. Now again see, this is the instrument, right? This is getting, as you see, like you saw the previous video, right? So now inside that this instrument will go. I'll show you that. Now this is holding, this is cutting, this is grasping, right? So when you are cutting, bloods come, tissue come. Where it is going? Nothing will be seen inside. Where it will go? All thing will go here. Everything will go here. Now, if you are not opening and cleaning it up, are you cleaning the entire thing? Are you cleaning that blood? Are you cleaning that tissue area? No, no. Again, you see here very carefully, you will see a ball and socket joint. Can you see this? This is ball and this is socket. This ball and socket is walking here. Right? Because where it was there only, right? Ball and socket joint. It will come here. Now if you don't clean it properly, the blood will come and get there on that joint. So after 2 or 3 surgeries, what will happen? Will this open? No. Why? Why will that not open? Because you haven't cleaned it. The cleaning is not done properly there. So always open this and do it. Ball and this. Sorry, this is the ball, this is the socket. Sorry. This is the socket. This is the ball. So it goes here and attach here when the insert is taken down. This way. Can you see that? Cleaning should be done after dismantling the, like removing the, disassembling the instrument. It should not be done as a whole. You are not cleaning it. You are just showing your boss that I have cleaned it. Within 4 surgery, is it a disposable or reusable? Reusable means this can go up to till the time it doesn't break. But if you don't know how to clean it, after 5 surgery, this will not work. This will not open only. If it is not opening, what's the use of this instrument? Okay with this one. Now, again a question to you all. How many of you have known about cautery? What it is? Why it is used? This side, no one knows about cautery. Have you heard of cautery? Energy source? You have seen that, right? What does it do? It do cutting, coagulation and all, right? Have you seen in open surgery or any idea you have seen in lap also? Open surgery, how many of you have seen how it was used? In lap? So the person who have seen in lab have any idea of monopolar and bipolar? We have that idea, right? Now, so the person who have seen, is this a monopolar instrument or a bipolar instrument? Monopolar or a bipolar instrument? Bipolar, how many of you are saying bipolar? Bipolar? 2, only 2 of you from here. Monopolar, bipolar. You can take a look. Monopolar, bipolar. How many of you are saying this is a monopolar? And how many of you are say that this will not take the current? Means the current will not transfer from this. All are neutrals. See, this is a monopolar instrument. It's a monopolar instrument. This is, see, lap is difficult, that's why only. All the instrument that you see here, which has this tip, can you see this metal tip? Is all are monopolar instrument. Just remember one thing about monopolar instrument, means the current can pass through this. I'm not going very deep into it, but this much is important, and I'll tell you why. Now, this instrument is, which instrument again? Monopolar. This, monopolar, bipolar. Monopolar, bipolar. It's all metal. Now again, think your answer. Monopolar, bipolar. And how many you say the current should not pass through this? Those who are saying current should not pass through this is correct. Metal, if you give current, surgeon will get shock. Forget about the patient. Metal, can I touch this metal with that bulb and I'll get shock immediately. Metal instrument can't be used for things. Okay? Monopolar, bipolar. Where you will connect? Bipolar, monopolar, if you have seen a cord tree, a wire comes through it, right? You have to have a place to connect that. It should not that any instrument I'll give you will put a current on that. No. Nothing. No tower. See? No tower. Can you see? Is the tower there? Is the tower there? Now again you will ask, sir, this has a tower. No, it doesn't have. This is a metal. It's for cleaning. Because, can I disassemble this? No. When the instrument cannot get disassembled, you have a hole for cleaning it. Every instrument will have. Make sure it's a reusable instrument. If it is not reusable instrument, you can see, no wire, nothing. This is from COVIDian. Nothing is there. If you want to dismantle, break it. Okay with this one? Again, bipolar. Confused. This is bipolar. Forget about what it does. It's not your headache. It's a headache of a surgeon. But if he asks you to give a bipolar, this should be bipolar. Again, if you ask me, can it be dismantled? No. Because current is passing through it and you can't put it in the water. This is bipolar. Please check this. Mono means 1 or 2? 1. So, 1 metal. Just simply, I'm breaking it in very easy way. Bi means 2. Can you see 2 metals with the insulator in between? This is bipolar. Please don't get confused. This is bipolar. Monopolar. Correct with this one? Okay with this one? Okay. Now, again coming to very important thing that a mistake is done. Okay. It was like a 10-15 years back. Heard of Lady Harding Medical College in Delhi? Lady Harding Medical College, a known medical college in Delhi, okay? It's a government, I don't know if it's a central or not, it's a government medical college. So a surgeon was appointed there. He started doing lap surgery. It's 10 years back. I'm telling you a story about, not 10 years, I think it's 20 years back. More than that, because I have been working for 8 years now. So 10 years back, a surgeon joins there. He started doing surgeries. Every week, he was having a case of bowel injury. And he was very sure that he was not making mistakes. Okay with this one? He was not making mistakes. So when he have to find out, see, making a bowel injury is very big thing, okay? And within a span of a month, he have made that too. Normally, if you are a good surgeon, in like 5 years, 10 years time, you'll make 1 or 2 bowel injury. And that person has gone into bowel injury twice in a month time. The whole committee was made, the department was involved, the medical college was involved, and you trust me, it was not his fault. It was the fault of OD technician or a nurse. What happened? Let me explain. Huh? Now see, what was happening was, surgery was done. Now, what did I tell you? What is this and what is this? This is insulation, right? And this is insert. Now, what happened was, a surgeon was using something like this instrument. This. Is this a monopolar or bipolar? First, one or two? You don't have an insulation here. I'm sorry to say that you don't have an insulation here. It's just single. Now monopolar or bipolar? Monopolar. Just single. You don't have an insulation here. It's a single thing. Okay with this one? Now, this instrument is only and only used for cautery or electrosurgery. Only used for electrosurgery. Current passes through this. So, when the surgery was over, this was handed over to the nurse to clean it up. Again, this can't get dismantled, okay? So, only like cleaning the tip and all should be done, and it should be put in the side X. I'll show you how it is done. Now, I must say that nurse was nurse must be favorite of the surgeons, so he handed over to her. She find a clot here on the tip, this way. What did she do? She didn't close it, she didn't use the any other instrument. She used a knife to clean it. Okay with that? When the cleaning with the knife was done, what did I tell you? This black part was gone. Now, like this. It was exposed like this. Can you see that? Did you see that black part going off? This is insulation, okay? It can peel off. Same thing can happen to this instrument also. It can peel off. And obviously if you take a knife, it will go. But that metal will go? No. Am I correct? Now, how this instrument works, you have to understand. What happens? You have seen that cautery, like everyone has raised their hand. What happens? That current will come here. The aim is that current should pass here. So wherever I touch, I should get cut, or whatever I want, the surgeon should get that. That's a normal phenomenon. Now what happened? Why the current is not coming to you, or not here, not here, not here? Because you have a insulation. Like you have heard now, when you're touching the electricity, you should have that rubber chappal with you. Why is that? So that the current will not pass and you will not get the shock. Same thing happens here. These are insulator or non-conductor, plastic, rubber. Now when she clean this with a knife, a dent was something like this, dent was done. So now what is exposed? Metal is exposed, correct? So electricity here should transfer here, but it was coming from here also. Again, in a laparoscopic, when you do it, you'll just seeing this. I'll show you in some time. You'll just be seeing this area. No one will be bothered here. So wherever it was touching, now I'm doing here. Now see here. I'm touching here. This instrument should walk here. But if anything comes here, will I get a shock? Why did I get that shock? Because that insulation was disturbed. So it's your job to clean it properly. Don't play with this insulation. Okay, I'll show you that. I think I have that. This was the one. It's taken from the same medical. Can you see this? This is insulation failure, what we call. It was damaged up to this level. Now, the current should come here, but you can imagine how it's working. So don't make this mistake. You have to understand the cleaning of your instrument. You should be responsible. You should be responsible. Clear on this one? Clear on the instrument part? Right? So how you do it? You remove everything Remove everything and then clean it. And then clean it. Put it in the Sidex. Now let us learn how to clean this. So what you'll do, you'll open. Whichever instrument get open, you'll keep this inside. There are some instruments which should not be put inside the Sidex, like bipolar instrument, this heavy instrument like Ligashio harmonic, if you have heard of it. Instrument that runs on electricity. Like, same thing this all, telescope and all. The cables, will you immerse the cable in the Sidex water? No, we can't do that. Okay with that? So that should not be used that way, right? But all the instrument, this instrument, the needle holders, the trocar, cannula, all you open up, clean it up with a tap water. Take all the things out, like the blood, the tissues and everything, and then you put it on the Sidex, right? So this what you see here, this is what we call as a Sidex. Light nahi aa raha. This is what we call as a Sidex tray, right? See the length, the whole instrument can get inside, but don't directly put it. You do it after what? After cleaning it, right? Then, do anyone know about the composition of Sidex? Heard of Sidex? Like you must have been knowing about Sidex. What it is? Sidex is a brand name. What it is? It's glutaraldehyde. Right? So if you see here, this is your Sidex. Can you see here? Activated glutaraldehyde solution. It's not that this alone will work, okay? You have something called as an activator. This one. Can you see the activator? So what you do after cleaning your instrument, you pour this inside, and with this, you keep this activator inside. What is the color of Sidex? Green. But this will not be green. When you put this, you mix with the activator, then it will turn into green and then it's ready to use. Okay with this one? As soon as you do that, please give the labeling. Like what was the date? What was the date? And then you put it here on, we have a perforated instrument handler here, this way. You put it here. Not inside, you have to put it here. Like, because as soon as the surgery is, like you want to arrange the table, you can take it out and put it on the table so that all the Sidex will drop back. The Sidex will not come with the instrument. Right? So this is called as a simple Sidex. The duration is like you keep it for 14 days or 10 surgeries. Whichever comes first. Whichever comes first. 14 days or 10 surgeries. For how long? That's another thing. How long the instrument should be deep inside the Sidex. If you are just using normal Sidex, 8 hours is the minimum time. 8 hours is the minimum time. It's not that your surgeon is doing 2 surgery at a time and he can say that give me instrument, like same instrument you're using for both the surgery. He can't ask you for this instrument instantly. You can't do that. It will not be done. Because minimum time to disinfect or sterilize this instrument is, if you're using a Sidex, is 8 hours. But again, the company comes with something important that is called as a rapid Sidex. Rapid Sidex. Here the contact time, if you are able to give 30 minutes is enough. So it will kill all the viruses, all the bacteria, fungi, everything. This will not take care of the spores in 30 minutes. If you are dealing with the spore, it will not take care of it. But yes, bacteria, virus, and all the disinfectant, sterilization, everything will be done within what we call as a 30 minutes. But for this, minimum 2 hours is required. Minimum means it's very good to keep it for 8 hours, but to get up the level of that also, it's there. If you see here if you go through this here, like after this, you can see here, it has written here, 20, like 8 hours, 4 hours, 14 days and all. They will give you the instruction. Okay with this one? Now, the question comes, so what to do with this ligashore or the telescope or the bike cables and all? How to disinfect it, how to sterilize it, right? That is important. For that, clear with this one? Like this is important, okay? Labeling will be done by the technician and the nurses staff. Surgeon will never look at this. They'll have no, they don't bother about it. It's your job to arrange the table. It's your job to take the instrument in and out, clean it in a proper way and do it there. Okay with this one? Clear with the side X-ray? This is side X-ray. The good thing if you have a metal one, but nowadays you can get a plastic kind of thing also, right? After that comes formalin chamber. Formalin chamber are used for when you want to deal with the instrument, like with the cables and all. Like this is ligashore setup instrument. Sorry, ligashore setup instrument. So can you put it inside the water or the liquid? No. So what you do, you have this transparent formalin chamber that comes with formalin tablets. This is formalin tablets. If you open it, it will be like a tablet, right? And how you do it, see? How you do it, you take out the tablets, you wrap it in the gauze piece and put it all over, right? After that, you put the instrument, after cleaning it, now again, how to clean all this instrument or the cables? Use spirit, alcohol. You wipe the tip with that, because if you wash with it, next day you will be fired. This kind of instrument costs you around 35,000-40,000 rupees. Just one instrument. Normally it's called as a disposable, but in any corporate hospital they will be using at least for 5 to 10 times. Right? So you can't use water to clean this, but again blood will be here also, right? The clots and the fibrous, the tissue will be here also. So how to clean it? Dip that gauze into spirit, clean the tip and all the things, and just put it inside this one, like this. Put the telescope inside, put the cables inside, put the hysteroscope inside, cystoscope inside. The thing you don't want to, like you feel it will get damaged by the fluid or the water, you will be putting it inside. Now, how you will be know that your formalin tablet has been over? When you open that gauze, when you are cleaning it, that powder, that tablet will be become a powder. So when that powder is there, you replace the formalin tablets. That should be replaced. If a good corporate hospital is there, they will always go for what we call as a ETO2 or the plasma chamber sterilization. But it's really costly and maintenance is really difficult. So a lot of people will be dealing with this only. Side X-ray and the what we call as a formalin chambers. Okay with this one, clear with the sterilization thing, how we need to do it. Now we'll quickly go through the instrument. Right? So we understand how the instruments are used, right? Now, the first instrument that goes inside the human body, when the surgery is done, starting is always going to be a atraumatic grasper. Atraumatic grasper. You have 3 types of grasper. It's atraumatic grasper, traumatic grasper and semi-traumatic grasper. Why you need to know is because if you have scrub at your surgeon side, you will be asked to give that. Right? You will be need to give them that. Right? So again, if you see here, this is your atraumatic grasper. Atraumatic grasper. Learn this, okay? This is important. Because, how many types of grasper did I tell you? 3 types. Again, important to be understood. A simple, again, a story back here also, why I take a lot of effort to teach, let it be surgeon, gynec or OT technician of an instrument. Last March, there was a candidate from Thalassery, Kerala. She was too senior to me. She was like 45, 48 years of age. She came for the training with us, okay. So I asked ma'am, she was a nun sister. I asked ma'am, why did you are learning this late? I'm not complaining, but I need to know why you were like. So she said she had done her graduation from Bangalore Medical College, okay. Bangalore Medical College, and at that time, like 20 years back, her HOD was doing lap surgeries. At that time, that was very new. But what happened was, she was a resident. Her HOD and other surgeons were doing surgery. It was an infertility case patient. She asked her assistant to introduce a grasper inside. This was to be introduced, but unknowingly, she introduced something called as traumatic grasper. This one, can you see here? Can you see the difference here? This is like, I can easily hold my finger with this. Nothing is happening. Can I do that? Can anyone want to try this? No, you can't. It will bleed like anything. See? See the tip. See the tip. This instrument was introduced inside. Unknowingly, that madam hold the bowel with this. Will it get perforated? Definitely it will. And ma'am was very anxious. She said, leave it, leave it. They did their part, they came out. The patient returned after 5 days with abdominal distension and peritonitis. So they knew what had happened. The bowel was punctured because of this. Within 10 days, the whole body was infected. Heard of some sepsis? Patient went into sepsis. Within 2 weeks, the lower limb was gone. Within 3 weeks, the patient died. So after that, she was never able to take the laparoscopy. It took her too long to understand this. Why I am saying this? See. So can you differentiate this traumatic and traumatic grasper now? Sunil, khol ke dikhao. Which is this? Which is this? A good one or bad one? Bad one. Which is this? Good one. Can you differentiate now? Can you, if I do this, can you say it? Which is which? All the laparoscopic instrument looks same. You have to understand that. It differs from the tip. You need to know just a small mistake and the patient can lose their life. And it's a real story, okay? I'm not making it up. That's why I take this class really seriously when I deal with surgeon and gynec more. But my concern is, rather than teaching surgeon, it's you who will be passing the instrument to the surgeons. If he doesn't have a habit of checking it twice, he can be into deep trouble. He can be into deep, deep trouble because of a simple mistake. Now we can argue, aapne grasper hi kaha tha. You have to be specified. The first instrument that goes inside the human body is a traumatic grasper. It has fenestration, it has low serration, can hold instrument like the organs like tube, intestine, bladder, nothing will happen. See, I'm holding my check with this, nothing will happen. Can I do with the same? I don't. Got my point? This is really important. Right? So just I'll complete this grasper part and we'll go for a tea break, okay? You got my point, why it is important? You got this point, right? So now, what are the use of all the three graspers? Atraumatic grasper are the grasper which you use to mobilize things like the bowels, tube, the organ that you don't want to harm. Semi-traumatic grasper are the grasper when you hold something with that, it should come out. The instrument, when it holds the organ, that organ should come out. The traumatic grasper, the bad one, is mainly for when you are like struggling to take the things out, like the gallbladder, appendix and all. When the gallbladder is out, the appendix is out, you want to bring it out of the body, you want to pull it out, this time you will be using this. Right? All these are important. So let us see this one by one. This is atraumatic grasper. So isn't it the same thing that I show you? This one. So now the telescope is inside. So again, just going back, the telescope has gone inside. Now you are seeing the organs. What is this? What is this? Bowel, right? This is bowel. It's a hernia surgery, a male patient. If you see here, this is the hernia defect actually, right? This is the bowel. Now, can you touch with any sharp instrument to this? That was a mistake that was made at that time. And like now also people repeat that, okay? But I think I got to hear that madam's story, and because that was that bad, right? But see here, can you move this bowel with other instrument? Is it possible? Don't ever think of it. If a surgeon is doing, you can scold them. कि क्या कर रहे हो सर आप? Directly. You can't use that instrument. It's bowel. This is the lower pelvic area, okay? This what you see here, this is bladder from inside. Urinary bladder. Right? This one. It can be only touched by the atraumatic or another term is Babcock's forceps. Babcock's forceps. See, this way you can touch it. This all are dangerous areas. See, this is bladder you are touching is. You don't dare with any other instrument. Right? This is the way it is done. If you see here, this area will have appendix and all. But this is the job of a traumatic grasper. After that, comes your semi-traumatic grasper, with which you can like hold the things and take the things out. This is your semi-traumatic grasper. It has a slightly bigger serration. This is gallbladder. The thing that you see here is liver. These are the bowel again. So it's a gallbladder surgery going on. So you hold this, right? You hold this. So now, when you hold this gallbladder with semi-traumatic grasper, that organ should come out. So see, for the grip, if you hold with it, the atraumatic, you will keep on sleeping. The surgery will get difficult and difficult. Right? This way. So again, atraumatic, this is your semi-traumatic. This way. And this is the other instrument that you are using with. Right? This is your semi-traumatic grasper. Then comes a traumatic one. The bigger version of the traumatic is this one. This one. See here. Can you see the jaw? That was 5 mm, this is 10 mm, but the same, right? You can compare with. You can compare. Can you see here? Same tip. But the only difference is it's 10 mm, it's 5 mm. Right? So you see here. So this is the way you use it. You use it to take the things out of the body. See, can you see the same traumatic? Now, when you use a traumatic grasper, will it come out? No, you will struggle. The surgeon struggles, the staff struggles. So you will hold it like this and bring it out. If it is bigger, you have to take whole thing out. This is gallbladder coming out. Okay with this one? Right? The same thing can happen for here. This is for gallbladder. This is what? Anyone? What is this organ? Appendix. Right? So see here. You can easily take this out. Because if you use other instrument, it will not come out. Another thing. One thing you need to understand. 5 mm, 10 mm port we discussed, right? Nothing comes out through 5 mm port. You should always use 10 mm port to take the specimen out of the body. It's always through the 10 mm. Like this thing also you have to keep in mind. When you learn it, it will be easier for you. Right? So we're done with grasper. We'll take a 5-minute break and again deal with other instrument that is left. Like that will hardly take half an hour because sterilization part, giving you knowledge of how it opens and closes was more important for me. Right? So we'll just have a 5-minute break and we'll come back. Start again. Right? Okay. So one thing just need to understand, a small thing is like, again, I don't want you to get forget. So what was the size of the cannula? Different size of the cannula, please. 15. 4 size, right? Or 7 and then 3 are like You don't have to deal with. But now you are posted at a hospital. Gynec inform you in the morning, the team has been informed that a case of laparoscopic sterilization is there. Sterilization means tubal ligation. So she said she will be using fallopian applicator. What was the size of fallopian applicator? 7 mm. Remember, right? So do you have no 7 mm cannula? You don't have a 7 mm cannula, and the surgery is planned, the patient is been admitted. What is the option? 5 mm? Instrument will not go inside. 10 mm? Yes, can be, but the difficult part is gas will keep on leaking. So can there be any alternative? Can we do something on that? Any idea? I can't hear you. The answer is coming, but I can't hear you. Louder? Reducer. Right? There's something called as 10 to 7 mm, 10 to 5 mm reducer. This one. 10 to 7 mm, 10 to 5 mm reducer. Is that okay? Now, for surgery like gallbladder, one 10 mm port is mandatory. One 10 mm port is for always for telescope, okay? You have to understand that. Another, if 10 mm port is put, can you go through this instrument? No, what will happen? Gas will leak. Gas will keep on leaking. So what you need reducer. You need a reducer. So normally there are 2 to 3 type of reducer. 10 to 5, 10 to 7 and 5 to 3. For you it's important to be known like 10 to 7 and 10 to 5. This is 10 to 5. So this instrument will easily go inside this, and now you can use it. So the term reducer means reducing the 10 mm port to 5 mm port. 10 to 5. 10 to 5 reducer. You have reduced the 10 mm port to 5 mm port. Is that okay? Clear with this one? Then comes 10 to 7 mm. This one. This is 10 to 7 mm. Right? So if you see here, right? See, this is ring applicator, fallope ring applicator. You hold it, you go here, and you can easily do the surgery. Again, one common mistake that surgeons and gynecologists made, and assistant has to correct it. Just see this. So where is this? This is inside the abdomen. Now we have a concept, right? How laparoscopy is working. This is inside the abdomen. This is outside. Now, for any reason, if this comes out, is it right or wrong? Is it correct or incorrect? Why? Because reducer is left there. What does that reducer has done? It has opened the valve. Okay, see, when this reducer go inside, what it is going? It's opening the valve and going. So when the valve get opens, what will leak? Gas will leak. So instrument should go inside and come out together. It should go inside and it should come out together. It should not be like going like this and coming alone. The whole abdomen will collapse within 5 seconds. The whole abdomen will get collapsed within 5 seconds if you do this. Immediately you have to remove this. Okay, so go inside, come out together. This way, going inside and coming out. Okay with this reducer? Now, because of same reason, you have something called as a short mountain reducer. Short mountain reducer means it's again 10 to 7 or 10 to 5 mm reducer, but that length will not reach up to here. I'll show you that also. That length will not reach up to here. So that when that instrument is moved in and out, you don't bother to remove it. Just have to hang that. That's it. Nothing to be done extra. Okay with this? Okay with the concept of the reducer? Right? So we'll move forward with other instrument, that is scissors. In laparoscopic surgery, you have different type of scissor. Right? Simple, and I don't think it's an interesting question. What's the job of a scissor to be done? What does a scissor do? Cut. Simple. In the laparoscopic also it's the same thing. So you can see here, you have different type of scissor. See? This is what we call as a curved scissor. Then you have a straight scissor. Then you have a micro scissor. Micro scissor. See, can you see which is bigger? Can you see the jaw, which is bigger? This is bigger, this is smaller. So micro means when you want to do a very fine dissection. So the surgeon can ask you for the micro scissor, give me curved scissor. A very interesting scissor in laparoscopic is a hook scissor. That is not present in open surgery, this one. This is what we call as a hook scissor. Now, again a simple question. When you cut, how do you cut? When you are cutting, do you cut the proximal part first or the distal part first? Means you cut the nearer part first or the farther part first? You always cut the nearer. Everyone does that. This is the only scissor that cuts the distal part first. One thing. Another thing that you need to understand is, to cut anything, for cutting anything, you need to have something called as engagement. Engagement. Engagement is important. What does the meaning of engagement is? If I want to cut this tissue, my jaw of the scissor should be, like this tissue should be inside the jaw. Am I correct? So that when I press it, it will cut this way. If I'm taking like the big thing, this big tissue, will it cut? No, because the jaws is not getting engaged. Every scissor has the same. Let it be a home scissor or whatever you are using it. But for this scissor, you don't need it. Sunil, sorry. This scissor, you don't need it. What I'm trying to say, I'll show you. है क्या? Thread है? कुछ? हाँ? है तो दे दो अगर used है तो. Right, so I'll show you why I'm saying this. Suppose if you have something hanging there and you just need to cut the thing, you don't need the engagement. It will cut on its own. It will cut on its own. Right? कुछ भी tube? Okay. इसी को पकड़ो. Right? So what I'm trying to say is, see, you see this thread here, pakro. Now, if I want to cut this with another scissor, like a normal scissor, curved or anything, it will not cut. It will not engage only this way. It will keep, can you see it's slipping out? It will keep on slipping out this way. But when you cut with this hook scissor, what happens is it will get engaged and then it will just chop it out. Means this hook scissor doesn't need a support inside. Only different thing that you will be finding from an open instrument. In open surgery, you don't have anything called as a hook scissor. Because in open surgery, what you are doing, if you want to cut something, you'll hold with your hand, your assistant will cut it for you. But there you don't have an assistant. In laparoscopic, there's no term called as assistant. It's a camera person. Either it's you, your both hand, or a camera person. So what happens is, in that way, you can engage and you can do the surgery. You can use these scissors. And it has other advantage. For you, just see the tip and remember this is hook scissor. Next time someone asks for you, or when you are graduated and when you go for the hospital posting and all, you should identify the instrument. Right? Again, is it a monopolar or a bipolar? Monopolar. So energy can pass through this. So this can be again used for cutting with the current. Laparoscopic has that advantage. In open surgery, what happens? Only you have a pencil or some instrument to be used as a electric instrument. But here, everything can be used like that. Okay with this one? Clear with this one, right? So let us see how it works, how you cut it. So here, see, this is the anterior abdominal wall, and here is the, like, previously the patient must have gone for another surgeries, and what is happening? The whole omentum has been adhered to this abdominal wall. Now, to do this thing, you just have to keep on cutting. Again, a question can come, why not we are using an energy source? Why we are not using an energy source? Because when you are doing when your surgeon is doing a dissection, what happens? If bowel and all are there, the current can jump to the bowel. So it's said that if bowel adhesions are there, don't use energy source. Go for cold dissection, we called, cutting with the scissor itself. Same thing, this is cyst inside the patient, ovarian cyst. So what you are doing, this is the ovarian tissue, you are cutting with the scissor. I'm just showing you how it is used. Same instrument can be used for different things. This is what we call as a cutting by the scissor for an ovarian cyst. This is the ovarian capsule that it is being cut, right? That was scissor. Then comes, we have seen artery forceps in open surgery. You have seen that artery forceps. Same thing in laparoscopic is called as a Maryland. This is Maryland. Just see the tip, okay? Why I'm showing you so carefully to watch is this, because if I do this, you are not going to identify it. Am I correct? Which is which we don't know. All the things looks normal. How do you identify the instrument? By looking at the tip. If you are smart enough, you can always say okay, this is needle holder. Without looking it also, we can say it. This is needle holder. Because it's different. But grasper, scissor, Maryland, they all have same build. Same company is giving you, this is your hook scissor, this is your Maryland. So, but if I ask my assistant also to tell, he can't say which is which. No one can say. I can also not say. Because I'm not seeing the tip. That's why tip is important. So what is this? This is Maryland. Right? This is Maryland. Just see the jaw. Doesn't it look like an artery forceps from the open surgery? It's the same thing. Right? The artery forceps. So what is the jaw? When a surgeon will ask you for this instrument, when they want to do a dissection, when they want to strip the things, they want to peel off the things, they want to tie a suture, they will ask for Maryland. When they want to create a window, when you are doing a gallbladder, this is a mandatory instrument that should be on the OT table. Right? We always, when we conduct the classes for nurses and thing, we tease them for different surgery, how the things are arranged. For ovarian cyst, what are the instruments that should be there? What technique your surgeon is using to get inside the abdomen? Is the varus needle mandatory to be put in there? What type of cannula he is preferring? What is the first instrument your surgeon will ask when you are doing hysterectomy, when you are doing cystectomy, when you are doing gallbladder surgery? It's different for everything. So, in 90% of the time, Maryland is important. Maryland should be on the OT table. Okay with this one? This is called as simple Maryland. Again, for advanced one, you can have right angle. Udhar kya hoga? So you can see we are confused here also. So imagine when the lights are off, in laparoscopic surgery, if you have observed, you don't have a top light. Okay? That makes the things more confusing for the assistant. See, this is right angled. Simple. It doesn't mean it's not a rocket thing and anything, but see here, just the tip is different. This is right angled. This is normal. This is right angled. So for sharp dissection, If they are doing a surgery when you need a proper angulation, they will ask you for right angled Maryland. Okay, another type of Maryland. So one instrument type was monopolar. What was the another type? I can't hear you. Bipolar. In bipolar, one of the major instruments, see, bipolar has a very less number of instruments. You just remember 2 instruments. Maryland, grasper. Bipolar, Maryland. Can you see, isn't the jaw same? Isn't the jaw same? फिर से गया. Maryland. नहीं, ये नहीं, दूसरा. Just compare this. Isn't the jaw same? So this is bipolar Maryland. What is the difference? This yellow thing, that is insulatio, and the back. So 3 type of Maryland. Simple normal curve Maryland, right angled Maryland, and a bipolar Maryland. Any time the surgeon says bipolar, 80% time he is asking for bipolar Maryland. Same way in grasper also hai kya? You can have a, see again, 2 pole with an insulation. This is bipolar instrument, and the tip, check the tip. Another way to identify, you will always have this yellow color on a bipolar, okay? That's the insulation, so that the current doesn't hit the patient, right? So see, can you see here? Can you see which instrument was this? Atraumatic grasper, right? Atraumatic grasper. This was atraumatic grasper. So, grasper and the Maryland. There are only 2 instruments for bipolar. So, arranging the table, you should just have any one of this. Any one of this. You can either have this bipolar Maryland or bipolar grasper. Another famous name for this instrument is Roby's dissector. So, you should not get confused. Oh, sir, didn't told me about Roby's dissector. It's the same instrument. Bipolar Maryland is also called by the name Roby's dissector also. Don't get confused. When bleeding happens, when the surgery is taking place, bleeding happens. This is the instrument that gives you hemostat, that controls the bleeding. This is the instrument. So, isn't it mandatory to be on the table? Yes, you can't miss out. Let it be a small surgery or very advanced surgery. This is the rescue for the surgeons. When some mistake is there, or cutting is not, like the tissue has been cut and started bleeding. Savior instrument. Okay, bipolar Maryland or grasper also. So you see here, as I told, this was a young lady with endometriosis, like unmarried. But if you see here, can you see the instrument? How good dissection it is doing? This is the job of Maryland. No other instrument. Can you do this dissection with a grasper? Grasper tip is very thick. This will not happen. Can you do with the Caesar? No. Again, another surgery, gallbladder surgery. Can you see how the window is being made with this instrument? When your surgeon is asking for a dissector, you have to give a Maryland. Don't get confused. Don't panic. Right? This is the gallbladder. This is the dissection that is happening. So see here, this instrument will go. No other instrument can do this job. Let it be higher, advanced it is. The job of Maryland can be done only by the Maryland. Right? This way. Okay with this one. So Maryland, again, being a monopolar instrument, the current can also pass. But remember, for stopping the bleeding and all, you have to have a concept of bipolar Maryland. For the time being, just remember that. Right? But for dissection and all, always surgeon will ask for the Maryland. Maryland. Clear with the Maryland thing? Right? Then comes aspiration needle. Oh, okay. Aspiration needle are the instrument that are used to aspirate the fluid that is inside the abdomen or any what we call, there are cysts now, ovarian cyst and all are there. So when the ovarian cyst is very big, filled with fluid, you puncture that and take that. Same way, if you want to inject something on the organ like a needle, it helps that. This is what we call as a aspiration needle. So this is ovarian cyst, dermoid actually. So this instrument with the tip. This is what we call as an aspiration needle. See, it went inside, and the other part you'll have a, this is ovary, okay. Other part you'll have a, what we call as suction getting attached to the tip, and whole fluid will be sucked inside. So that the organ will collapse and the dissection will be easier. So when your surgeon or a gynecologist asks for aspiration needle, you have to give them this, the aspiration needle. This is the ovary with the cyst. Right? This is the way it works. Right? So when it can aspirate, definitely it can inject also. Which is this organ? Which is this organ? This is uterus. This is uterus. This, can you see here? This is tube. This is ligaments and all. So what is this? This bulky area, like the thing that has come up. What do you think? What is this? What is this? What is this? Fibroid. This is fibroid, right? So normally when a surgeon or gynec start with the fibroid surgery, a lot of bleeding happens. Like you heard of the injection called vasopressin? What it is? Vasodilator or a vasoconstrictor? Constrictor? Right? So if you give it to the patient, what will happen? The bleeding will increase or decrease? It will decrease, okay? It will constrict the blood vessels, but can raise the pulse and BP like anything. So you have to be careful with that, right? So see here, and see when it is injected, just see this area, okay? It will get blanched. Can you see that white happening? The whole area is, the blood supply is being constricted there. That's why. So when you do the surgery, the bleeding will not happen. Right? To inject the vasopressin, again aspiration needle is needed, and surgeon will ask you for that. So again, for surgery like myomectomy, you have to have aspiration needle on your table. Got my point? For gallbladder surgery, you don't need it. For hysterectomy and all, you don't need it. But for some surgery, you need it. Then comes spatula. Then comes spatula. So this is your spatula. Again, monopolar, bipolar. Monopolar. This instrument is only used to transfer the current. Means, what happened is like, if you want to, heard of a term endometriosis? Nowadays it's spreading like anything. Like all the case of infertility happening to, like in this year time, like 2-3 years, is majorly because of endometriosis. So one of the instrument that can take care of that is spatula. It burns the endometriosis. Mainly, if it is in the area where you can take it out, it will be taken out. But suppose endometriosis, like, do you understand what is endometriosis? How many of you know? What do you think is an endometriosis? Normally, your uterus shaded endometrium, correct? When the endometrium is inside the uterus, it's fine. Nothing is going to happen. The uterus is fine, everything is okay. But when that endometrium come out of the uterus and it start going to the ovary, the bowel, then the problem starts. Okay with that? And that is one of the major challenging surgery and one of the major problem of primary infertility nowadays. So wherever we can dissect and take that out, it's done. But suppose that endometriosis is on the ovary. Can you take the ovary out? Like for a unmarried girl or thing? No, you can't do that. Can you take the endometriosis out of the bowel? Sometimes it is very painful. Sometimes it is very, like you can't do anything. You have to take it out. Do bowel resection. But if you're not able to take it out, what you do? You take a spatula and you burn it like this. So here, this is ovary, okay? This is an ovary that was being infected by endometriosis. So whatever was, we take it out, but to make it sure that it doesn't happen, we burn this. So current was used and this spatula was used to burn this. So whatever you see is being burned is endometriotic tissue inside the ovary. The endometriotic tissue should only be inside the uterus. If it is coming out of this, it's abnormal. And you have to deal with it. You have to deal with this. Is it okay? Clear with this? So you can't do with any other instrument. Proper instrument is there. We call this as a spatula. Spatula. Okay with this one? Okay with spatula? Right? This is the way it works for the endometriosis. And the term that what we are doing is called as a fulguration, if you want to add to that. This is called as a fulguration. So if your surgeon is saying, I want to do a fulguration, be ready with a spatula. Right? Then comes needle holder. This one. Needle holder. Right? So you have a curved needle holder and a straight needle holder. So what can be the use of needle holder? To hold the needle and to do the suturing. So if you see here, you have 2-3 kinds of needle holder. Curved, straight, right? And it can be easily identified by its metal composite. Or everything is metal. Forget about the monopolar, bipolar thing. Nothing goes here. Just to do suturing. In lap surgery, suturing is the most difficult part. So this is needed to do suturing and knotting. To tie the knot, to close the uterus. If bleeding is happening, anything is happening there, to take a bite. For that you will be using this needle holders. Right? What type of handle? Axial. Axial handle. Right? Let us see how it works. So if you see here, this is the surgery where fibroid has been taken out of the uterus. So you can't just leave that uterus open, so you have to close this. So when you do this, this is what we call as holding the needle with the needle holder. And you just start taking the bites this way. Right? So see, this is the whole uterus being cut, mama being taken out, and then suturing for the uterus being done. Same way, you can see it for, this is the surgery, this is a female pelvis. What is missing? What is missing from female pelvic? Uterus is not there. So hysterectomy has been done, the uterus has come out through the vaginal route. Now you are closing the vaginal vault. So what is needed? Needle is needed with holding with the needle holder. You should know which type of, like, I think today you have a class for the suture and all. Which suture is being used? What is the needle that your surgeon is preferring to take a bite? Right? Is it a curved needle, straight needle, J-shaped needle? Called as endoscopy needle? Right? Which type of needle holder your surgeon is preferring? How to take the needle out from and close the abdomen? Right? At the end of the class, I'll share you our channel link where we discuss instrument. We keep on discussing laparoscopic instrument and all that. You can follow us on that and you can see that how the needle is introduced inside the abdomen. How the needle is taken out of the abdomen. How you hold it. Right? I don't expect you to do it, but you should have an idea. When your surgeon asks, give me this needle, you should not be confused. Vicryl, PDS, silk, absorbable, non-absorbable. I think you had a class of that. You have to understand that and apply to the surgical field. Right? So this was about needle holder. Then, tritome has one. Then comes a good interesting instrument called as PCOD needle. Heard of PCOD? Polycystic ovarian disease? Right? So normally it should be taken care by the medicine and the diet control. But for some reason, the patient is not able to conceive. For a long time, the couples are dragging and they are not able to conceive. You have to go for an ovarian drilling. That is done by this instrument called as PCOD needle or tritome. Like if it is being used by gynec, they will tell you PCOD needle. If it is used by a surgeon, they will tell you a tritome, T-R-I-T-O-M-E. And how it works, the thumb goes here and middle finger and the index finger goes here and a needle comes out. Okay? And then again, is it a monopolar or a bipolar? Monopolar. So current comes here, the needle comes out and you will drill the ovary for the PCOD disease. You'll drill the ovaries. Right? This is your PCOD. Nowadays, surgeons are also using, because of its sharp tip, they are also using it for cutting and all. Right? So if you see here, this is the way you use this PCOD needle. Uterus, this is the dye. So this patient was for infertility treatment. So we do a dye test to see that the tubes are patent or not. The tubes were patent, but the ovaries were too bulky. The ovaries were too bulky, and what happened? What did we do? We just punctured it. See, the term polycystic. Poly means too many cysts, okay? So you just puncture it so that the reserve of that ovarian reserve will come out and the ovary will start breathing in, that ovarian tissue will have a space to breathe actually. Same way it happens, see? You just puncture it. Can you see the needle? You go, you press it and you puncture with the current. If you do it directly, what will happen? Bleeding will happen. This is the way you drill the ovary for the treatment of PCOD. This way. You just keep on drilling it. And there's a rule of how to do it, but you don't need it that. But you should understand when the surgeon is asking for PCOD needle, this is the instrument. You should not be blank. You should not be blank. Right? This is your PCOD needle. Again, and as I told you, this can be also be a very good instrument to cut. See, remember one thing, you don't feel, this is not being cut by the instrument, okay? How it is being cut? Cut by the current. Can you see that burning thing here? Smoke will come out, see? See, this is being burned by electricity. And then you do the dissection. So this PCOD or tritome is used for multiple purposes. You can use for the dissection, you can use for the drilling, you can cut the tissue with it. Right? This is for tritome. After that, you have a myoma screw. Like myoma screw, again simply, the name itself is a myoma screw, so it will be used for, so this is myoma screw. Can you see the screw here, and this is pointed. It is very dangerous instrument, okay? Why? Because you're going to decide if it slip and hit anywhere, puncture will happen and it is not good for the patient. So this is myoma again. So you are using a current to cut it. When it is cut, you'll take it inside. You'll take the screw inside. Right? You'll take the screw inside. Right? This is the use of myoma screw. Just see the instrument. You need to understand this. Just check the instrument. Myoma screw. Right? So it will help you to move the uterus up and down. See, this myoma has been taken out. Now you want to take this inside again. So again, which organ is this? Uterus. Right? Uterus. Right? So this is the use of myoma screw to deal in the surgery of fibroid. After that, hook. One of the major instruments that is used for electrosurgery to cut anything inside. The best instrument. Nowadays the people have started using tritome, but just see this. This is hook. It's a L-shaped instrument with a tip and a heel. With a tip and a heel. If you're not checking the insulation of any other instrument, it's totally okay. But don't miss to check the insulation of this. This was a major blunder done in, like it was done in Delhi. This was the instrument that was used to cut the tissue and then the mishappening happened. This is hook. Electrosurgical instrument, monopolar instrument used to cut. Used to cut. Right? So if you see here, this way. cut anything. This is the wall that is being cut, like for the myomectomy surgery. See? This is the vault. Like when you are opening the cavity, like you are opening the uterus, the vaginal end, you are cutting this side. Okay? This is the one. Can you see? Can you see the smoke? It can be dangerous like anything, okay? If it touches here and there, it's really, really risky instrument. Like I'll try to complete it fast and I'll try to show you 2 or 3 complications that it can give you, okay? This way. Again, just repeat with which type of handle? Rod handle, if you remember. Right? So when you use a rod handle, you don't have a good control. The control that I have on this instrument is different than this. It moves on its own. It's so flickering actually, or what we call as overshooting. This is under control. Right? This is hook. So see, this is the uterus that is being cut. Okay, this is the uterus that is being cut to open the myoma. Means whatever dissection you want to start up, you want to cut the things, you are doing with the hook. So again, if this insulation is not there, if there's an insulation failure, the surgeon can land up into trouble. Right? So you have to take care of the same. Right? So same way after the surgery is done, you want to cut any tissue, you'll be using the hook to cut it. But be careful in this kind of area. Right? If you are helping the surgeons, make sure that mistakes is not being there. Right? This is the one. Okay with this one? Clear with this one? Then comes stone holding forceps or forceps for the retrieving the cut tissue out. This one. It's called as a spoon forceps or a stone holding forceps. Spoon forceps or a stone holding forceps. When it used, when you're doing a gallbladder surgery, the stone is like spill out of the gallbladder. Now I want to pick that stone. I can't leave that stone inside the abdomen, right? So when I can't leave that instrument, I'll be using this kind of instrument to get the stone out of it. Right? Or any other tissue also out of it. So it's something like this way. Can you see this yellow thing? This is the spill stone. This one. So see, when the lever happens, this. Can you see here? This all are the stone that was dropped because the gallbladder got punctured. So at that time, your surgeon's doctor will ask you for stone holding or spoon forceps. So you have to come and you have to give them this instrument. This is stone holding forceps. Okay with this one? Clear with this one? Just try to remember the tip, okay? This is important. This way. So, any other instrument can't do this, okay? It will crust or the stone will, like the grip will not be there and it will be difficult to take it out. So, this is stone holding forceps. After that, you have a clip applicator. This you have to understand. This is clip applicator. You have seen this instrument, known about it. This instrument is used when surgeons need to ligate the artery, duct or any other structure. If you're any of your colleague or senior are walking in the instrument, walking in the hospital, this is one of the instruments they should know very throughout to know the importance of this instrument. What they do, they are the one who load this instrument and give it to the surgeons. We call it as a clip applicator. Must to be on the table when the surgeon is performing gallbladder surgery. Okay, okay. So you have to know this instrument. Again, can you differentiate the size of this instrument? What should be the size? Size of this instrument, 5 or 10? 10. So again, for gallbladder surgery, every time you have a 210 mm port. Why I'm saying this? Because when you're preparing a table for that, you have to have a 210 mm port at your OT table. Then only you can start with the surgery. Because this instrument only goes with 10 mm port. It will not go with 5 mm. That's why this is important. Now, when you're talking about clip, you have to say this. Like today, we had a class on IV cannulation. Remember the codings? Green is for? What is the gauze? Green. Green gauze. You have to revise, must. Green gauze. What is that green color cannulation? What is the size of that cannula? 18. Yellow? Yellow? So it is smaller or bigger? Slightly opposite here, okay? Here, the clip applicators come in form of, the term is LT, it's a ligation thing. If you are using a yellow cartridge or a clip applicator, clips, that means the vessels that surgeon is going to ligate is a bigger one. Can you say LT 300, 400, 300, 200 and 100? Here the codings should. So normally every time you will be using green one, what we call as a LT 100. But sometime you have to use LT 400. The only thing is, like, you need to understand the means what the surgeon is asking to you. They will not say give me green or yellow. Like they will tell you LT 300, 400, so you can have a pick of this if you want. Just take and it will be with you. This is important. Then nowadays another thing comes, the same thing like a clip applicator, everything is same, only the tip is slightly different. You call it as a hemoclip. And the clip applicator is hemoclip applicator. The thing is, if you see here, this, what is written here? What is this? Titanium. So it's a metal. Now, if surgeons don't want to use that, they will use this. So can you see here, what is this? This is silicone or a plastic-like thing. Nowadays, this is being preferred than the clip, the titanium clip. Right? So you need to understand of this hemoclip applicator also, this one. So it comes in again, medium, large, XL. Normally, this purple will be used. Right? You need to know how to load this or load the clip applicator. Right? Then you have small instrument like suture passer, right, to close the port and all, or suction and all. Suture passer. Right? These all are the small instrument that you need to do. This is what we call as a suction and irrigation. This one. Suction irrigation. This will be for the suction tubing. This will be for irrigation tubing. Right? This is called as a clock type suction. Means if you see here, when you go forward, this is irrigation. This is closed. This is suction. So suction tube comes here. Irrigation tubes comes here. And then again, if you can ask me, same suction that is used for the open surgery? Yes. The same suction that is used for the open surgery, that is used by the anesthesia person or by anyone. Same thing. Suction, neutral, irrigation. This is clock type. Size is 5 mm. Same thing comes in a 10 mm also. Suction, again, suction, irrigation, but this is what we call as a trumpet type. Trumpet type. So suction tubes comes here, irrigation comes here. Now, bigger one, 10 mm, where you have a lot of blood fill up. You want to do a fast suction, you will be using this. Okay, so this is, see how it is done. This is your suction and irrigation. So if you see this, the uterus was taken out, this is the below part, and here, you see here, this is suction being done. See how clean it become. Again, if you want to wash it, want to wash the area, see for the bleeders and all, you'll be doing. See, this is the way the water comes in. We call it as a irrigation. Irrigation. Okay with this one, right? This is your suction and irrigation. Right? After that, suture passer दिखा दो, खत्म करें. This is what we call as a suture passer. Means this is for port closing instrument you can call. It's used to close the port, put the mesh and all. If a surgeon is asking for port closing instrument after the surgery, you have to give them this. They have different parts also, but you have to give them this. This is port closer needle, right? So after this, my assistant gave me this. This was the short mountain reducer that I was discussing with you previously, short mountain reducer, right? Now small, like 1, 2 instruments are still left. I just want to show you one important instrument which is mainly dealt by the nurses actually. Manipulator, manipulator. Uterine manipulator, right? Like I'll just show you the instrument so you are oriented to it. Detail will be discussed some other time. This is the instrument. This is called as uterine manipulator, mainly done for total laparoscopic hysterectomy. You use this instrument, right? This goes inside the uterus and the manipulation, the movement of the uterus happens. And the surgeon will have easy. In maximum time, the thing which, like the person controlling this are assistant only. They are not doctors. So you need to learn this instrument very well. Like after the class, if anyone is interested to learn this, you can come here and discuss this with me. I'll guide you with that, right? But individually, it's tough instrument to deal with. Learning is difficult, so you have to understand this instrument well. But when someone shows you, don't get confused. This is uterine manipulator called by the name of Mangala uterine manipulator. It was built by an Indian surgeon. Mangala, दूसरा तो नहीं होगा. Mangala manipulator. There are some simple also, like if you see here, this kind of, which is called as a Indian type. This is a Forgesi uterine manipulator, right? Then you have a Marva uterine manipulator. This is Marva. The only difference that you see here, this has a tenaculum, this doesn't have a tenaculum. Okay with this one? Right? Any confusion on the instrument part? You are okay with this one? Like this is important, okay? If you are putting a lot of effort traveling through and coming to learn this, the instrument should get inside you. Like you should, when you see it, you should not get confused on monopolar and bipolar at least, and then the identifying the instrument. Now, last thing I just want to ask you if you are interested, you want to see inside how everything looks laparoscopically? You want to go through that video? How many of you are interested with that? You want to see the inside of the video? Like, so let us see that, and then let me scare you also. If you don't use your hook properly, what can happen, okay? So first you want to see the complication or the organs video? Organs video? Okay. कितना टाइम है? 6 बजे. SSB सर को कॉल करना होगा. It's okay. So we'll follow the whole abdomen in a very good way, right? We'll start from one corner and we'll come out and see everything, okay? Hope your anatomy are good. If any question, you can see. So what you are seeing here, what can be this? It's bowel. This is bowel, okay? So you start from the bowel, like it's called a diagnostic laparoscopic. So this is bowel. You follow this area. This, can you see this highlighted area? This is called, you follow this and you land up to appendix. This is appendix. This is appendix. Okay? Again, what is this? What is this? Uterus. This is uterus. Right? It's moving up and down. This whole area is bladder. The whole area is bladder. And these are tubes, ligaments and all. And then, what is this? How many of you know how to put a Foley's? It's a Foley's catheter. Seeing from inside. It's inside the urinary bladder. This is from inside. Again, the uterus is being moved. How it is being moved? Why it's moving up and down? What is controlling that? Manipulator from outside, from the vagina side. Right? This one. See? Uterine manipulator. Then it lifted up. It will lift up. This is your small fibroid coming out. This white thing that you see inside is your ovaries, right? Ovaries. Then this is POD area where the collections are there, pouch of Douglas we call. These are tubes connected with these are tubes with the fimbria here, right? Tubes with the fimbria, ovaries. Can you see the blood collected here? This is called as a POD, pouch of Douglas, or cul-de-sac area. Cul-de-sac area, this one. Right? After that, again coming to the right side of the pelvic, this area that we are hitting is a ureter. One of the nightmare for the gynecologist if they hit it. Right? Then this is your internal iliac artery, this one, just below. Ureter being lifted and internal iliac artery. This is a fimbria, ovary, the white one. This is IP, infundibulopelvic ligament that is being held. This is your external iliac artery. Again, getting into much detail, this is your ovarian ligament, this is ovary, this is tube, this is round ligament. It's mainly for a surgeon point of view, but this is called as an upper pedicle of the uterus. This is your upper pedicle of the uterus. Again, coming from the right side of the pelvic, see this is psoas muscle. Sacrum promontory, you don't need this detail, but again internal iliac artery with the ureter. With the ureter, this is the uterine artery, and here will be your uterosacral vessels. Ligaments. Then there's something called as a median umbilical ligament, medial umbilical ligament, and lateral umbilical ligament. It's good to know if you are preparing for the exam, this ligament and all are the favorite question of the examiner actually. This area is called as a deep ring or round ligament area for the female point of view. For male, it's vast difference. Right? This way. After that, you again come through the same thing, but in a different patient. Lateral, medial, median, and medial. Again, and again lateral. So, actually you have two medial umbilical ligament, one median umbilical ligament, right? This is now upper abdomen. Whatever you are seeing was a lower abdomen. This is upper abdomen. So this is spleen. This is the diaphragm area, the heart. Can you see the pulsation here? That's heart pulsating. Right? Again, this is the ribs and all, and the liver and all. We'll come back again. Right? Again, spleen, stomach, liver. This is falciform ligament. This is your gallbladder. This is your duodenum and all. This is transverse colon. This will again be your ascending colon, this area. Right? Now we turn here, you see an organ coming here. This will be your ovary with the cyst. This is bulky uterus. This is tubes. And the uterus has been pushed away like this one. The ovaries has come up. This is your sigmoid colon, descending colon, and then the whole thing is omentum. So this is how the laparoscopic look inside. And it's all transfer on your monitor. Right? So this is how it looks like. And at least, I don't say you have to be expert on it, but when you know it, when you have attended a workshop, you have to identify certain things. Like you should not be blank when someone asks you about telescope, laparoscopic instrument. Let it be in your student ways only. Doesn't matter. Right? Last thing, you want to see how helpful this happens, this diagnosed laparoscopy can do. I'll just show you a small example. What is this? What do you think this is there? It was a fish bone that punctured the stomach and came out. So if you're doing a diagnostic laparoscopic, it can be this helpful. So don't scare, you can have your dinner as a fish, but it can be this dangerous. This is fish bone that has punctured the stomach and come out. If diagnostic laparoscopic, like if your surgeon is doing laparoscopic, it can be easily diagnosed. The patient will have a good time. Right? But sometimes it can be dangerous like anything like we discuss a lot about insulation failure, right? This is insulation failure. See, the current is passing here, but see the spark. This is insulation failure. This is lever being burned. This is insulation failure. Right? Same way, this is your insulation failure. See, the dissection is happening here, but can you see the burning here? This is insulation failure. And trust me, it is only done by the assistant. The mistake of the, no surgeon will wash the instrument, right? No surgeon will arrange the OT table. But who will be blamed? Surgeons. Right? So you have to be good with this. Same thing, the last one. And then we are done for the day. If any question, you can definitely ask me. This one, see, a hook is being used. Just a minute. Like a hook is being used. If a laparoscopic is good also, it can be bad also. This is area of external iliac artery. Can you, like which instrument is this? We can see like this is a hook. Right? This is hook. Right? If it is a good thing, it can be a bad thing. And how bad? How bad? This bad. This bad. I don't know what happened to the patient. It's not my video. But it can be this bad. Did you get the point? It's not that the laparoscopic is like if it is in a wrong hand, the assistants are not good, no idea of how the things work, can really be bad. Within 3 seconds, see the whole abdomen is filled with the blood. Just the instrument that we discussed, it's a hook. Right? But can be this bad. Right? So I just want, like if you are interested in minimal access surgery, learned in a proper way. Like attend the things. Doubt, I'll be reachable to you all. Like I don't know, like I was talking to the faculty here. They were like, you are from all part of the India and all, and from the Bangalore, everywhere. But you can always be in touch with us. And in like we have a training session. You want to come for that? You are most welcome. Right? So any doubt, any confusion? So you liked it? You understand? I know it was lengthier after lunch. I hope I don't make you all sleep, but needed, okay. When you are attending things, you need to, it should not be like people come, they advertise themselves and they go. No. It should be like my students should learn. But because what we are dealing with after you graduate, you will be dealing with real lives, okay. Take a note from a surgeon, I'm saying you that we are dealing with human beings. It's very tough. You have seen, like, did you see that last video? Survival would have been very difficult at that time. It's very tough. The first person that will panic will be a surgeon, second will be the assistant. Right? So you all are a part of the system. Whenever I take classes for the surgeon and gynec, I always do that. Sir, ma'am, your assistant should be really good. They should know things. You should not be blank. Okay with this one? Right? So I just want to say, share last thing. We have a channel where we keep on putting all the videos for that. We are like into the growing phase. We'll keep on it. You can scan this and subscribe to the channels. Right? It's in the name of our mentor. Like RK is Dr. Rini Kuruvilla. I am Dr. Rahul Pandey on the behalf of her, taking care of it so that you can be reachable. I'll be leaving my cards here. Right? I'll be leaving my cards here so that you can contact us if you are interested in learning laparoscopic in a better way. Like it was the time limit given to me was really small. We take a whole day to just discuss the instrument only. At the end I was slightly fast, but I'll keep on uploading things there. You can contact us through that, and I'll be leaving a card. You can have a number there also. Right? So I'll just open this. It can be there already. Sorry. Right? So thank you for the attention. It was a good session. Hope it was benefited for you. Thank you. Thank you.
Thank you, sir, for sharing your knowledge and making our event a success. And we are grateful for your valuable contribution. I request Padmashri ma'am to hand over a token of love and
Good evening to one and all present here. It is a privilege and great joy for me to extend a vote of thanks to all those who have contributed in one or the other way to make this conference a great success. I take this opportunity to thank the management for being the driving force behind this whole process. I extend my sincere thanks to our respected Chairman, Dr. Ganapati P. Sir, and Vice Chairman, Dr. Anita G. Bhatt ma'am. I would like to thank our Principal, Mrs. Pratijna Suhasini ma'am, and Vice Principal, Geeta Lakshmi ma'am, for their support and guidance. I extend my sincere thanks to today's resource persons, Mr. G. Prasad, Mr. Sahiruddin S.K., Mr. Pradesh C.B., and Dr. Rahul Pandey for sharing their knowledge. I also thank Administrative Officer, Mr. Dharmaraj K., Manager Ramesh Nayak, PRO Vijay Sir, and Anil Sir. Thank you. I also thank our teaching and non-teaching staff for their immense support. I thank Mangala caterers for the delicious food and sound system, Sharon's Lights and Sounds, Vamanjur. Last but not least, I would like to thank all the participants for their involvement. Thank you.
Every ending is a sign that new things are coming your ways. As we have come to the end of Mangala College of Allied Health Sciences in association with KAHPA organizes AHSCON 2K24. Thank you everyone. Have a great day.